just to kind of set the stage. And then I'm going to highlight 3 projects that are going on scientifically and collaboratively in different places on how we can advance what we do for individuals who are dealing with any of these conditions. So, what is our current understanding? I have summarized this to 1 slide, but it is a little bit of a compare and contrast. And I do this just to get people thinking a little bit about what we all share in common, regardless of which alphabet soup title you carry, whether it's MOGAD or NMO or any other condition that has an acronym, and then where there are differences in how our communities can learn from each other by comparing and contrasting. So if you think about both of these conditions, most people, if not all, 95+% of people get to the title because they've had a symptom and they have a blood test that identifies an antibody. So in the setting of neuromyelitis optica, it's the aquaporin 4 antibody, sometimes called AQP4 IgG or NMO IgG. In anti-MOG associated disorder, it's the anti-MOG antibody. The parts of the nervous system affected are very similar. Predominantly vision by affecting the optic nerve, the connection from the eyeball to the brain, or motor, sensory, bowel, bladder symptoms because of the spinal cord, and then both of them can, with different frequencies, affect the brain or brainstem in different ways. Aquaporin 4 neuromyelitis optica is overwhelmingly an adult condition. There are very few cases before the age of 12 in the world. Whereas anti-MOG associated disorder is kind of the inverse. We see a huge number of cases in pediatric populations, but it's an equal opportunity offender and continues to cause issues all the way through adulthood. And then one of the critical differences that as an immunologist has kept me up at nights trying to understand is if you're an individual who has an event and you're found to have the aquaporin 4 antibody, you're likely going to have that antibody for life, and you're likely going to have risk of something happening for life without treatments or interventions. But with the anti-MOG associated disorder antibody, there are individuals who lose that antibody over time. And those individuals have a very different existence, and we'll talk about that. So there are immunologic differences, even though they're both antibody-mediated diseases, and even though they both affect the same organs within the body. So where are we relative to treatments? And if I were giving this talk even just 5 years ago, I wouldn't even need a whole slide. I could just say it. And we've come a long way in the last 5 to 10 years. So for individuals who are having acute symptoms, there's lots of things we do. Many in the room may have experienced 1 or more of these: high doses of steroids, plasmapheresis, intravenous immunoglobulin. And the goal during an acute attack, as I try to teach our residents, is put the fire out. And once you get the fire out, let's go on to what we need to do to recover. And then we move on to prevention. We move on to making sure the next event doesn't occur. And in neuromyelitis optica, we have multiple FDA-approved medications, something that frankly was surprising to see with relative to the speed with which it came. From the time the autoantibody was identified to having multiple FDA-approved medications was under 15 years, which sounds like a long time, but in drug development for essentially a new disease to be identified, defined, and then drugs on the market is highly unusual. And not just 1 or 2, but now 4 different drugs that are FDA approved. There's still some use of off-label medications, rituximab or mycophenolate. That's been steadily declining over time as we learn both the safety and the profound efficacy of these FDA-approved medications. And then in anti-MOG associated disorder, it's followed a similar fashion as neuromyelitis optica. We used a lot of medications, interventions off-label, but we now have 1 clinical trial that's completed and will go to the FDA for review for satralizumab. And there is another trial which is completed. And who wants to pronounce this one at the bottom? You get bonus coffee if you can do it on the first try. Rosanilixizumab. Come on, 5 times fast, everybody. So, and that trial is going to be completing. And so we may get to a point where we have multiple FDA-approved therapies for relapse prevention and anti-MOG associated disorder. And this went even faster than neuromyelitis optica because of the work that had happened in neuromyelitis optica. The trial designs were better understood, the medications were better understood, the conversations with the FDA had already happened, and so the ability to go from understanding a disease which really was evolving between 2015 and 2020 to having drugs going to the FDA in 2026, 2027, it cut the time in half. Understanding a condition and building a patient community accelerates investment in trials and research. One of the reasons, there are 7,000 rare disorders that are identified in the world based on a variety of things. Here are 2 of the 7,000. There are lots of individuals who, rightfully so, are seeking partnerships and investments from the NIH, from universities, from our partners in industry, and there are limited resources to go around. How did neuromyelitis optica, how did MOGAD get to a place where it's advancing faster than other rare diseases? It was investing in science, and particularly investing in things like this. As our partners in industry and the NIH see organized communities, the barrier to understanding the conditions and developing treatments go down. So the investments get made into groups that have vibrant, engaged communities such as this. So I applaud all of you for being part of that process. So I'm going to shift gears now to actually what I was asked to speak about, which is the state of the science. And I'm going to give you 3 very different studies, insights into studies that are going on, just to show you the diversity of work. And again, this is just a small snapshot. So the first study is going to be a MOGAD-focused study. I'm going to do 1 study focused on MOGAD, 1 study focused on neuromyelitis optica, and then 1 study that will have implications for everybody. So what about predicting relapses in MOGAD? There are lots of groups around the world trying to work on this, but I am very loyal to UT Southwestern. My colleague, Linda Wynn, I think is doing the best job of everybody on this. Lots of people doing a great job, but Linda's doing wonderfully. She had a NIH-awarded K Award, meaning she was presented a project around this rare disease, got funding from the NIH to support the notion of, can we predict who's going to have a relapse or not? So remember I said anti-MOGAD associated disorder antibodies is different than aquaporin-4. There are some people where the antibody goes away. So about 2/3 of people, once you have a first event, you test positive for the antibody is going to stay with you. But there's about 1/3 where it goes away. And if you look at the individuals where the antibody goes away, their risk of a relapse over 5 years is really small. They probably don't need long-term immunotherapy. We don't need to prescribe something for those individuals, or at least that's the current thinking for most. For individuals who remain positive for the antibody, it is not destiny that another event is going to occur. And yet we're faced with this challenge of who do we treat, when do we treat, with what do we treat, and for how long? Is it possible to go on a therapy for 1, 2, 3 years and then come off the therapy, something we would not do in aquaporin-4 positive NMO? So I get asked by patients all the time with neuromyelitis optica, Dr. Greenberg, it's been 5 years since my last relapse. Can I come off, fill in the blank, whatever medication they're on? And I say, I'm so happy for you. No, because that risk of relapse persists. It's a very different conversation with our patients with MOGAD. Dr. Greenberg, I've been stable for 3 years. Can I come off my medication? I said, I'm so happy for you. I don't know. And it's an unnerving position to be in for everyone. So what Linda is doing is a prospective study of willing participants who've been diagnosed with anti-MOG-associated disorder, who are not just willing to share their data, but roll up the sleeve and share blood samples in specific ways so that she can do a 360-degree analysis of the immune system and the analysis of the antibodies being produced and how they're being produced to come up with a scoring system, not just based on epidemiologic studies, but based on biology. Who actually needs to be treated? Because there are some people I'm treating who may not need it, and there are some people not being treated who do. And we really want to get people into the right camp. So this is an example of science going on to try and personalize medicine, to try and make sure it's not a one-size-fits-all, but we really risk stratify individuals in an appropriate way. So that's a glimpse of one study, one example of a study happening in anti-MOG-associated disorder. Let's shift gears and talk about neuromyelitis optica. And for this, I'll highlight a study that has just opened up at UT Southwestern and will be opening up very shortly with our partners in Boston at the Mass General and Brigham program. And this is around something called CAR T therapy. Has anybody here heard of CAR T therapy? A couple hands. And if you've heard of it, what was the context? What CAR T is out there right now for certain conditions? One of these patient days. So you got a preview. What it's out there for right now is certain cancers, certain oncologies. And the idea in CAR T, and I'll show a picture, is we take an individual and we take out some of their immune cells. So these are your own cells, and then we genetically program those cells to go on the attack against a specific target. It turns out, I'm going to put this in the context of cancer. Let's say somebody has a leukemia or a lymphoma, and they have cancer cells throughout their body. I can give drugs like rituximab to try and kill those cells, but the drugs don't get everywhere in the body where those cancer cells are hiding. So they're very effective. Rituximab changed the world of lymphoma. It made the diagnosis not just survivable but curable for many patients, but not all. And for those who didn't get a benefit, a lot of it was because the drug couldn't get everywhere. And several groups recognized, you know, T cells, a person's own immune system, can get everywhere in the body. It is the ultimate surveillance for cancers or infections. What if we could teach the T cells to just go after lymphoma cells? So you take a person's T cells out and you program them to go after lymphoma cells, and then you give a person back their own immune system. And what happened in cancer was literally nothing short of miraculous. There were patients who had failed multiple rounds of chemotherapy, cancer cells throughout their body, literally were not going to make it through that year, who underwent this therapy and walked out of the hospital cancer-free and have survived now without further therapy. Really incredible. So the idea was, could we take those immune cells and use it to fight off autoimmunity? So instead of going after cancer cells, why not just go after the confused immune system? And indeed, colleagues in the world of lupus have been doing this now for several years. And what you're looking at is each of these lines represent a patient, and this is the severity of their lupus. So there are lots of people with severe lupus, and these are individuals whose kidneys are failing, who have lots of rashes and joint pains, and they're on lots of immunosuppression. Lots of things have been tried, and yet despite those medications, they're still quite ill. They get CAR T therapy, and over very rapidly and then in a sustained fashion, their lupus goes into remission, and they can come off all their immunosuppression. And in fact, right now, the rates are at least 75% of lupus patients who've undergone CAR T therapy, 3, 4, 5 years later on no therapy, don't have signs of active lupus. And so in the setting of autoimmune disease, this has been effective. So the question is, could this work in neuromyelitis optica? And that laid the ground for this phase 1 trial of CAR T therapy in neuromyelitis optica. So this trial is going to enroll 10 individuals. It's a phase 1 trial who are seropositive for the aquaporin 4 antibody. They will remain on background immunotherapy. There are reasons scientifically this was limited to ravulizumab and satralizumab. You actually need B cells present for the CAR T to work. And so it wasn't to be exclusive instead of inebilizumab. It just has to do with the science. And then what we're looking at is, can we take someone who's positive for the antibody and get rid of the antibody? If we kill off those B cells completely in a person, will they lose that aquaporin 4 antibody and start to behave like an anti-MOGAD associated disorder patient whose antibody goes away and has such a low risk of relapse? And so it's both looking at safety and efficacy for getting rid of the antibody. So why are we using CAR T here? The technology's ready now. We don't have to develop a new drug or a new science. We can use it. We have insights from other antibody-mediated disorders. There's a marker, that antibody, that we know if you lose it, you're likely not going to have relapses. And this is a one-time intervention. You show up, you give your cells, you come back a couple weeks later, you get your cells. It's a little more complicated than that. There's other regimens involved, but I'm just simplifying. And then you get followed over time. And if you lose your antibody in the trial, we will say you can come off your background immunotherapy and just be monitored very, very closely over many years. But the idea is, can we actually get rid of the disease and or give people long periods of time where they don't need to be on immunosuppression? Imagine somebody coming and saying, I'm interested in starting a family and I don't want to be on these medications while starting a family. Could I have a 5-year period of time where I don't have to take medication and be safe? So there are lots of ways to use this intervention that we're excited about. So now we'll get to the last topic. So there was one bit of science for anti-MOGAD associated disorder, one bit of science relative to neuromyelitis optica, and now I'm going to shift to one that we've been chasing now literally for 20 years around restoration, more than 20 years, around restoration of function. So we have an ongoing, it's getting much closer to the end, phase 1 trial for using stem cells to repair the spinal cord in individuals who've had inflammation of the spinal cord, myelitis. Why has it taken so long? So when I was in medical school, which is a long time ago, people were talking about stem cell therapy for everything. And it was going to cure the world, this, that, and the other. And then a couple years later, it's still coming. A couple years later, it's still coming. I'm like, I'm not sure I'm believing this anymore because we keep talking about it and I don't see them yet. And so why does it take so long? There are a lot of barriers to getting this right. So there are lots of clinics. You can go online. You can book your ticket to, I think my favorite right now is in Panama. I could be wrong. And go get, quote, stem cell therapy. It is not stem cell therapy the way you think it is. When we talk about stem cell therapy, at least when we do in our clinic, mainly what people are envisioning is we introduce a cell that repairs damage that has been done. So in order to do that, you need to control what cells we're injecting. The way I like to say it over the years is, you don't want a tooth in your spinal cord. There is no reason to grow a liver in your spinal cord. And the power of stem cells is they can differentiate into anything, but you want to control the differentiation. That took a long time. How do you get it where you need it? Turns out if I infuse stem cells into your vein, 99% of them get cleared by the liver and the lung in just the first pass in your circulation. So I can give you billions of stem cells. They're never going to get to the spinal cord when we put them into the vein. And then it's like an organ transplant if we're putting these cells in. How do we make sure we don't elicit an immune response and you reject the cells? So each of these barriers were addressed in different ways. So the group that's provided the cells to us spent many years working on the differentiation to make sure that the cells that were being used only turned into what are called glial-restricted precursor cells, cells that would regrow myelin within the spinal cord. They then tested it in a bunch of preclinical studies, and I put this up just to have pretty pictures. It's like modern art. But what you're looking at is cells being put into animals, being put into culture, and them growing new myelin. These rings here are myelin being grown by the cells, and this is actually a slice of brain from a mouse. And you can genetically get rid of the myelin in the mouse because you should see some blue there. But if you inject the cells, all of a sudden they start making myelin throughout the tracts of the brain. So lots of animal work to show that the cells that we were using would turn into the cells we want. But the FDA kept saying, prove that it doesn't turn into a tooth or a liver. So you had to do this over and over and over again over years to prove the negative, that they never saw a tooth or they never saw a tumor, or that they never saw cells that shouldn't be there. So after proving all of that, we then got to implantation. How do we get the cells into the spinal cord where we want them? I mentioned we can't put them through an IV. Even if we put them in the spinal fluid, they don't really go exactly where we want them. So the decision was made to surgically put them directly into the spinal cord. So we tried this. This is some of the early research I did in different studies trying to show that we could take a syringe, I know it sounds weird, and inject the spinal cord with cells. And it turns out that every time you breathe and every time your heart beats, your spinal cord moves. And we have to inject very slowly or the cells break apart. So over a couple minutes of trying to inject, the target was moving, and no matter how steady my hands are, no matter how much I avoid coffee, no matter what I do, it's not that steady. And so a neurosurgeon out of Emory had to create a device, Nick Boulos, that could, in the operating room, attach to the patient and move with the spinal cord. So every time the spinal cord moves, every time you take a breath, every time your heart beats, the tip of the needle stays exactly where it is over the course of that infusion, and that had to get FDA approval. So had to prove, because it's a medical device, so you couldn't just go into the cells. You now had to do a whole separate FDA submission around the technique. So this is why it's taken a long time. So I am going to show one picture out of the operating room. It is not gory, so if anyone is sensitive at all, you can look away and ask your table partner, how bad is it? But this is the one, and what you're seeing here, and this is from our first patient. This is the device. We call it a floating Derrick cannula, and it attaches to the patient, and we can do the infusion very safely, and we've now shown over and over again, we get the cells exactly where we want them. And this phase 1 trial has been ongoing. This is designed to show safety. We've enrolled multiple cohorts now, and the FDA gave us clearance this past year to actually expand. So we had originally started with individuals who were completely non-ambulatory because we wanted to prove safety of the procedure, that we weren't going to make things worse. We're now approved to move into individuals who are ambulatory. We have not had any cell-related serious adverse events. We haven't seen any cysts, any tumors, any growths, anything along those lines. And people have been tolerating the medication quite well. And we are working with partners now to see, could we do this in the optic nerve? We need a whole different implantation technique to do it into the optic nerve. So we're working with oculoplastic surgeons and people who work on the optic nerve all the time in terms of how to get this done. And we have partners that Mike Levy works with in Boston doing some of this work on the optic nerve. So, conclusions. We're making a lot of progress. We have a lot of options now. The way I look at the drugs today is they're great, they work, we can manage them. Do we want to do better? Yes. And we're doing it in several ways. We're trying to personalize how we treat. We're trying to come up with therapies that could give you durable remission without staying on immunosuppression, and we're working on ways to try and restore function that's been lost from prior attacks. And we've definitely come a long way. I want to acknowledge partners as listed here, sRNA and PHA for today. Bristol-Myers Squibb is providing us with the CAR T therapy for the phase 1 trial. Q Therapeutics is giving us the stem cells for the stem cell trials, and most importantly, our patient partners. Literally, as I said at the beginning, could not do this without you and all the volunteers in the studies. The pictures you see here from just a small part of the UT Southwestern team I want to give a shout out to, who are involved or leading the studies I've mentioned. Tricia Plum, Manny, Salah, Taylor, and Paula, all part of the team, whether it's around the stem cell study or the CAR T study. So with that, I know I'm a few minutes over, but I'm happy to take any questions if we have time. Thank you so much. And Corey, yeah.
Progress for those that are NMO and MOG negative, double seronegative.
So progress for individuals who have had the symptoms of these conditions, but they keep testing negative in their blood test because they just want to be difficult. And so first, we're coming up with a counseling program on Get With It, turn positive for something, please. So we're doing a couple things. So one is diagnostic criteria. So this sounds very academic in terms of groups of clinicians and scientists and patients sitting around a table trying to figure out what title to give everyone. It actually turns out to be really critical, because when somebody says to me, I'm double seronegative, that can have very different implications depending on how the testing was done, when it was done, and where it was done. And so part of the work we're doing is to give guidance to patients and to clinicians around how to appropriately characterize and to make sure we're all using the same language so we get like-minded patients grouped together. There have been multiple groups now that have published. We have, the group out of Yale has, that there are individuals who test negative for these antibodies, and I've had patients who I've tested for 10 years negative for the antibodies. And if I take their B cells, the cells that make antibodies, and I do this neat trick of science where I can clone the antibody out of the cells. So I can't find the antibody in the blood, but I take the cells responsible for producing them. We find the antibody, we find the cells making the antibody. And we've published on this where the blood test may be negative, but the person actually has it in their system. We're just not detecting it on the test. So some of the work that's being done is in novel diagnostic techniques to see how many individuals who are in double seronegative actually have it. It's just an issue with the assay to pick up the antibody. Because once we have people appropriately characterized, it gets a lot easier to recommend how to treat and how to navigate. Yeah, so where would somebody go to do that test? It is not commercially available in any way. We've only done it on a research fashion. And what we're trying to do is to use that knowledge to actually inform the blood test for the antibody to make it better. I think it'll be at least a couple years before we could have it at anything that would be outward facing. One of the things that happens, not to geek out, but I think it's important, in the world of medicine, in the world of laboratory medicine, is every test that you get has to be in what's called a CLIA certified lab, meaning you have to have a reproducible test with adequate controls, and it has to be rigorously developed, tested, and validated. There are lots of tests we do in the research lab that's great for research, not ready for prime time because you have the chance of false positives, false negatives, and we don't want patients or clinicians making decisions on something that hasn't been validated yet. So it has its own path to validation.
My B cells were 0 for years because I was on rituximab, so now I'm off of rituximab on Actemra, and so they are coming back. So how high do they need to be able to have, like, if that does become available or to become part of a study like that?
The CAR T?
No, the B cell testing, like.
Oh, the B cell testing. It's a good question. Once your B cells are detectable in the blood, we can do that type of testing. It doesn't take many.
My question is about the CAR T therapy. With women, we have children and we breastfeed, we pass on our immune system. So is there any information on if it's safe? Is it after going through the therapy, is it safe to have children? Does it transfer? Stuff like that.
Yeah, great question. So the fascinating thing about CAR T is it's your own immune cells. The cells don't pass on in breast milk or anything along those lines, and they don't pass on to the infant. Your immune cells don't go over. And the really neat thing about this is the CAR T cells expand and then they disappear. And so one of the safety protocols in all CAR T trials is to check a person's blood month after month after month to show when have the cells disappeared, and they do. So it's actually a really attractive therapy for individuals looking to start a family because you can take all of your exposure and all of your risk, and there is risk to CAR T. So I want to be extremely clear here. The reason this is a phase 1 is this is not a free lunch. There are risks, and the consent form is really, really, really long as we go through all the risks. But if tolerated and it goes well, it's a one-shot exposure, and then you don't carry the risks on from there.
All right.
You're never the only one.
Okay.
And that's the point of all of these, but yes.
Okay, cool. With MOG, I have had it where I will relapse and then my serum levels will go to like 1 in 1,000, but then between relapses, it'll go down to 0 or very, very minimal, like 1/40 or something. I can't remember what it was. But in that case, is there a way to predict at a certain point that I will be out of having any more relapses in the future with MOG?
Yeah, it's a great question. And the answer is we think so, but it's going to need more work in terms of using a blood test to predict when that risk of relapse goes away. I will also say, as I talk to patients and even clinicians, we're just wrapping up a week-long meeting in Charlotte called the CMSC, the Consortium of Multiple Sclerosis Centers. And it's a national meeting where neurologists who treat individuals with multiple sclerosis, neuromyelitis optica, MOGAD-related conditions all come together for education and science talks. And we ran sessions dedicated to NMO and MOGAD to try and increase awareness and understanding. One of the biggest topics that was discussed in one of the sessions was on the selection of test for the MOGAD antibody. The test is very different in different labs. It is run very differently in different labs. And I can send the same blood to 2 labs, one's negative, one's positive. And so part of the discussion that's going on is which test should be used in different situations. And so one of the discussions to have, because when I hear people saying I'm going for positive negative, sometimes when I pull the results, it went to 2 labs as somebody went up and went down. And it wasn't that they actually went down, it's 1 month they got one test and the other month they got another. So I always recommend a conversation to make sure when you get your lab reports that you see it's going to the same lab over time. You don't want a lab hop because you can't compare results across labs. And then the assays that are used can give different results. So it's a complicated answer, but to your point, we will get to a place where we can take an individual's own profile, whether it's the antibody or something else, and give you a much better guidance on when are you at risk for relapse, are you at risk for relapse, do you need to stay on medication? That's the goal.
Thank you.
And I'm happy to keep taking questions until Corey shoots me, so.
Okay, my question is about the modeling around the cell. You showed the slide where it showed where it regenerated, but did you also find in studies that the patient response and motor skills improved also?
Yeah, so great question. In the pictures I showed, those patients were all mice and they did great. Turns out I am the best mouse physician around. I can cure mice all day long. I've also killed a few, so it comes and goes. So to your point though, on the human side, the phase 1 trial is still going on, so we have not publicly released efficacy data, and we made this decision as a group very early on because we didn't want to false advertise on one story or not and make it a media thing versus a science thing, just being transparent. What I will tell you is in the cohorts we have studied, there have been individuals where we don't see an appreciable clinical benefit, and there have been some where we have seen a change in function. And so we stayed it like that until we complete the study and we'll show all the results. Yep.
We maybe do one more question before I kick Ben off the stage. Anyone else? Oh, Jody, hold on. I'll bring you the mic. Travis? Do you have a question?
I'll give him my fun one.
Oh, yeah.
Fun one. All right, here we go.
I'm one of those stubborn double seronegative people,
Okay.
and I blame that on testing done after I started Rituxan.
Yes. Yep.
The fun part is, last 2.5, 3 years, I have progressively gotten worse.
Okay.
Walking, dexterity, everything just sucks. Have you seen a lot of progressive cases, but no change in my MRI, no significant change at all in my MRIs?
Yeah, so thank you for sharing that, and I'm sorry you're going through it. I will say, in general, the answer is no, we do not see progression in neuromyelitis optica or anti-MOG associated disorder, and I'll watch Tanuja's face in the back, who's going to be speaking, to see if you disagree. But I find it to be extremely rare to the point that there are debates as to whether or not it happens in those conditions. Now, what I want to separate out is individuals with any damage to the nervous system can have a decline in function over time independent of new attacks or new immune-mediated damage. So I'll have patients who've had spinal cord events who come in and they say, I'm doing worse, and 6 months later they're doing worse. And we dig really deep and we find another explanation for why function is worsening. So it is always a flag to get a comprehensive assessment to make sure there aren't other explanations, because we would say that is so unusual in anti-MOG associated disorder or neuromyelitis optica that there's either a different diagnosis or a different explanation for the progression, and both may be true. There are exceptions to that statement. So there have been a couple of my colleagues internationally who I trust, who are extremely good, smarter than I am, who have confirmed to me that they have a patient or 2 patients out of thousands where they felt like there was progression going on. So I'm not saying it's impossible, but it's highly unusual.
Yay.
All right?
What other tests would you be doing for somebody to
That-
explore future, additional injury?
Yeah, that's a long list depending on the specifics. I wish I could give you a short answer to that. Great. Thank you all so
Thank
much.
you.
Appreciate it.
All right, well, that was a tough act to follow, Ben, so thanks for that. You made my life very complicated, but I want to introduce myself. My name is Tanuja Chitnis, and I am a neurologist. I'm a professor of neurology at Harvard Medical School, and I also work at now what's called Mass General Brigham. So this is a conglomeration of the Massachusetts General Hospital and the Brigham Women's Hospital. As my kids like to say, MGH is called the man's greatest hospital, and Brigham and Women's is the best women's hospital. So they got married, and we're all together now. So what I'm going to focus on now for this talk is women's health. So sorry, guys, in the audience, you're wonderful, but we wanted to have a little bit of a shout out to the women and kind of go over some of the questions that are common in women's health in MOGAD and NMOSD. So what I'm going to speak about is who does NMOSD and MOGAD affect? What are the effects of hormones and contraceptives on the disease course? What about pregnancy and how do we manage pregnancy in these disorders? And then what about menopause? What do we know, if anything, and what work needs to be done? So for the first question, there's a little bit of a delay there. Okay. So who does NMO and MOGAD affect? So, you know, we know that NMOSD is a very female-predominant disease. So antibodies are found most often in women. It's about a 9-to-1 ratio, maybe 8, depending on your age and depending on the region of the world that you're in, but it is really female-predominant. There are some men who do get NMOSD and do have aquaportin for antibodies, some men who are seronegative, of course, but you know, by and large, there is a real female predominance. What about MOGAD? So MOGAD tends to be a little bit more equal opportunities. So about a 3-to-1 ratio, so females to male, about a 3-to-1. It also depends on age, and age might be telling us something very important about the pathogenesis or the reasons for the disease. And so in younger patients, I see kids with MOGAD and NMOSD, but in younger patients with MOGAD, they tend to have something called acute disseminated encephalomyelitis, which is essentially a lot of inflammation in the brain. In older teens, optic neuritis is very common. In even older teens, and especially males, we tend to see transverse myelitis. And then in older people in their 20s and 30s, we tend to see both optic nerves and the brain and the spinal cord involved. So, you know, age does play an important role, and hormones, of course, do play an important role in all of this. So why is this important? We know that there's a female prevalence in all autoimmune diseases. So most autoimmune diseases, with very few exceptions, women tend to be affected more than men. And why is that? So we know that estrogen activates immune cells, especially in different ways. So estrogens can activate antibody cells or B cells to produce more antibodies. It causes some of the cells called T cells to be more inflammatory. And it has many effects on the immune system. So when estrogen kicks in, that is when autoimmune diseases tend to start and become more common and more prevalent, and also change in their overall disease course. Also, some of the genes on the X chromosome, so women XX, men XY, double dose of the X chromosome can give you more of these immune-related genes. And so that's another reason why women tend to be a bit more affected with autoimmune diseases, and some of these do come into play. And some of these are important mechanisms and targets for therapies. So what do we know about hormones and contraceptives, and especially, you know, starting in the early phase of you know, if you're in your 20s or so, what do we know about this topic? So we know that hormones and contraceptives do portend a slightly earlier age and onset of NMOSD. We don't have much information about MOGAD or seronegative NMOSD, but there is more work to be done. And I think part of, you know, some of these discussions and reviews is trying to understand what work needs to be done, where are the gaps in our knowledge, and what should we be doing next. Now, where there has been a lot more work done is pregnancy in both of these disorders. And I sort of have come from a world of MS. I spent a lot of time, or do spend a lot of time working in the MS world. And what we know in MS is that the relapse rates, so attack rates, do go down during pregnancy, and somehow pregnancy is somewhat protective. However, in NMOSD, unfortunately, the relapse rates tend to either stay the same or even increase during pregnancy. And so there is a concern that there may be an increase in relapse rates. And also after pregnancy, there is an increase in relapse rates. So we know that, and this is a very important period in which to protect the woman who is now just given birth and to consider restarting treatment. So, years ago, when someone had an autoimmune disease, then doctors would say you should not get pregnant, you should, never consider this, but now we know how to manage it. Now we have much more information in terms of how we can manage these challenges. So after pregnancy, important to consider treatments. Now, the other issues around NMOSD in pregnancy is twofold. So one, there's a slightly higher rate of miscarriage, so that it's not dramatically higher, but it is slightly higher. And so it does need to be managed by someone who is very knowledgeable in pregnancy management, a high-risk OB. There's also a higher rate of something called preeclampsia, which is basically high blood pressure and also a complication that can affect the liver and kidneys and blood cells. And so this rate is also higher in NMOSD. Again, it requires management by a high-risk obstetrician who's very knowledgeable and working with the neurologist and able to monitor and manage this if it does come up. Now, part of the reason why is because the aquaporin 4, so that's the target that the antibodies in NMOSD is attacking, is also expressed on the placenta. So this is where the baby is growing, and so there are antibodies that could attack that area as well. So again, important to consider all of this when managing pregnancy. So what do we do about this? So we know these complications could occur. And in some people, we might think about immunosuppression during pregnancy. In general, if there's a low risk and there's been a successful pregnancy in the past, then we might say, well, let's just monitor and see how things go. In some people who've demonstrated high rates of attacks or challenges with past pregnancies, then we might say, let's try to continue immunotherapy during pregnancy. And there's more and more data that's mounting that is showing that some of these treatments are safe and effective during pregnancy, both for the mother and for the baby. So these are some of the results from registries and studies and what we currently know, and some of the drugs that are used. We should stop many of them before pregnancy. Some of them have a durable effect. So for months and months, you can be immunosuppressed with B-cell therapies. However, some of them can be used potentially during pregnancy. These complement inhibitors have demonstrated in some instances safety during that period. So in terms of attacks during pregnancy, we try to avoid steroids during the first trimester, but after that, it is safer to use steroids. And so that's a possibility if there is an attack that occurs during pregnancy, and also, again, using some of the other C5 inhibitors if needed. We could start those if there are no other options. So after pregnancy, so a lot of women will say, well, I'd like to continue to breastfeed, and this is really my dream and my hope. And so we do know now that some of these antibodies, there's studies showing that it does not get into the breast milk. This is with a drug called Ocrevus or ocrelizumab, which is used in MS. But it also stands to reason that most of these monoclonal antibodies will not get into the breast milk, and so they would be relatively safe. So it might be safe to restart treatments and then be able to breastfeed. So what do we know about MOGAD and pregnancy? So in MOGAD, it kind of follows the same pattern as MS. So relapses tend to decrease during pregnancy, but they do increase again after delivery. So just that after delivery part is very complex, and it always, in all of the diseases, tends to re-increase. Some people with MOGAD who previously had just one attack have been known to develop a second attack after delivery. And again, that's sort of a risk period. All those hormones are shifting. And so some people went from monophasic to multiphasic disease. And again, that risk period after pregnancy. So very important to monitor and be in touch with your neurologist in that period. And also, especially if there are symptoms, consider restarting treatment. So in general, we do also know that there are fewer complications, so we don't see those increased rates of miscarriage or preeclampsia with MOGAD as we did with NMOSD. But there are limited studies, and we also need more data around what the outcomes are for babies and also for long-term management. So in terms of treatments, so in general, we think we can discontinue treatments prior to conception or starting a pregnancy and considering pregnancies. Treating relapses during the first or during the second and third trimesters, not in the first trimester, ideally with steroids. We could consider IVIG throughout, so that's a possibility, and then monitor especially for relapses in that post-delivery period. So that's kind of a summary of what we know now about MOGAD and pregnancy, but again, more work to be done. And thank you for everyone who kind of responds to registries and questions and signs up for studies, because all of this data is very helpful and very important, and it really helps to inform you in the future and really people worldwide. So menopause, so this is another change in life that is very important for women, and there's not a lot of data around menopause. We're starting to get some data in multiple sclerosis. There is a bit more data that's starting to be accumulated in other diseases. What we've seen is that there is no association with menopause and the age at first symptom in NMOSD, and so that's sort of reassuring. Menopause doesn't cause NMOSD, and maybe that change in hormones doesn't really cause the disease to start. We don't know anything about HRT or hormone replacement therapy. So that's, again, work to be done. What is clear, however, is that NMOSD is not a disease that stops after menopause. So even though estrogen, I said, is pro-inflammatory and it kind of revs up the immune system, there is really not an indication that NMOSD slows down after the age of 50 or typically after the age of menopause. So it's a bit unclear why that is and what's happening, but it does mean that people are going to be treated for a long period of time. There doesn't seem to be a time when, right now we can stop treatment safely and say you'll not have any future attacks. So we have to understand long-term immunotherapy. And also the rates of seropositivity do increase after the age of 50. So we've seen persistence of relapses, and really, I think we need to understand this risk management of what drugs and what treatments are the best for the longer term. In MOGAD, we don't know a lot, again, about long-term outcomes, more work to be done, so thank you for responding to questionnaires, surveys, participating in studies at your centers, but all of these questions, aging, effective menopause, HRT, how long to continue treatment, does it all stop and go away maybe in menopause because the immune system revs down because of the estrogen decrease. So we don't know the answer to that, so more work to be done. So I'd just like to share a couple of pictures from our group in Boston. This is us on a boat cruise. This is our research team, and also a lot of doctors who are working on NMOSD, MOGAD, seronegative NMO, and all the other autoimmune diseases. And I'd like to thank the sRNA Foundation, the PHA, for the invitation to speak, and for all of you for your attention. Happy to take questions.
Thank you, Dr. Chitnis. We're going to save questions until after the other two doctors have done their presentations, and then we'll have you all come up and sit down, and we'll take questions from the whole room.
Okay. Hi, everybody. Happy to be here today. Thank you to sRNA and to PHA for the invitation to give this talk today. So I'll introduce myself. I'm Monica Diaz. I'm a neurologist and neuroimmunologist from the University of North Carolina at Chapel Hill, so relatively local, about 2.5 hours away. And I've been tasked with a challenging talk today. It's less scientific than the two prior talks, but I think still important. And we're going to be talking about how can we reach underserved patients that have rare neuroimmune conditions, disease. And I think if you look at this graphic, many of you, when you were going through your diagnosis and your management trajectory, you may have already dealt with some of these challenges. So although it's the same disease, it doesn't affect everybody equally, and that's because different barriers may affect people differently. So from recognizing the disease to receiving the appropriate testing, receiving the appropriate treatment, and then also getting plugged in with the right specialist. These are all things that everybody needs access to. And then insurance approval, treatment access, and follow-up and rehab. These are all things that are crucial so that everybody with NMOSD and MOGAD can receive the right treatment. But how do we prevent these barriers from happening? So rare diseases are vulnerable to gaps in healthcare. Patients can see several doctors before they reach the right specialists. Many doctors in the community may not be familiar with symptoms, common symptoms of NMOSD and MOGAD. And local hospitals may not have the right or they may not have neuroimmunology specialists. Some of these symptoms can be mistaken for common conditions, so that's why oftentimes many primary care doctors or ER doctors may not be familiar with the symptoms that can help somebody get diagnosed with NMOSD or MOGAD. And antibody testing and MRI interpretation can require special expertise. So how do we get people referred to these specialists quicker? That's a challenge. And then treatment decisions can also be complex. And then this study, it's from Europe, so may not be 100% what we see in the United States, but I think one of the clear things that we see here is that the majority of people with any rare disease, it took them 4.7 years to see the right specialist, to see somebody with rare disease expertise. And that's because many of these symptoms are just not known by local providers. So how do we educate local providers in some of the symptoms, common symptoms that are seen in NMOSD and MOGAD? That's something that we as neuroimmunology specialists really have to do to educate our local providers in recognizing these symptoms quicker. So I'll talk a little bit about NMOSD. NMOSD is rare overall, you all may know that, and that's the second bullet point there should really say that it affects about 10 per 100,000 people in general, so both male and female. But it is more common in females, like we heard from Dr. Chitnis, and I think one of the things that I want to highlight here is that it affects minoritized populations more than non-minoritized populations. So Black and Asian females are at higher risk for NMOSD, and there's a higher prevalence compared to white females. And you can see that there in the bar graph. You can see that Black and Asian females have a much higher prevalence of NMOSD compared to white females. So although the disease is the same, again, the barriers may be different in accessing care, and these barriers might include several of them. So this is a study that looked at how different race or ethnicities, particularly with rare neuroimmune diseases, what challenges they had to encounter to reach care. And in the blue and the orange lines, those are Hispanic, Latino patients and Black patients. And they had the highest challenges in reaching care compared to white and Asian patients. So some of these barriers that have been reported by patients with different rare neuroimmune conditions are minoritized populations sometimes may not feel like their symptoms are believed, like they're heard. They feel like their symptoms may be minimized. These are just things that have been reported in qualitative studies where patients with rare neuroimmune conditions have been interviewed about their experiences going to a doctor. There may be delays in referrals like we just heard about, and particularly for Latino Hispanic patients, there may be language barriers that they have to encounter as well. Lower access to specialty centers, and minoritized populations may also have challenges with insurance or medication approval barriers as well, depending on what their insurance may be. And then again, based on prior experiences with the healthcare system, this could create a sense of mistrust against the community, the healthcare community. And then in general, like I mentioned, there's a lack of clinicians who understand the symptoms of NMOSD and MOGAD. So we as neuroimmunologists really have to try to educate the people out in, or the physicians out in the rural communities on recognizing these symptoms quicker. So rural patients, they are also at significant risk for barriers to care. So this is a map of the US that shows, compared to the population density within each state, how many neurologists are there that typically treat NMOSD and MOGAD, but how many neurologists are there within each state. So you'll see that North Carolina here, we actually do have a good amount of neurologists available, but many states out in the West don't, and many states in the Midwest don't. So about 20% of the US population actually lives in rural areas. And this one study where I took this data from was done in MS, but again, many patients with NMOSD and MOGAD do seek care in MS centers. So patients with MS in rural regions had 80% lower access to neurologists compared to those living in urban areas. And 25% of zip codes across all of the US had no MS specialty center available within 60 miles. So you can imagine this creates significant barriers, and even maybe some of you may have to travel more than 60 miles to get to your neuroimmunologist or neurologist where you seek care. So this obviously creates barriers that we have to be cognizant of as physicians. So there can be several challenges that this rural problem creates, right? So one could be that, like I mentioned, the neurologist might be several hours away, and then coordinating transportation, especially if somebody doesn't drive, you may have to rely on a family member to get you to your neurologist. These are all challenges that people have to encounter. An MRI at a local facility, it may be far away from them, but even coordinating the MRI within the local facility, how do you get that MRI to your doctor that may be in another healthcare system? Getting blood work at a local lab, getting infusions coordinated, and physical therapy coordinated closer to home. These are all some of the challenges that we sometimes have to encounter when we're having our patients go to healthcare facilities that may be outside of our own healthcare facility. So it can be a challenge to coordinate all of this care. And then also transferring records between systems. So these are all some of the collective challenges that sometimes patients living in rural areas have to face. So we're going to talk a little bit about how healthcare systems might be able to create a safety net to encounter or to challenge that. So again, you all might be aware, of course, when care is delayed, what happens? So attacks, especially in NMOSD and MOGAD, need to be treated quickly. And if there are delays in those attacks, then that can create more symptoms, that can lead to certain levels of disability. So of course, we want to get attacks treated quickly. We want people started on the right treatments as quickly as possible. And of course, we want people to get their MRIs and lab monitoring on time. So these are all things that we have to be aware of, both as physicians and also as patients. And then we want to recognize side effects of medications early, and we want people to start their physical therapy, occupational therapy, and other rehab as quickly as possible. And then this is just kind of like a trajectory of what you might expect when these barriers happen and lead to delayed care. So of course, barrier may happen. Let's say attacks or the disease is not treated on time, that can lead to more symptoms developing, and then that can lead to decreased quality of life, and then of course, a decreased sense of support from the medical system. So we want to try to avoid all of these things. And then I won't go through this whole list, but some of you may have encountered this, especially if you were started on a medication or an infusion. There are a number of barriers that people can face through insurances, such as prior authorization, high copays, infusion site approval, etc. There are a lot of things, and sometimes we feel powerless as doctors when we're prescribing these medications because we don't have a lot of say sometimes, and it can be, of course, challenging and very frustrating for patients as well. So again, these are just some of the things that we have to be aware of when we're prescribing medicines. And you as patients also have to advocate for yourself as well, and just try to, advocate and work with your doctors on trying to get the right medicine approved that your doctor thinks is the right medicine for you. And then, of course, trust and communication matter with your provider. So patients are more likely to get timely care when, of course, they know who to call. So if they feel like they're having new symptoms in the middle of the night or over a weekend, who do they call? So this is all information that you should be asking your provider when you go to their clinic. Patients are more likely to get good care when they feel listened to, when their concerns are taken seriously, if there is a language need, a particular language need, that there's the right interpreter available, and that before you leave the clinic, that your care plan is explained by your provider. We want to make sure that you don't leave the clinic with questions and that you know what the next steps in your care are, and that family or caregivers are included when that's needed. And then, of course, I think one of the challenges sometimes is that when we're at a big academic medical center and your primary care may be at a local clinic, sometimes there's a breakdown in communication. So how do we get the specialist to talk to the local clinician? I mean, these are all things that we have to be aware of and that we have to work on as providers as well. So this is an idea of a system safety net that could be created for rare neuroimmune conditions, right? So we as healthcare centers, we need to try to track missed visits. So particularly if a patient has missed, more than 2 visits, well, there should be something that flags us that, okay, maybe this person is falling out of care, and how do we identify them? How do we follow up with them, right? We need to, especially for patients that are located in more rural areas, we need to try to bring more telehealth options to them, and then also helping coordinate local MRI and labs. So even having like a nurse within the center where the neuroimmunologist is located, help coordinate some of that MRI and lab, those MRI and lab needs. And then also getting the infusions scheduled, interpreters if needed, and then helping with transportation as well. So there are resources that can help with this that I'll show in a little bit. And then you as patients or as family members or caregivers of patients, it's really important before you leave the clinic that you know several things, right? One is, of course, what is your diagnosis? What is your antibody status? And then also, when was the last major attack? Because in the case, hopefully not, but in the case that you were ever to have to go to an emergency room, these are all things that the emergency room doctor would need to know as well. And then the right treatment, right? What is your current treatment? What is the next step in treatment? When is the next infusion date? And then what's the emergency plan? So if there are new symptoms, who do you call? Do you call the neurologist's office? Do you go to the emergency room? These are all kind of things that you have to discuss with your doctor before you leave the clinic. And then for monitoring, it's really important to just know when's the next MRI, when is your next lab scheduled, et cetera. And then, of course, need a list of those contact numbers. So these are all just important things that you should keep in mind before leaving the clinic. And that way you can advocate for yourself or your family members with NMOSD or MOGAD. And then just a list of some questions that you might want to ask the physician before leaving, right? Who do I call if I have new symptoms? What should I do after hours or on weekends if I do have new symptoms? Who helps with insurance approval, right? That's a big question that can oftentimes be confusing for patients. And then can any labs, MRIs be done closer to home? And if so, how do we get that information from the lab result or the MRI result? How do we get that transferred to the doctor if they're not within the same healthcare system? Is there a social worker that I can work with? And then can you send a summary of my office visit note to my local doctor? So these are all just questions that you can ask your doctor before you leave the clinic. And then there are, of course, community advocacy organizations. We're working with 2 great ones right here, SRNA and PHA, the Sumaira Foundation, and then a couple of others that I listed there that do have resources for patients with rare neuroimmune conditions. And then you may have local support groups. Some of this you can find just Googling if there are local support groups for patients with rare neuroimmune conditions. Your clinic or the center where you receive care may have social workers and case managers that can work with you as well, and patient assistance programs may be available through some of these organizations. And if any of you receive care at our center at UNC, we do have a transverse myelitis and neuromyelitis optica support group, and then on June 16th we'll have one for caregivers. So if anybody is interested and you are a patient with us, please join our licensed social worker for that. So there are questions that research still needs to answer about how we can best serve people that are underserved with neuroimmune conditions. So one is, how long does it take for people to receive a diagnosis of NMOSD, MOGAD, and transverse myelitis, particularly among minoritized populations, rural populations? We have data for patients with MS, but we don't have data for patients with NMOSD, MOGAD, and some other rare neuroimmune conditions. So we really, as a research community, need to invest more in that. Whether rural patients have longer delays with these conditions, and then whether minoritized populations face different barriers, particularly with NMOSD and MOGAD, because like I mentioned, we don't have much data on that. How insurance can affect treatment timing, and how we can include more or diverse patients within neuroimmune research, and we have a panel on that later in the afternoon. So just to kind of summarize the 5 things that can help reduce these delays, right? So one is, as patients, being aware of what are the next steps in your care, and then as clinicians, particularly in clinicians that are not specialized, being aware of NMOSD and MOGAD symptoms. Access, so having more access to specialty care, MRI, labs, infusions, and rehabilitation within the local area of where the patient lives. And then also coordinating care between the local primary care doctor, the local neurologist, and the specialist in that big academic medical center. So need to help join forces and help the patient together as best as possible. And then also navigating, how can we help patients navigate insurances, appointments, records, record transfer, and transportation. These are all things that big MS centers many times have resources for, but sometimes local neurology offices may not have resources for. So where else can we get help with that? And that's when some of these community-based organizations or advocacy groups may help. And then also building trust. So we want a respectful patient-doctor relationship that's culturally responsive and where patients feel listened to. So these are just some of the things that we can do to help reduce these delays in care for underserved patients. And I'm happy to take any questions during the Q&A session. And this is a picture of our group at the Bodford Family Transverse Myelitis Center right here in North Carolina, in Hillsborough, where we treat many patients with NMOSD, MOGAD, and transverse myelitis and other rare neuroimmune conditions. So thank you very much, and I'll take questions later.
Good morning, everyone. I would like to thank Patient Health Alliance and SRNA for the opportunity to give a talk today. I'm Dr. Tomovic Bazarowski. I am a neuroimmunologist and professor of neurology coming from University of North Carolina in Chapel Hill. And we treat a lot of patients with NMO, MOGAD, MS, and other immune-mediated CNS diseases. My task today is to talk about symptom management in NMO and MOGAD. Those are my disclosures that my institution needs me to share with you. So, talking about symptoms in NMOSD and MOGAD, it requires just introduction to say that those symptoms can be very similar. We know that NMOSD and MOGAD are different diseases, but they can have overlapping and very similar symptoms. The symptoms in NMOSD and MOGAD are highly unpredictable, so symptoms can come at any time. They can worsen at any time. They can get better over time. And they can fluctuate. So there are good days and bad days. Some symptoms on some days are feeling less. Some symptoms are feeling worse on some other days. And they are highly variable. So what kind of symptoms we can see in people who have the diagnosis of NMOSD and MOGAD? We can see a lot of vision symptoms. We can see symptoms with having troubles to talk or having troubles to swallow. We can see different degrees of weakness, muscle weakness, mobility problems. Patients may have spasticity, like increased muscle tone, or they can have spasms. They can have different kinds of sensory symptoms, like tingling, numbness, burning, pain. People with NMOSD and MOGAD can have different bowel control problems, bladder control problems, sexual dysfunction. They can have balance issues, coordination issues. Sometimes they can have movement disorders. They suffer from fatigue. They can suffer from sleep disorder, cognitive functions, dysfunction, and sometimes can have seizures. So those are all different symptoms that we need to think about what is the best way to help with those symptoms. As you have heard, NMOSD and MOGAD are attack-driven diseases, which basically means if there is a new attack, it is going to bring new symptoms or worsening symptoms. If we successfully prevent attacks, most likely people with NMOSD and MOGAD will not have new symptoms. Symptomatic treatment plays a huge role in that phase after we successfully tried the best possible attack treatment. There are still some residual symptoms that we need to target and manage in the best possible way. However, symptom management can also be important during the attack period. Symptomatic treatment includes different modalities of rehabilitation, physical therapy, occupational therapy, speech therapy, cognitive rehabilitation. However, it also includes mental health support, and it also includes different medications. Let's start talking about vision symptoms. Vision symptoms are pretty common in NMOSD and MOGAD. Vision symptoms can come very often after the person has optic neuritis. And as you can see here, I don't know if I have a pointer. So inflammation of the optic nerve is called optic neuritis. During the attack period of optic neuritis, patients may have blurry vision to different degrees. They can have pain with moving the eyes to the side. They can have visual field cuts. They can have flashing lights in front of the eyes. And they can have like color vision changes. And all those symptoms can get better after the acute treatment is applied. However, what if those symptoms don't get better? What if something is residual? What if the person is left legally blind after the optic neuritis attack? So in those circumstances, we need to consider how we can help that person who is left with significant vision decline, or maybe even legally blind. We can recommend different magnifiers. They can be, as you can see here, handheld magnifiers or different apps that people can use on their cell phones and on computers. We can use dictation tools for people who cannot see so that they can be able to write. There are different kitchen aids to help with to people who are blind or have visual impairment of a certain degree. For people who are photosensitive, meaning sensitive to light, those people can consider using transition glasses, or they can apply with the help of their provider to get an exemption to get their car windows tinted. Sometimes people with NMOSD and MOGAD can have double vision. And that double vision comes from lesions in certain parts of the brain that control eye movement. If you have a patient who has a double vision, then we treat that with acute attack treatment if it is a part of the attack. But what if the double vision persists? This is where we need to partner with ophthalmology, and they typically recommend prism glasses, and sometimes they do recommend physical therapy for the eye movements, which is eye exercise program, which can help align the eyes better. There are different apps that can help people with vision impairment function better. Those apps can either translate the text into the language and the speech, or they can even tell what denomination of the paper currency the patient is holding in their hands in real time. So patients with visual impairment can pay bills successfully using cash. There are different websites that can offer different resources to people who have vision impairment. One of them is listed here, called Vision Aware, but there are also different organizations and advocacy groups, such as National Federation of the Blind and the American Council of the Blind, which really can work together with patients to advocate and provide useful resources. When a patient with NMOSD or MOGAD has speech difficulty, we really need to partner with speech therapy. Speech therapy assessment and management is very crucial in this situation. Strategies to improve speech are actually involving different exercises that help with articulation, help with voice, help with fluency, help with other oral movements that are involved in speech production. Strategies to improve strategies to improve swallowing include postural adjustments, eating modifications, and texture modifications if they are needed in a certain patient. What about weakness? We know that a lot of patients with NMOSD and MOGAD can have weakness, and that weakness typically comes from myelitis. This is just one study that has shown that around 30% of patients with aquaporin 4 antibody positive NMOSD develop permanent motor dysfunction, and 33% of those become wheelchair bound after median disease duration of 75 months. This is just one study, and this study was done before the era of FDA-labeled medications for the NMOSD. However, this is still a huge problem. Even with the most successful medications, we do still have patients who have significant mobility issues. There are studies that were comparing who will get into more severe disability, patients with NMOSD or patients with MOGAD. And this study done in 2024 has shown that actually people with NMOSD will be more likely to get into more severe disability earlier than people with MOGAD. If people have those severe mobility issues, what we can do about it? If the acute treatment with steroids or plasma exchange, in MOGAD we often use IVIG for the acute treatment as well, does not help. So we need to target that from different perspectives. We recommend, of course, using mobility aids such as canes, crutches, walkers, different kinds of manual or motorized wheelchairs, scooters. But we also recommend in certain patients who may qualify functional electrical stimulation. So functional electrical stimulation is actually a technique that involves stimulating the nerve that controls the muscle. So by stimulating the nerve, you get muscle response. And in that case, you can help mobility in patients who have impaired mobility because some muscles are weak. In addition to that, I would like to take a few minutes to talk about exoskeletons. So exoskeletons are those robotic suits that actually help move the muscles. They passively help move the muscles. Functional electrical stimulation stimulates the muscle to do the job. Exoskeleton moves the muscle. So far, we don't have any exoskeleton that is FDA labeled for NMOSD or MOGAD. We do have one, which I have shown here, which is FDA cleared for people with multiple sclerosis, although just for rehabilitation purposes. We don't have an FDA clear exoskeleton to be used at home as a personal device. There is a lot of research going on into this field with a big goal in the future are we able to develop exoskeletons that are going to be used at home as a personal device and assist with walking to people who have those needs? At the UNC and NC State Department of Biomedical Engineering, we are currently designing a study. This is actually going to look into combining exoskeleton with functional electrical stimulation in people with transverse myelitis of any cause, including NMOSD and MOGAD, to help with mobility issues. And our postdoc, Christine Lambert, is currently working on this study. Of course, if people have lower extremity weakness and they cannot drive car, then we do recommend that they get vehicle adaptation with hand controls. Of course, very important issue is home adaptation for safety, as well as work accommodations at work. What else we can do to help people who cannot walk or they have significant walking impairment? From the medication perspective, there is a drug that is called dalfampridine, and that drug is actually labeled to improve walking speed in people with multiple sclerosis. However, there was a small study using this drug in a small number of patients with NMOSD, and it did show that in about 23% of patients, it did improve walking speed. The criteria for improvement was to improve walking speed by at least 20% after 2 weeks of treatment. So what else we can think about? This all seems great, but not enough. I would like to take a few minutes to talk about brain-computer interface. Brain-computer interface is a very complex high technology. It is not studied in NMOSD or MOGAD. It has been studied in people, for example, with traumatic spinal cord injury. So what does it do? Even when we are thinking about making a movement, our brain creates electrical activity that can be captured and then converted into the digital signal that tells the computer what you're thinking about and what you want it to do. And then the computer can execute the action, or you can even, using this technique, give commands to the motorized wheelchair, or you can even move bionic arms that are attached to the computer and do some physical activity in that way. This is still a huge research field, and again, it's not studied specifically in NMOSD or MOGAD, but we're hoping to get there. When people with NMOSD have spasticity, which is defined as an increased muscle tone that makes people walking ability difficult, and then the movements do not run smoothly and you cannot stretch out, then we need to use first physical therapy to try to help with spasticity, but also we can try some medications. There are some good sides of spasticity as well, because spasticity can help compensate for the weakness that the patient has. So we never do not want to overtreat the spasticity, because it may be beneficial to help people stand, to help with transfers, to help with the blood supply and circulation. It can help prevent pressure sores. So we need to find the best sweet spot when we decide how much spasticity we want to get rid of. So what do we use? We use, as I said, physical therapy, but we also use a lot of medications. I just listed some of the most frequently used ones, which is like oral baclofen, tizanidine, dantrolene works directly on the muscle, so it should not be causing any sedation or drowsiness that other medications can. If the oral medications in the optimized regimen, optimized to the individual patients, do not work, then we can consider other options, such as intrathecal baclofen pumps, where the baclofen, which is a muscle relaxant, gets injected into the spinal fluid space, and in that case, it works directly on the spinal cord level. We can also think about botulinum toxin injection, which botulinum toxin is a toxin that blocks muscle activation. So it can be directly injected into the muscles that need it the most. The drawback of using botulinum toxin is that you can only use it on selected muscle groups, and it needs to be repeated usually every 3 months. So what about paroxysmal tonic spasms? So paroxysmal tonic spasms are episodic spasms that people with NMOSD or MOGAD can get. They're usually generated from the spinal cord, and they usually come all of a sudden. They last short, and they may be repeated, and they're typically provoked by movements. So to treat those, we actually use anti-seizure medications. And I just listed here some of them that they can be tried, such as gabapentin, pregabalin, carbamazepine, or oxcarbazepine. Sometimes we also use Lamictal as well. What about sensory symptoms? This can be a very disabling symptom, even though sensory symptom is maybe felt or regarded as something that is less important than mobility, it is equally important. So people with MS and NMO, interstitial myelitis, or any other cause, or MOGAD, they can share symptoms such as numbness, tingling, nerve pain. Sometimes it can be a feeling of burning, which can be generated from the spinal cord. So we need to target those symptoms because they can be very disabling and can be really affecting in a negative way patients' quality of life. So what do we use? We use gabapentin, pregabalin, carbamazepine, oxcarbazepine, sometimes we use levetiracetam. So as you can see, a lot of anti-seizure medications used in the world of treating neuropathic pain and sensory symptoms. Unfortunately, if the patient has numbness, we cannot help much with that, but we can help with so-called positive symptoms, such as tingling, pain, burning. Other options to consider here sometimes can be lamotrigine, antidepressants, such as amitriptyline or triptyline, duloxetine. Sometimes we use low-dose naltrexone as a treatment to treat neuropathic pain that does not respond to classical neuropathic pain management strategies. Acupuncture can be considered, as well as biofeedback techniques. People with NMOSD and MOGAD can have impaired walking patterns. And then impaired walking patterns on a long time can cause some spinal instability and some musculoskeletal pains. So we do target those with non-steroid anti-inflammatory agents. We recommend compensatory gait strategies, and of course, spasticity management can help here as well. What about bowel, bladder, and sexual dysfunction? When it comes to bladder dysfunction, we have seen different kinds of bladder problems. There are difficulties to store the urine, and there are difficulties to empty the urine, and some patients have both kinds of problems. This is where we need to partner with urologists and neurourologists. I have listed here some of the most frequently used medications that we try in people who have difficulties to store urine. But medications are not enough. We usually need to combine it with pelvic health physical therapy that is going to help strengthen the pelvic floor and help regulate things better. When we talk about medication and we are considering which medications to use, we really need to use individual approach, because the thing is, some of those medications can have side effects which may not be desirable in a single patient. So, for example, some of those medications can have negative side effect on cognition. And if you have a patient who is in an older age group, or they have cognitive challenges already, we really would like to avoid medications that can have a negative side effect on cognition. Some of those medications can have a side effect in terms of dry eyes, dry mouth, and if you already have those symptoms, we really don't want to give you any medicine that can make it worse. Some of those medications can increase blood pressure, for example. So we need to think about comorbidities. Does the patient have high blood pressure as a comorbidity? So all this needs to be taken in consideration before we make a decision what drug to use. If the pills don't work, sometimes our urologists who are specializing in neurourology can help with some implants, which are, for example, sacral neuromodulation, which is basically an implant that is placed into the lower spinal roots, and stimulating those spinal roots that control the bladder function, you can have improvement in the bladder function overall. Posterior tibial nerve stimulation is not an implant. It is a procedure where the tiny needle is inserted just above the ankle. It is an outpatient procedure, requires multiple appointments, but by inserting that needle, it provides electrical stimulation to the nerve that shares the same origin as the nerves that control the bladder, and in that way, you can, by stimulating the leg nerve, you can get improvement in bladder function. There are different kinds of problems where people get failure to empty bladder. So when we speak about those, how to target those, we can use some medications, for example, as this one, tamsulosin. However, in some cases, we need to apply either suprapubic catheters or a Foley catheter, or sometimes patients who are able to do that can do intermittent self-catheterization. For patients who are waking up multiple times to urinate, we can sometimes use desmopressin, which is a medication that helps reduce the volume of urine produced overnight. We need to talk with our patients about sexual dysfunction. Sexual dysfunction is an important component of quality of life in our patients. And I have listed here what we most often recommend, sildenafil and tadalafil. However, if you don't ask our patients about this problem, it's more likely that they are not going to tell it to us. So we need to have this open discussion, because we can have a patient who is able to walk without restrictions, maybe has some tiny numbness in the legs, but their quality of life is so poor because they have sexual dysfunction. So we need, as providers, need to be very cognizant about this. When it comes to bowel management, there are different strategies, regular bowel regimens, high fiber diets, sufficient liquids. Sometimes you need to recommend stool softeners or laxatives or enema, mini enema suppositories. What about other symptoms? Patients with NMOSD and MOGAD can have different kinds of other symptoms, as I already mentioned. And if you don't talk about them, we will not know about them, and we will not be able to treat them. So we definitely need to recommend that our patients tell us about all the symptoms that they have. And sometimes it may take a long visit, but this is what we are here for. So if there is a coordination symptom or a balance problem, physical therapy can help there a lot. But also there are some medications that can help with, for example, tremors. If the patient has cognitive dysfunction and psychiatric symptoms, we really need to partner with psychiatry and mental health therapists to help with psychiatric symptoms, but also refer patients to cognitive rehabilitation, because it can be helpful. Unfortunately, there is no drug that can help with cognitive symptoms in NMOSD and MOGAD, but cognitive rehabilitation can be successful to some extent. Fatigue is a huge problem in our patients. So fatigue can be seen in about 70% of patients with NMOSD and MOGAD. So how do we tackle fatigue? Fatigue is multifactorial. It can come from different sources. It may be because of the disease, and it may be because the patient has a poor sleep, or it may be because the patient is depressed. So we need to think about all those options and discuss and see what would be the best way to treat fatigue. There are some medications that can be tried in people with NMOSD and MOGAD to help with fatigue. I listed some of those here, like armodafinil, normodafinil, amantadine, sometimes used. Some patients, especially with NMOSD, can have excessive daytime sleepiness, or they can have acquired narcolepsy, and helping with those symptoms is very crucial. What about seizures? People with MOGAD, both pediatric and adult patients, as well as patients with NMOSD can have seizures, of course. And if they have seizures, then we need to treat them. When we speak about movement disorders, different kinds of movement disorders have been reported in people with NMOSD and MOGAD. However, when we see them, we need to treat them, and usually physical therapy and some medications can help with that. All those symptoms are important to know about so that we can treat them well. And as you can imagine, not reporting your symptoms to your doctor will actually result in getting not sufficient care. I would like to thank you for your attention. I'm happy to answer any questions. And this is just a photo just showing a part of our team at the University of North Carolina Transverse Myelitis Center, where we see patients with NMOSD, MOGAD, transverse myelitis of any cause, and we provide a comprehensive multidisciplinary care. Thank you so much for your attention.
Standing up? You're going to be standing
No,
up?
yeah, I'll stand. Oh, I'm sorry, your hands are full. I'm handing you this. So this is one of the most favorite parts of the day. You can answer or ask any of your questions to the experts. Excellent information this morning, and we dipped into some of this time because Ben gave us a little bit of time to take some questions, which was wonderful.
Hi, my name is Danny. I'm from Brazil, and I have two questions. First is about menopause and like some medicine that cause cognitions impairs that the last doctor talk about. And in menopause, we can have cognition impairs during the journey. And so I would like to know about the NMO, if we can have cognition impairs, and if it can be worse during the menopause, and which medicine can get it worse, you know? Please.
Yeah, so maybe I can start, and then Dr. Juvamak might like to add on. So in general, menopause, we know, does cause itself, regardless of having NMO or any condition, it does cause a number of changes. So sleep changes, sometimes onset of or worsening of depression, mood changes, certainly hot flashes, fatigue, and just generally changes in quality of life. Does not happen to everyone. It's different for every woman who is going through this change, and so some experience some of these symptoms more or less. If it's something like surgical menopause, where the ovaries have been taken out surgically, then it's very dramatic, and there's a dramatic change, and it's very obvious. Sometimes, you know, with natural menopause, it's a more gradual change that occurs over a few years. So, you know, in terms of some medications that could help, so individual medications can help each of these symptoms depending on how, you know, what the issues are. So sleep issues, there are medications for sleep. You can speak to your doctor about those. They can range from anything as simple as magnesium, sometimes melatonin, or even some of the sleep aids can be helpful, and especially getting through a certain period. There are medicines for hot flashes. So, you know, there is, and actually I'm blanking on the name, but there is one for hot flashes that can be helpful as well. And, you know, then the other things, mood changes, so antidepressants, et cetera, can also be helpful. And sometimes it's just for a period of time. There are creams that can be helpful as well, so in situations of dryness, et cetera. And then, you know, there's also an additional question: when you have a neurological disease, is the disease getting worse because of menopause, or is there an interaction of the two factors together? And I think we don't know enough about it. I suspect, yes, there is some interaction, and just everything can seem a little worse. Hormone replacement therapy can be helpful for many of these symptoms, and, you know, there's a lot of data showing both benefits of HRT for certainly hot flashes and other symptoms, and also for even longer term outcomes regardless of having an autoimmune disease. There are some concerns as well, and so depending on your situation, you can speak to both your neurologist as well as someone who is specializing in this area. There are primary care physicians, menopause experts, gynecologists who can also help to advise on your particular risk situation. But I think we don't know enough about whether HRT, hormone replacement therapy, can exacerbate NMO and lead to more activity. But I suspect if you're on a treatment that is very effective, then it's controlled, and so there's less of an issue of interaction.
Can I just? Oh, sure. One is not about menopause anymore. It's about Enspring, because someone told me who is on Enspring doesn't get fever. Can you talk about it, please?
Yeah, it doesn't mount a fever. So, because it's a cytokine blocker, sometimes that can interfere with mounting a fever, and so it's not as obvious. But it's variable. But I think a situation where it's important to think about is if you have an infection and you think that you do have an infection, but you're not mounting a fever, it's important to mention this to any doctor who's taking care of you.
Thank you.
Hello, thank you so much. My question is, so I'm actually paralyzed on my right side on my long thoracic nerves, and they have found lesions on that, but I was told that it couldn't be caused by MOGAD because it's part of the peripheral nervous system. Is that true, or could MOGAD go outside of the central nervous system and cause damage on the peripheral nervous system nerves?
Yeah. You can go ahead. I talked a lot.
So MOGAD is technically a central nervous system disease. Whenever you have a patient who has associated peripheral nervous system lesion, then we need to think about whether there is some other cause for it. The situation in your that you're describing may require such as assessment, and also there may be a lesion in the part of the spinal cord where the thoracic nerve that you're talking about originates from. So it may be another cause why the symptoms may be coming from the actually spinal cord and mimicking peripheral lesion. Does that answer your question?
Yes, thank you.
You're welcome.
My question is for Dr. Diaz. So it has been my experience people are rather blind to their bias, myself included, and I appreciate you addressing the topic. But what is being done for the providers? I mean, it's all well and good to say, oh, you need to advocate more, right? But if you're talking to somebody who already has that bias, having an advocate is kind of hard. And so I'm curious, is there anything being done to help educate providers on the marginalized population and the lack of care? Because it's really disingenuous to hear a doctor telling one of my friends that she doesn't want to get better because she can't attend her physical therapy appointments because she has a job.
Yeah, so thank you for bringing up that point. So I think there's not enough being done. I mean, that's the truth, right? And there are certain programs, like for example, Project ECHO is an education program for community-based providers, so primary care doctors, neurologists in the community. And I know as part of Project ECHO, there have been some talks that have been given, particularly on this topic, right? On minoritized populations, people of color, and how they may encounter symptoms of different neurologic diseases. So, I mean, there are certain programs available, but in general, I mean, there's not enough being done, I think. And, I think that it would be nice if there were more structured programs for community doctors to kind of learn more, become more aware that this is a bias that exists, so that way they can become, aware of these biases. And not just like community doctors, just, any provider would benefit from that type of training too.
Hi. don't know why it's making that sound. Oh, it's because I'm too close. Okay, let me go over here. Hi. So I am a young adult, that kind of thing. I have PCOS, and so my doctors are always kind of trying to push estrogen, or like, oral birth control, or try to do IUD. I did an IUD for a long time, but I started having a lot of symptoms with it. I would have 40-day periods, which is not great. So I'm trying to figure out kind of like whether or not I need to treat the PCOS at all. What's the priority? Because I know PCOS has a really high cancer risk, and I don't know. What would you recommend to someone who's like really, really does not want to go on like an estrogen type thing just due to having NMO? What would you recommend for that?
Yeah, so I think, this is a conversation with your neurologist and also your endocrinologist, but maybe I'll ask you, concerns about going on oral contraceptives. You might have specific concerns about this, but this might be a way to regulate the kind of dose of estrogen that you're getting, and this can be helpful. In some patients, I have found that sometimes having a more steady dose of estrogen rather than this up and down and constant cycling can be helpful, and especially if you are on a treatment that protects or is controlling your immune system, then that combination can be successful. And you can ask us anything about, other treatments as well. We don't have to stick to the topics that we talked about.
I think we had an online question come in the other day, just before the event, about comorbidities, about other diagnoses of multiple autoimmune diseases. And specifically, they were asking about Cushing's, maybe post-steroid use. Is that something that you've seen in your own clinics? They were asking frequency of seeing Cushing's and NMOSD.
I can take that one. Thank you. Thank you for that question. Cushing syndrome can be like disease per se, so separate disease. Sometimes you can see Cushing after prolonged steroid treatment. We are trying in the recent years to use steroids less and less in the prolonged setting. However, sometimes that happens. So yes, the answer is yes, we can see Cushing syndrome sometimes after prolonged steroid use. However, with the use of new medications for NMOSD, as well as with like more awareness of that side effect, I think that people are in the recent years using steroids less and less on a prolonged like steroid taper manner, and this brings less incidence of having that side effect as Cushing.
Okay. If you see someone with prolonged high cortisol and low potassium, would that indicate testing for Cushing's?
Yeah, you usually partner with endocrinology in those workup tests.
Okay, thank you. I hope that person's watching. I'll send them a clip of that.
Okay, thank you.
We also have another question. Someone just wrote in, can I consider no treatment? Or any recommendation for another way to modify? This is hard to read, Noah, sorry. I guess I'll start with that. Do you recommend no treatment for AQP4 positive NMOSD patients?
No.
Thank you.
So the treatment for AQP4 positive NMOSD is lifelong.
Yeah. So there was more to the question about having been on Rituxan and then moved to Ocrevus, and then diagnosed with breast cancer, and is on a hormone blocker. Do hormone blockers make NMOSD worse?
Yeah, so I think, given that we think that the immune system is revved up by estrogen, then maybe a hormone blocker might be helpful, but certainly not a treatment that I would rely on for NMOSD. And I would probably think about additional immunotherapy on top of that.
Thank you.
Hi. Hello. Hi. So this is for all of the speakers, but Dr. Chitnis, on one of your slides, you mentioned kind of the ideal timing for when someone should get their last dose of medication before getting pregnant. But as I think we all know, in real world settings, that's not necessarily something that happens at that precisely. So what do you typically recommend in that kind of more real world setting of if we can't control things perfectly, what to do in terms of medications and when to stop them kind of before attempting pregnancy?
Yeah, that's a great question. And, I think real world and practicalities. So taking the example of, say, B-cell therapy. So the ideal situation is to receive a dose and then start trying to conceive 2 months later. And so that's generally a safe period. And then if conception doesn't take place within that next 4-month period, then, receive the next dose. And so constant testing and continuing on that. And then similar principles for the other immunotherapies.
About the pregnancy, what's the best time to restart the medicine after delivery? And what's the best medicine to, if you can feed the baby during the medicine?
Yeah, so the best time to start medication, and I'm sort of assuming you're talking about AQP4 positive NMOSD or seronegative NMOSD because it's treated with similar medicines. So the best time to restart is right after delivery. So within, say, 1 to 2 weeks. That is really the ideal situation. If it needs to be delayed a little bit further, that, so be it, but that would be the recommendation. In terms of breastfeeding, we know that Ocrevus does not cross into the breast milk, so it is safe to breastfeed on that medicine. I generally tell women to pump and dump for 48 hours after getting their dose, just in case, and then that way they can restart breastfeeding. So now we don't have a lot of data on the other medicines. So, the medicines that are approved for NMOSD, we don't have breastfeeding data yet on those medicines. So it may be reasonable to try to breastfeed, with, again, the guidance of your neurologist, but with some period of pumping and dumping after an infusion, because we don't think the antibodies get into breast milk. But, this is a study that needs to be done.
Another question for you. So I'm curious about nausea. I, again, have MOGAD and experience a lot of daily nausea. Is there a correlation with MOGAD and long-term nausea? Because a lot of my specialists that I've seen don't tend to think so. So is there a high likelihood of reoccurring nausea in MOGAD patients?
Should I take? Okay, thank you. Thank you for that question. That's a very important question. Nausea is a symptom that can originate from multiple sources. So nausea can come from GI symptoms, or it may come because you didn't like the food, your stomach doesn't like the food you have consumed on that day, or it may be coming from the central causes. When we speak about nausea coming from central causes, NMOSD is more likely to cause like nausea. It can also cause intractable hiccups and vomiting for no clear reason, but it can also happen in MOGAD. And it actually depends on where the lesion is. If there is a lesion in the part of the brain that is very responsible and sensitive to any blood chemistry changes, then that lesion can cause nausea. And symptomatic treatment of nausea is important. So taking symptomatic medicine such as Zofran, for example, can help lessen the nausea if it is very like a daily problem or very often experienced problem. I don't know what your situation is, but we usually recommend taking nausea medicine as needed in people who suffer from nausea, whether it is in MOGAD or NMOSD.
Thank you.
You're welcome.
Hello, thank you for all the work you do for us. This question is from Diana. She has MOGAD, and I'm going to translate or try to translate. She has, her question is, why her brain is always has inflammation for 3 years.
Could you also clarify brain inflammation? Is it because of MRI lesions, or is she experiencing symptoms of brain inflammation? And if so, what are those symptoms?
¿Es salen en el MRI inflammation or es por lesión que tiene el cerebro? The MRI inflammation.
Yeah. So, and it sounds like you're continuing to have new lesions and experiencing brain inflammation, and this is going on over 3 years. So more lesions are coming up. Is that the situation? Yeah, and this is despite treatment?
Which treatment? Así tenga tratamiento, siempre está inflamado. ¿Qué treatment tienes?
She's taking prednisone for the last 3 years.
Okay.
And the inflammation is still there.
Yeah. So, I can start, and others I'm sure can join, but so prednisone we don't think is a very good long-term treatment for MOGAD. And in general, excuse me, prednisone, we know that it's very helpful for acute attacks, especially high dose, either prednisone or steroids is very helpful when there's an acute event that happens. But prednisone long-term can have a lot of side effects. And so we try to avoid long-term use of prednisone for years and years because it can lead to Cushing syndrome, it can lead to osteoporosis, it can also lead to other side effects like gastritis.
And what do you recommend for her to say to her doctor or his doctor about the long-term prednisone treatment?
Yeah, so I would think about other options. And so there was recently a phase 3 clinical trial which showed an effect of something called satralizumab, which is a drug that is an IL-6 receptor blocker. And so it showed that it was beneficial in preventing attacks, preventing new lesions, and it hopefully will get FDA approval very soon. So this is a drug that's approved for NMOSD, and so it can be kind of borrowed and used in MOGAD. And we know about the safety profile, we know about the efficacy profile now in MOGAD, so that's an option, satralizumab.
I'm sorry, I understand satralizumab for
Yes.
MOGAD?
Yes.
Okay.
Yes, and then some other options, and depending on where you live and approvals, et cetera, other options are IVIG can be very helpful, and this can be given on a every month or every 6 or 8 week basis, and so that's been very helpful in preventing new attacks and lesions in MOGAD and controlling the symptoms. Also some of the older drugs like mycophenolate mofetil, which is a mouthful, also known as Cellcept, CELLCEPT.
Cellcept.
Yeah.
Yes, actually she's from here, from Charlotte.
Okay, well then
Thank you.
you have a couple of doctors here who might be able to see you.
Yes. Thank you, doctor.
To kind of piggyback off of that topic, so I was on prednisone high dose for a couple of years, and I developed osteoporosis. And one of the treatments that they put me on was HRT because I'm also post-menopause. But then how do you weigh the risk? Because my bone doctor did not know anything about my illness, and I was right in the middle of switching neurologists. And so the question, I guess, is there a lot of data on, or is there not really much data on HRT and the risks with it? Because we know there's data on HRT and bone health, right? So
yes.
How do you weigh the two?
Yeah, so I think, you're really identifying a gap in our knowledge base. So we do need studies in this area in MOGAD and HRT use and menopause. So, maybe we'll have a postdoc working on this topic. soon. And, weighing the risks. So, at this point, I think just careful monitoring for new symptoms is important. But again, I would sort of, question long-term use of prednisone. So it has had side effects and issues. There are other options available now, and, especially with satralizumab kind of being on that horizon of potentially being approved, that could be an option. There has been also a lot of data on IVIG, on mycophenolate mofetil, which is a daily pill. Also, rituximab might be helpful in some people. So, there's less success with rituximab and MOGAD, but it might be helpful in some people. So I would look at these other options as well.
Hi, my question is for anybody that can answer it. My name is Larkeisha. I'm aquaporin 4 positive. I'm currently on rituximab. I do have to take IVIG monthly. We're working on a therapeutic right now, a new one. My question is, I have really bad tonic spasms. I'm gonna list off what I take for those because most of them was on that list. Tizanidine, dantrolene, baclofen, oxabenzo something. I always just say the one starts with the O. And then I also take abapentin, which is a lot of muscle relaxers. Part one is there one pill that I could take versus all of these? Because they seem like they all do the same thing. And then part two is Dr. Diaz. I live in a very rural area. I don't know if y'all know about Cowpen, South Carolina. I know you say you're from Chapel Hill, so you may have heard of I'm from Cowpen, South Carolina, which is not very big. We have maybe 2 really good neurologists that knows a good bit about NMOSD. But when I get there and I'm pushing and I'm advocating, because I'm an advocate here in DC, everywhere, it's like they don't listen. And I'm thinking it's because of just barriers. I live in a not so great area in the country. And sometimes I feel like they think I'm med shopping or pill shopping, and I'm not, because I don't want any of these. I would like to have one super pill. So could you answer either one of those for me?
So I got my voice back. So I'll take that one. So sometimes, we as providers are also wishful to get a super pill and magic bullet, but sometimes it's really difficult. And sometimes we need to use multiple strategies and to target the problem from multiple angles and use medications that work in different ways to help manage the symptoms if the symptoms are refractory. And in your situation, it does seem like it was a refractory symptom because, I assume you were not prescribed 10 medications at once, but it was just building up over time. It is true that some patients who have myelitis, they are left with very debilitating paroxysmal tonic spasms in legs, which can come with either stretching the legs out, or like the foot would go in, or it can flex, or sometimes it can affect upper limbs, so the arms can lock out for a few seconds, 10 or 20 seconds, and it will go away. And usually what we have seen is better outcomes if we use anti-seizure medications that block so-called sodium channels. So sodium channel blockers, and oxcarbazepine that you're mentioning is one of them, to help with that symptom. And maybe sometimes we combine different sodium channel blockers if one is not enough. And muscle relaxants, if you don't have spasticity, like continuously increase muscle tone, then they may not be helpful too much, although they may provide some relief. So I would recommend talking to your neurologist and maybe switching the approach into maybe using more of the anti-seizure medications and less muscle relaxants. You're welcome.
I can take the second question. So I think the important thing is having a local neurologist, particularly if you're in a pretty rural area, but also having an expert neuroimmunologist that can really weigh in on these questions that you have about long-term symptoms, about paroxysmal symptoms, about the right treatment for NMOSD. So we actually just finished a study on Latino patients that we see in our center in Chapel Hill and in Hillsborough. And we found that on average, they travel about 67 miles to come to our clinic. That's a lot, right? But, we try to do a combination of hybrid, as in like remote follow-up plus following up in person. So that is an option, right? If you'd like to see a neuroimmunologist, we're of course happy to see you at UNC if insurance, approves that. But we try to do like a hybrid follow-up if that's possible. So, yeah.
I would just like to add, it is always good to have a local neurologist if you're living far away from a specialty center, because in a case of relapse, it's much easier to get into the local neurologist than to travel 3 hours or 4 hours to see a specialist. And we should work together with your local neurologists, who are most often like a general neurologist. But we should build up like care team approach. And if any help from our side is needed, we are always able to help. If we would appreciate local neurology, seeing a patient in the case of relapse, then it's much easier to arrange in most cases.
Monica.
Good morning. I was just wondering if you have had patients complain or you have seen a correlation with skin sensitivity. I've noticed since I was diagnosed 6 years ago that my skin has been becoming increasingly sensitive. Things that I wasn't normally sensitive to before, like for instance, getting IVs and like the adhesive from the IVs will leave bruises. I bruise way more easily now than I did previously. If I am in the sun for an extended period of time, I start to develop whelps and things of that nature. So I wasn't sure if maybe it had something to do with maybe the treatment that I'm on or just something that's developed since NMO. I don't know. I'm seronegative, so I know for me it's a little different. I don't have any lesions either, so it makes it kind of hard for me to get answers on certain things. And I've seen a dermatologist, and they weren't really able to provide any kind of answers either.
Yeah, I would speak with your neurologist, and sometimes there can be other autoimmune diseases that can occur with NMO. We know that with aquaporin 4 positive NMOSD, there's an association with patients having lupus as well and Sjogren's syndrome. So I would, I think we don't know enough about double seronegative NMOSD, or if you're in a rare case where you might have missed your antibody testing. So I would look for these other autoimmune conditions as well and speak to your neurologist about those. Sometimes lupus can cause some skin sensitivity symptoms, and there can be testing done for that.
Thank you.
I had another question that came up in conversation in the last few weeks, and it may be something that ties together with your presentation, Dr. Diaz. We have a lot of patients that, when they were first diagnosed, they presented maybe with more outward symptoms, something more obvious. And then when they have to return to the emergency room, first of all, it's terrible. Nobody wants to go back to the emergency room, especially if they were turned away maybe the first few times they went in their early stages of NMOSD. But kind of proving that they have this disease that someone's never heard of is a challenge. And it was suggested that possibly on their after-visit summary, there could be some type of instructions of what to do if they have to go to the ER, or what the diagnosis is and what the protocol is in the event of symptoms of relapse. Is that something that is a reasonable ask of a neurologist during their appointment? Is it something that you've ever been asked or that you would do?
Yeah, actually, so yes, I think that is a very reasonable expected request, right? That at least the neurologist be able to provide an emergency plan, right? Like who to contact if you do have symptoms after hours, what's the phone number? And we actually provide that in our after visit summary. I think almost all the providers in our center provide that. We have the contact numbers. And I think it's really important to discuss with your provider what are the next steps in treatment, right? So that way, like you said, in the case that somebody has to go to an emergency room, or if they go see their local neurologist, that way the local neurologist also knows what the game plan is too. So
that's great. Thank you. Oh, sorry, Danny. And then we'll maybe have time for one more.
If no one has questions. We talk about using steroids for a long time. So what do we expect when we begin to decrease the steroids that we are using for a long term, like 14 years?
And can I ask the diagnosis?
NMOSD aquaporin 4 positive. I was in Imuran plus steroids, and I switched to Enspring last year, and I'm no relapse since this time. I never had a relapse after I start the medication, and I still on steroids because the switch, but I think we're gonna be decreasing now.
Yeah, so, I think that's the right way to do it. So you want to, especially if you've been on the steroids for this long, you want to decrease them very slowly and probably over several months. And so that is the right thing to do. So, you're going to work with your neurologist and look out for any both rebound of any symptoms, which it sounds like is very unlikely to occur, but also any symptoms of steroid withdrawal. And this includes monitoring your blood work, looking at your electrolyte counts, your blood glucose, and some other measures. So you want to make sure that those are in the right range as you're tapering off the steroids.
Okay. I can't believe someone else didn't ask this, especially Doug, I expected. But can you discuss a little about someone that's been long-term on rituximab or any of the biosimilars and monitoring IgGs and what that looks like? Because it usually comes up, and I think there's a lot of people maybe seeing a neurologist that's not checking that. Like, we see that and hear that on our helpline. Of course, we don't give any medical advice on the helpline, but we're hearing the question. How do I approach my doctor to ask about checking these levels? And I just wondered, what is your protocol in your practices about someone that is on off-label therapy like Rituxan, a B-cell depleter, having multiple infections, and at what point do you intervene with either a change or adding IVIG, something like that?
I can add to that.
Oh.
Got a mic. So, and this question, we asked this a lot last year through the series, and so I'll just maybe summarize that. So there's a proportion of us that are on B-cell depleters who, in addition to that, have to have IVIG to stay out of the hospital. I was every 4 weeks, now I'm every 3 weeks on IVIG. First of all, is that common? What is the percentage? 10, 20, 30% of B-cell depleters? How many of those are also on IVIG? And what does that mean long term? Does that mean that we have failed on that B-cell depleter? Should we be moving to something else, and should our insurance company accommodate that?
I can maybe start answering those questions. Those are very important questions, and thank you so much for asking. So we, to answer the first question first, at UNC, we usually monitor immunoglobulin levels, IgG and IgM, on the day when the patient comes for the infusion. So in that way, we get results on those tests every 6 months. If the infusion goes every 6 months, sometimes people need to receive infusions more often because they repopulate B cells sooner rather than every 6 months. So, but whenever they go for the infusion, we get those results. And it is true that sometimes not everyone checks those. Those are important for us to know if the patient starts getting more frequent infections, whether we can associate the infection frequency with maybe dropping down in immunoglobulin levels. And it is always a shared decision-making discussion what we do about it if we see a patient who is having frequent infections more often than prior to starting on rituximab. And are we going to change the medication to something that is not going to increase infection risk so much? Or we're going to add IVIG to rituximab to try to minimize infection risk if we assume that rituximab is still working and keeping good disease control over NMOSD. So it's always a shared decision-making approach. And it's difficult to say, yes, this is a recommendation that would fit every patient. I would generally like to try to switch treatment. And it also depends what kind of infections are those. Are they severe infections or mild infections? How often they happen?
It was putting me in the hospital. Every 3 to 6 weeks, I was back in the hospital before I started IVIG. And some of those were minor infections, others were significant. So, you know, again, I'm 9 years without a relapse, you know, so is the Rituxan, which is or Ruxience, that I'm on, and the IVIG, is that the right process? And, you know, Travis up here in the front, he's essentially on the same regime that I am. I shouldn't tell your medical history, sorry, Travis. But there are several of us that you know, end up having to do the IVIG with the Ruxience or Rituxan in order not to get sick and be in the hospital. Is that okay? Is that, as long as we're not getting a relapse, is that all right? Or should we be looking at something else? And how do we convince our insurance companies that something else is better?
In a way, it is one of the way to like keep control over infection risk and over your disease, but I would definitely consider other options, such as switching maybe to complement inhibition or satralizumab for example risk in most of the patients, not in all, but in most of the patients compared with rituximab. And in that way, you may get rid of IVIG. IVIG on the long term can also show nephrotoxicity, so it can be affecting kidney health. So, you know, if you're on a long-term IVIG monitoring, then your provider needs to monitor your kidney function as well. I don't know if Dr. Diaz or Dr. Chintis would like to add something.
Oh, sure. I was just going to quickly address the insurance question. How do you get your insurance company to approve another medicine? It can, of course, it depends on the insurance company, but really advocating and for your clinician to appeal if you get a denial, right? Because oftentimes we'll try to appeal that medicine that we really feel is the right medicine for the patient, and then I would say not, well, I don't know, maybe like 50, maybe more than 50% of the time that appeal actually does go through, but sometimes it doesn't, right? So it's just kind of, you know, being an advocate for yourself and really telling the clinician, I would, you know, really like you to appeal this.
And if the insurance denies, then there are patient assistance programs through the companies that can help.
My question, excuse me, my question is about GLP-1s. There are a lot of people, you know, it's available now, and a lot of us gained weight from prednisone and stuff. Can you talk about any thoughts on the use of GLP-1s? I am aquaportin 4 positive, and I was wondering if it makes a difference, like if that matters, if it's a factor.
Yeah, I think there's a lot of data that's now coming out on GLP-1s in multiple sclerosis and generally showing that they're safe, well tolerated, they don't interact with the medicines, and in fact might have some benefits. And so, the weight loss is one benefit, the control of the metabolic system as well is also a benefit, and that helps to reduce inflammation in general. And then there also may be some benefits neurologically beyond that. So I think that's sort of an area that is being explored, and companies that make these antagonists are very interested in that area as well. A lot of patients report reduced fatigue on GLP-1s as well, so that it might be a combined effect. So I think in general, at least in my clinical practice, I think it's fine to combine GLP-1s and beyond immunomodulatory treatments, and it seems to be beneficial and helpful.
I wanted to follow up on Doug's question about the levels of IgG that you should worry about, because I've always been like in the low 500s, one little dip into the 400s. I haven't gone on IVIG, but I also noticed with my last set of labs that the cutoff had been 600 for normal IgG, low end of normal, and now they've bumped it up to 700. I didn't know if that was just a Quest thing or if that's, all across the labs. And so what would be a normal, what would be an IgG to worry about? And has there been a change in what's considered normal?
So different laboratories have different ranges of reference or normal levels. So you can not really compare the test done in one lab with the test done in another lab that has different normatives. The thing is that people practice differently and have different approach when it comes to this question, because there is no standardized guideline how to approach those IgG levels, and when to start thinking about adding IVIG to prevent infections. I can tell how we practice at UNC, but it may not apply to all centers. So in general, we consider the level of 400 something that we need to start looking more closely. But if the patient has a level even below 400 and no infections, then we typically don't recommend IVIG. But if they have a level below 400 with recurrent infections and at least one severe infection, then we start thinking about discussion about whether we will add IVIG or maybe switch to another treatment that will not drop down the IgG levels or will not increase infection risk. If the patient has IgG levels below 150, then we are more proactive in recommending IVIG in that situation. But again, different centers may practice differently, so maybe Dr. Chintis would like to share with us her practice.
Yeah, I think it's, there's not one specific level that we act on and start IVIG in everyone, so you hit a certain level and immediately get IVIG. It depends on, several factors. If you're having recurrent infections and it's low in the lower range, if you're in the 500s, then we would consider IVIG in that situation if you are having recurrent infections. If you are in the 400s and you're not having any infections, we may just watch it and see how things go and only start IVIG if you start to have infections. And then I think beyond that, if it's dropping lower, at least in our center, than below 400, then we start to replace regardless.
Hi, good morning. I have NMOSD. And upon my initial attack, I was placed on Solaris, Aqua P4 positive tested, and very quickly after having Plex, went to like a negative Aqua P4 level, no new lesions. And my question is on the safety and efficacy of switching treatment. So like I know there's Ultomaris out now, other infusions where you don't have to go as frequently, but still have the same coverage. I just want to know what your thoughts were, because I've spoken with my neurologist on it, and for now decided that if it wasn't broken, to leave my treatment alone. But my goal is to, at some point, if I may possibly have durable remission, not necessarily go without therapy, but decrease how often I'm having to have treatment.
Yeah, so I can start, but maybe others have, comments. I think it's fine to make that switch from Solaris to Ultomiris, and it's basically a very similar drug, and the formulation is allowing you to have less frequent infusions. But I would still, if you do switch, and I think it's absolutely fine to switch, I would still continue to be on the treatment long term. So, with aquaporin for positive NMOSD, we do know that it continues. Attacks can occur even in the future, even if you've been attack-free for a long time. So it's very important to continue with the right, with the regimen that's recommended, that's prescribed.
I would just like to add, some patients come to us requesting to switch from eculizumab to ravulizumab because of the frequency of infusions. And then we do that.
And it's a shared decision-making process, right? Like Dr. Dumovic said, I mean, if that's something that's your preference, I think that's more just like a discussion with your neurologist, because that might be important to you, that you want to reduce the frequency of infusions. So.
Thank you. Just to wrap up the Q&A, what could you recommend for wellness overall? We've had other presentations on sleep and nutrition. Is there any last tip you can leave with the people in the room today of something that they can be doing for themselves that may just make them feel better in general, that they could be doing easily on their own?
So I would like to stress out the importance of so-called brain health, which is eat well, sleep well, exercise enough, don't stress so much.
Very well said. That's very well said.
Eat well means eat healthy, nutritious dietary regimen. And exercise is important, not only for improve physical ability, but it can also improve mental health. It can, on a long-term exercise, can make some improvement in neurological function, even if there was no hope initially for some improvement. It can produce endorphins, which are like hormones of happiness. And then when people exercise, they may feel better after that overall. So I think following brain health process and lifestyle is very important in people with NMOSD and MOGAD and overall for all of us.
Yeah, and I agree. Adding on to what Dr. Dumovic said, the other thing that I would say is it's important to maintain your social connections too, because it's been shown that people that are socially isolated are more likely to have neurologic disease. So also, reaching out to your friends, family members, not forgetting about those social connections, that's also important.
That's why we're here today, right? This is a big one. Oh, yeah, let's have Dr. Chitnis finish first, and then if you have one little follow-up, we'll do that.
Oh, sorry?
Oh, I said you could go first, and Nick just had a little follow-up from this question, and then we'll
okay.
wrap
Actually,
up.
I was going to just agree with them. They gave a great summary. So.
Okay. Did you have a follow-up really quick?
Yeah,
Then we'll transition.
really quick. I think my follow-up is just, we talked about eating healthy, but is there a specific diet in NMOSD or MOGAD that you suggest?
I can take that one. So there's no specific diet for NMOSD or MOGAD. We typically recommend what we recommend in MS population. Most often recommended diet is Mediterranean diet. And this is what most of our patients follow. We do have a nutritionist in our multidisciplinary team at UNC. So if the patient has specific questions, then we often refer to nutritionist. You're welcome.
Thank you so much. I just thank you so much for your time today. We know you are all so busy We know how hard it is to get in to see all of you, right? But everyone here today came together to get answers and be with you and learn from you, and you just brought so much information today, so thank you so much. Why don't we give them a round of applause? Thank you.
Thank you. Thank you for having us.
Thank you.
Thank you.
All right, I'm going to have my panelists come up. It was starting to get really cold, but it seems a little better. How's everyone doing with that? Saw a lot of sweaters coming out earlier. It takes a lot of courage to get up here on a panel. And I know it's not easy. I send out these messages and ask people, oh, hey, will you do this? And everyone said yes, though, right away. So I love having new voices for us to hear from. This is a panel that we've repeated a few times because it's really important that we continue this conversation and hear from your peers about what the experience is like on FDA-approved therapies. Just like Dr. Ben Greenberg said this morning, it's remarkable that we have 4 approved treatments for NMOSD in such a short amount of time. And it's also shocking sometimes when we come together in a large room and there's only a few people utilizing them for whatever reason, access or just knowledge. So when we have conversations like this, we can learn about what the experience is like for people that are using the medication, just really the basics. How do you feel? How long does it take? How did you talk to your doctor about it? So we're going to talk about those things. In no way are we trying to sway you into choosing a medication. That is not the purpose. We really just want to share the different perspectives of your peers. And the decision-making is something that you can do with you, your doctor, your healthcare team. But we think it's this room and all of the educational information that PHA has created is for you to be armed with knowledge when you go into your next appointment. Get your questions ready and come in to have a conversation. And it just should help you make those questions. You can call the helpline. We are great at helping you just think about advocating for yourself. We can't give you medical advice, but we can help you think through those questions. So this is a conversation that kind of helps with that too. So I'm gonna just let you each introduce yourselves. So we'll just keep this part brief. So your name, approximately how long you've had NMOSD, and my notes are too small of print, so they're not gonna help me at all. My eyes are getting bad. And if you had one word to describe your treatment journey of where you are today, what would the word be? So.
Okay, my name is Dulima Carrillo. I've been diagnosed since March last year. It's been a year, and I'm stable. Yes.
Yes, that's good.
I feel good.
Stable is a good word.
Yes.
We all like that. That's a great word.
My name's Jessie. I was diagnosed 15 years ago, and I was going to say stable as well, but I have a healthy fear of relapse.
That's fair.
Rachel Alexander, and I was diagnosed in March of 21, and stable as well.
Wow. That's a really great word to have. I mean, that's a word everybody wants to hear, right? Definitely, definitely. So let's jump into what treatments look like for you. So Julie, what treatment are you on now?
Oblisna,
Okay. And how often do you go?
every 6 months.
Okay.
So I had the last one like 2 weeks ago. It was my third infusion. Yes.
And when you go, is it a long infusion? How long?
It's
does it
like
usually
2
take?
hours.
Okay.
2 hours. You know, the only thing is like they put Benadryl on it. It makes me sleep like.
That's a good nap.
Yes.
Yes, that's a good nap. Yeah.
Other than that, I feel good, you know.
Good. Yes.
Yes.
Yeah. Feeling good.
Good.
I know. You always have a good report. She does. It's really, it's nice. So when you started, was the onboarding for that different? Did you have to?
No, when I was diagnosed like last year, everything happened here in Charlotte. Okay, so but I don't have family here, so my family took me back to Florida. So the doctor, my neurology, when he saw the report, he recommended Oblisna. So I started with the Oblisna in May, then November. My third one was like 2 weeks ago.
Nice.
Yeah, I don't try any other. That was the one.
And it's working for you.
It's working for me. I feel good, stable. Like I don't have anything like to complain about it. So.
Do you feel tired or anything after your infusion, or is it more from the Benadryl, do you think?
No, the thing is, I feel like my energy go up to here. Like I feel good, no pain, no nothing. So.
Wow.
Yes.
Great news.
Yes.
Okay. All right. Jessie, so which therapeutic are you using?
I'm on Inspring.
And how long have you been on that now?
I've been on it for about 3.5 years.
Okay. So what was the transition like for you? Because you were on an off-label therapy prior to that, right?
Yes, I was on rituximab. So, like we were talking about with the doctors, my IgG levels had gotten severely low, and I was getting recurrent infections. And my doctor decided it was time for me to switch over to one of the FDA-approved therapies. And we had a discussion about what was available, and I decided that I no longer wanted to have to go to the hospital for an infusion, and Spring is a injection at home, a subcutaneous injection into my stomach once a month at home that I can do myself. And I decided that that would be the best option for me at the time, so.
And it's been working for you, right?
Yes.
Yeah.
It's been wonderful. I don't have any side effects. In the beginning, I had some gastrointestinal side effects, some nausea, some heartburn stuff, but other than that, I haven't had any issues.
So tell me about the process of doing the injection. Did you have support learning about how to do it? Did you start right away at home, or did someone teach you how to do it?
The company did call me at the beginning to instruct me and talk me through it, but I'm also a nurse, so I unfortunately know how to do that. But I did have a lot of support from the company, and you know, they offered me financial assistance if needed, you know, emotional support, all kinds of support the whole way through the process, switching over. It was
That's
wonderful.
really helpful. Yeah. It does help to have that support and know that you have someone to call.
Yes.
I know that you do that. You have that too, Dulima, that you have a patient access liaison that you can call if you need to, right?
Yes.
Yeah. Rachel.
Okay, I am currently on Ultomiris. I started out with, on Soliris, and I was on Soliris for 3 years. So that was kind of like your question that you had earlier. I was kind of skeptical about the change when my doctor presented me with the new medication that had just came out. So I was like, well, let me think about it. So I went home, I prayed, and I thought about it. And I was like, okay, I'll go ahead and give it a try. And I've been on it for a year and 5 months now. So I'm happier, I'll say that. As some of y'all out there that see my Facebook page and my TikTok, like I feel more alive now.
Oh.
I was kind of consumed with Solaris, just always worried about my infusions. Sorry.
That's all right.
Just not having a life.
Because
outside.
you're tied to that, right? You're tied to
Every
it
2
so
weeks.
often. Yeah. Yeah.
And so now I feel like, you know, just going every 2 months is more. I have more of a life now.
Right. Yeah. Yeah, it was a big change for a lot of people. Except one patient that I talked to pretty often said that she missed the visit. Like, that was her social visit, and she didn't want to give up. Like, she was sad to give up that. But over time, she has switched to, it's fine. She can see her people every 8 weeks, right? So what is the process like for you now when you go every 8 weeks? You've had a break, and then is it a long infusion?
No, it's still kind of the same. Like I have my pre-meds that I take, the 15-minute wait, and then the infusion is only like 35 to 40 minutes, and then I have an hour observation. And then I go home and I sleep for about 4 hours, but then after that,
Yeah.
I'm good.
Well, any good reason for a nap, we will take it. In the decision-making process at the beginning for you, you started right on Solaris, correct, after you were diagnosed?
Yeah, I think it was like a month after my diagnosis. I started pretty quick on Solaris. And like I said, it was 3 months, never missed an appointment. I was on it because I just didn't want that experience of like going to the hospital and having to stay, you know, away from my family.
Yeah.
I think I had a 10-day stay, and that was too much for me. So, but yeah.
When you were deciding, was that a conversation, or was it suggested to you? How did you come to the decision? Do you remember?
I think it was just something new, and like I said, my doctor, I don't think we like had a discussion before. She just asked me one day, was it something that I was interested in? And then I'm also a part of the study group, Amaze with UT Southwestern. So, you know, when I switched over, they've been with me every step of the way, like, you know, with the MRIs and extra appointments and stuff to make sure everything is going well.
Well, that's a really good point to bring up, though, because being in the study, it does provide you with extra eyes on you. And I think it's a benefit that some people don't realize to be involved in a study. You have a contact person right away. It's definitely like, it feels like a safety net is what I think, and what I've seen from other people too talking about this. You know, you don't have to fight for the MRI because it's part of the study, so you know you're going to get it and be able to see any changes that are going on. So do you feel like that? Like it makes you feel a little safer?
I do, because they call and they check on me, like, how are you feeling this week? And, you know, it's a check-in, so.
Yeah, that's great. So when you were going through the process of deciding, did you research the medication when you were told like the name or given any kind of information? Did you go and do your own research about it?
I actually went to my Facebook group and I just started reading and asking questions, and so I always go to them first. And, you know, because the first thing my doctor told me was, don't go to Google. And what did I do when I went home? I went to Google, so I thought I was dying. So, but yeah, I had that Facebook support, so.
Yeah, the support groups and the groups on Facebook are great for just interacting, which is similar to what we're doing right now. It's like, has anyone had this? We see these in the group. If you're not in the groups, join some of the groups. Don't ask for specific medical advice, because someone will give it to you, and that's not a good idea. But if you want to just get information on how people are doing on a certain medication, or if they've ever had any kind of issue, it's a great place to just kind of talk to other people that are going through what you're going through without, having to come to an event. Not to hold your question for 3 months and wait till the next patient day. And it helps us when we see questions like that in the group to know what people are looking for, what kind of information people are needing. So I think it's good. Did you get some good responses there?
I did.
Yeah.
Just go check it out.
A lot of support.
Yeah.
A lot of people in the room doing that too. Jesse, did you do that? Did you go back and do some research on the options?
When I switched over to InSpring specifically, I didn't, not really. I kind of trusted the advice of my doctor. I just asked which one he would recommend I switch to and took his word for it, kind of.
Yeah. Well, also there was like your lifestyle choice. You were, I'm not going to speak for you, but there's a sense of control, I think, with that, right? Because you're doing it for yourself.
Right.
So I can see that would be appealing, especially if you're a nurse and not afraid of, needles. Yeah.
Well, who made the decision was my family. At that time, I was like,
yeah, you're in bad shape.
So one of my sisters, she asked the neurology what the suggestions. So he put me on a list now. So I believe.
Yeah, you said that.
I trust
to me.
him.
You trust the.
I
trust your
trust.
team,
Yes.
And you're feeling well. So
Now now I'm learning like more about this.
It's a steep learning curve at NMOSD. There's a lot to learn.
A lot to learn, and to come here, it's more about everybody's different.
Yes.
Everybody's different, and listen to the doctors and everything. Every 3 months that I've been coming to this is different. You heard new things. You are, you are aware about the different things that you can do and learn. It's a learning process every day.
Yeah, definitely is.
It's a learning. You have to learn every day. Also, you have to learn. Well, I'm learning to listen my body. It's really important. Like, I'm not afraid to happen again, but I'm learning like, my toes or my head, or if I have a pain, a different pain, but also I'm going through a menopause. So,
yes,
is NMO or is the menopause?
Right, or aging itself is
yes,
inflammatory. So
yes,
I'm not saying you're aging. Sorry, but we're
the age
older,
also.
so you have that
Yes,
too, right.
So, but it's a learning. It's a journey that I'm going through. Thank God I'm okay.
Yes,
I'm fine.
Okay.
I'm stable. Yes, I can see. I can walk. I'm happy.
That's good. So, did you think that when you were starting your medication, was it what you expected? Did you have fears of changing? And then how was that experience? I guess that would be for Jesse and Rachel because they both switched. But
yes.
There's always a little fear, right, to make any kind of change. Did that match your expectations? Like, how did that go for you?
I definitely was afraid. I'd been on the rituximab for so long and was stable on the rituximab, and the InSpring doesn't work on the body the same way that the rituximab does. So I definitely had a fear that I would relapse. But I didn't, and I'm so grateful for that. And I thought I was going to have side effects with the InSpring, and they weren't terrible. And I'm still working on getting my IgG levels back up. I'm still having to get IVIG every 4 weeks. So still working on that, but everything's been better than expected.
That's good. Yeah, we did talk about that in the Q&A. That's definitely a subject that usually has a lot of questions, and I'm glad that that was addressed today too. Yeah, Rachel?
I had fears, of course. I didn't want to rock the boat. I was doing good. But my doctor also, she reassured me that if I didn't like it, that I could always switch back. So that's what made me. I just went ahead and did.
Yeah, there's like a freedom with that too. Yeah, that is reassuring. That's good. Okay, so we're running low on time, but I did want to give you a chance. We talked a little bit in the getting ready for this panel, maybe a person along the way that helped you through, that helped you remember, or with caregiving, or maybe someone along the way that was part of your care team that was memorable that you might want to talk about, a little story. Is there anything that happened? A funny story? Come on, Julie, you probably have something funny.
Well, my family, you know who take care of me, like my youngest sister.
Oh.
Yes. Even now, I have to tell her sometimes, you're not the oldest one. I am. Because she thinks that I'm a little one. She's always on me like, are you sleeping? Are you worried? You know, always something. But I'm really grateful for them, especially for my family. You know, no words.
Yeah. And they got you from North Carolina
They,
back
yeah,
to Florida.
they decide one day when that, okay, you're not gonna stay here, you have to go back to Miami. And for me, it was really hard because, you know, I had everything here, but I live by myself. Just working, a workaholic person. Well, they decide you have to go. We have to bring you here. So I'm back, you know, it's been not, I don't want to say hard, but it was hard for me to be independent, to be now dependent on them. Like for everything, I spent like 2 months in a hospital and 1 month in the rehab.
And then from the rehab onto a plane, right?
Yes.
It's a lot.
It's a lot. So, but a lot of things, a lot of stories, a lot of memories. But I'm fine, you know, it's a reset on my life. To be workaholic, hyper, to be like, take a day to do things. If I'm tired, I have to take a nap. I'm not working now, so it's hard to not work. But I'm doing other things that, you know, that I always wish to have a time to do it, but I'm doing it now.
Yeah.
Enjoy life.
Take your time.
Take my time. And something happened last year, like I had my first granddaughter. I spent time with her, with my son. It's a lot, but I'm happy. Nothing to complain. I'm really grateful with God.
I'm just very grateful for my family and all the support they've given me. Grateful for Dr. Levy, and grateful for the fellow that first diagnosed me when I had my first case of optic neuritis. And he said, I'm going to test you for this really rare autoimmune disease. I don't think you have it, but just in case, I'm going to test you for it. And came back positive. And, you know, it changed my life, obviously. I'm just grateful that he thought about even testing me for NMO, that it was on his radar. So.
Yeah, because how different would it be if you didn't know when you found out, right? Wow.
Absolutely.
Yeah, it always takes one person in the room to make that call, and that's the importance of education too.
Yep.
Rachel?
I would have to say the same. Family, my husband, my kids. For my husband, he really doesn't tell me no anymore. Um, they all know that if I say we're going here, they know to just pack a bag, let's go, because if we don't, she's gonna go without us. And so, yeah. And then I would say with the Ultimaris and the Solaris, going with the, I guess it's the Lexion, they were really helpful. They walk you through everything. They kind of took care of everything for me. I really didn't. They took that off my plate. So I didn't really have to, they stayed in contact with the infusion people, the insurance, all of that. They pretty much did everything for me.
That's a heavy lift,
Yeah.
too, to have help in those areas where it feels so unfamiliar if you've never had to do that before. Yeah, I know that we're very grateful for our partnership with Alexion and Amgen and Genentech, who are all here. Please go visit them during lunch that's coming up soon. Yeah. They work hard to provide education and advocacy and then support the work that we're doing so that we can help just bring that education to the patient population and caregivers so everyone can understand better. NMOSD is very complicated, we all know, and it's a steep learning curve, like we said, but getting in there and really understanding will make it better. I think it gives you a little bit of control back, similar to the choice that you made with your treatment. You can walk into an appointment feeling like maybe you're the smarter person in the room sometimes. Probably not if you're in their offices back there, or with Dr. Chitness or Dr. Greenberg. But certainly sometimes, I know you all know this, in a primary care office sometimes you'll have someone say, oh, I've never heard of that, I don't even know what that is. And you think, well, you could have Googled right before you came in the room, so you didn't have to say that. So we're doing the work to do the education for ourselves and for our loved ones, and we're glad you're here today. Every one of these journeys, like we talked about, is very unique. I don't think there's any two cases of NMOSD that have ever been the same. I've talked to thousands of people, and everyone has a unique journey, but we are all connected because of this disease. And I'm grateful that you're all here today, and I'm grateful that you guys were courageous to come up here and share your stories. So thank you so much.
Thank you.
All right.
Whew, what a morning. So much information. I just want to say before we break for lunch, please visit our booths over here for Lexion, Amgen, Genentech, and SNRA. They have some pretty cool swag, actually. I know my wife can't go by and not pick up a tote, so we have totes coming out of the yin yang at home. But, and the kids with chocolates, and so, anyway, but they're not only just great people, they're amazing advocates for you. And I've known this over years of working with all of them. So anyway, please have a great lunch. It's a Southern soul food lunch, so it's gonna be really good. And we'll be back at 1 o'clock. So thank you.
My name is Vilma Carmona. I'm originally from Puerto Rico and I live in Hollywood, Florida. I have been living with NMOSD for more than 20 years. Along this journey, I started looking for ways to help myself heal emotionally, mentally, and physically. While we know there is no cure for NMOSD, because living with NMOSD means learning how to live with uncertainty, stress, and pain. Even while living with pain, I still wanted to find happiness and peace. So I began exploring mindfulness, meditation, yoga, sound healing, aromatherapy, and other holistic and alternative practices that helped me feel calm and more connected to myself. Over time, these practices became part of my healing journey, and eventually I wanted to help others too. Today, I want to demonstrate the practice of mindfulness as a tool to help us adapt to NMOSD. The stop technique helps remind me that I can slow down, reconnect with myself, and move forward even during difficult moments. I invite you to try this practice in yourself. Maybe once a day, maybe once a week, or anytime you need a moment to pause. S for stop. Pause what you are doing, even for just a moment. Give yourself permission to take a break from the rush, the worry, or the fear. T for take a breath. Take a slow, deep breath. Then another. Inhale, exhale. Feel the sensation of breathing. Breathing helps calm the nervous system and bring us back to the present moment. O for observe. Notice what is happening in your body and your mind. What are you feeling? What emotions are coming up? What thoughts are racing through your mind? Observe without judgment. Just notice. Sometimes our bodies are trying to tell us something. P for proceed. Then continue, but with intention, not on autopilot. Move forward with more awareness, more calm, and more clarity. I invite you to try this practice for yourself. Maybe once a day, maybe once a week, or anytime you need a moment to pause. Stop, take a deep breath, observe, and proceed. And remember, you are not alone on this journey.
How's everybody doing? Awesome, awesome. So far, so good. Been a great day. And I'm so excited right now to introduce our next speaker, who is
Julie Wells, and she's with an organization called Give an Hour. And I'm just so happy that we decided, with this being the end of Mental Health Awareness Month, that this would correlate and be a great time to bring her with us. Corey and I have had the opportunity to be a part of one of the, I'll say it's a class that helps us with rare disease and being leaders of rare diseases like NMOSD, and how to navigate and help, our teams and ourselves navigate through what we go through. And so with that said, I'd like to share with you and tell you that Julie Wells is a part of, she's going to do the mental health and rare disease and the tools for coping, healing, and connection. And we do this, and she'll tell you, probably about once a month. And it's been helpful, really helpful for me. So with that, Julie.
This is the right mic. Okay, good to go. We'll see. I might get off the stage and walk around a little bit to point to where the speakers are so I avoid them. Either side. Okay, that's super helpful. Hi, everyone. Welcome to Charlotte. Welcome to North Carolina if you've never been here before. I am from North Carolina, so this was a wonderful 2-hour train ride this morning. That is not usual for me when I travel, so happy to be in my home state and so happy to be close and in person with my dear friends Kim and Corey, who have just been fantastic partners to work with. This community is so lucky to have both of you. So thank you for the work that you do every single day to make other people feel accepted, loved, and heard, which is the most important thing. So those are the people. Those are the real people right there. All right, let's see if we do this fancy stuff. Okay, so just a little context. Who was given hour-wise? Julie up here. What's their connection to rare disease? I just want to let you know that we've been a mental health organization for over 21 years in the U.S., and we actually started in service of the military, actually, because we were concerned about how military folks and their loved ones weren't able to find resources, mental health resources that spoke to their lived experience that felt safe. So we basically created a shadow network of clinicians outside of behavioral health who agreed to give an hour a week for a year to see individuals who came to us for care that was free and confidential. Over the years, we've continued to expand out the populations that we pay attention to. And the way that we got into rare disease work specifically was actually an industry partner came to us and said, every time we talk to a patient advocacy group across rare diseases, the number one thing that we hear that people struggle with is mental health. And we don't have any resources that feel very specific to the rare disease community. So that's what our journey has been for the last 5 years, is to really listen and learn, sit in each community that we serve and understand what the disease progression looks like, what the diagnostic journey looks like, what the treatments and therapies look like. But overall, what we've seen as we move in different rare disease spaces is that a lot of the mental health impacts are very similar. And so we want to talk about that with you today, not only to raise the issue as an important conversation, but also give you some tools and perspectives about how to pay attention to mental health. Here we go. All right, so this is me. I myself actually have what I now know is a rare heart condition. I had sudden cardiac death when I was 37 years old out of the blue at home, and my daughters found me. Blue. I was very, very lucky to be resuscitated by my husband at the time, who did CPR, and was transferred to Duke, where I woke up a couple of days later, and they said, well, you did nothing wrong, but this is going to continue to happen to you for the rest of your life. So we're going to put a machine in your chest, and you should just go ahead and go live your life like you were living it before. I was like, wait a minute, what? Wait a minute, hold on. They wanted to tell me everything about the machine that was going in my chest. The only thing I wanted to know was, can you connect me with someone who's had this happen before that I can talk to? And I don't mean like a 65-year-old man. I mean like a mom of young children who has this in their life
Does this mean that I'm sick forever? What's my capabilities? Should I be protective? How do I know if I'm going to hit the floor? And they had no answers either. So the very first thing that I was able to do in terms of my healing journey was to find others who had had that experience. So we actually started a peer support group at Duke Hospital, and that continues to this day. That work, and this is me coming home from the hospital with all of our babies around us, me and my sister. This little baby in the front, this is her in the middle, Oakley. She's my niece at 16. She actually got a defibrillator when she was 13 years old after seeing that she was having a lot of the similar symptoms that I have. My sister also has a defibrillator. She used advocacy as the way to deal with it. She actually won the Teen of Impact Award for American Heart Association. Her first year of getting a defibrillator, pretty important, I know. Yay, Oakley. Yay, Oakley. And I'm so glad she's going to Carolina to study neuroscience. That's my girl. And then this last cutie patootie on the end is my partner, Matt. I'm a caregiver to him. Matt's had several spine surgeries. He's had 2 spine fusions, a spinal stimulator. In March, he just got his neck fused. So I've been on a long journey of what it means to take care of someone who is not able to fully care for themselves, and all of the emotions that go behind being a caregiver, which I know many of you share. So let me just get a look at the room. First of all, if you live in East Coast time, raise your hand. Okay, Central, Mountain, Pacific folks. Oh, where are you from? Okay, great. Thanks for being here. How many of you all are living with a rare disease? How many of you are caregiving for someone with a rare disease? All right, many of us sometimes wear both of those hats too, right? We have a medical condition, and then we're also caring for others. Well, let's talk about specifically, what are some of the mental health impacts of NMOSD? What are some of the things that come along with the physical journey of having this rare disease? So first thing I always have to do with any audience is let's level set. Let's just talk about the stigma behind mental health. First of all, mental health doesn't always mean bad stuff. Oftentimes when we say that, oh, I'm concerned about her mental health, you're inferring that anything mental health-wise might be dysregulated or not good in some way. But mental health is just a part of being human. It's all of the experiences. It's not necessarily something bad. Everyone around you is touched by mental health, both their own and the others around them. And what we find to be really exciting at Given Hour, even though we do have 3,500 mental health clinicians in our network, we believe in the power of non-clinical care as much as we believe in the power of clinical care. And when we say non-clinical, what are the things that you can do by yourself? What are the things that you can do with community that can have incredible impacts in the way that you feel every single day? Not just in your body, but in your brain. So I also want to just mention about trauma, because what I've really found over the years of working with rare disease communities is a lot of the stories that I hear qualify clinically as examples of trauma. So what is that? So trauma is not the event itself. We talk about this a lot. Trauma is what's left after something has happened, right? So it is the emotional or psychological or the physical impact. When my partner came out of his first spine surgery, they did not manage his pain well. And that caused him to be in incredible distress. And from that experience, he is now traumatized. He's been traumatized by the medical profession, right? He feels traumatized that he's not listened to, he's not believed, he is not validated, he's not going to be helped. So when a medical issue comes up for him now, the trauma of what happened to him in the past impacts the decisions that he makes today about his health. Makes a lot of sense, right? Our previous experiences inform how we respond. Someone who has been traumatized means that they are having some type of emotional or physical response that feels overwhelming to them in that moment. It feels like it's coming over them. Sometimes people don't even know where it's coming from. I know that, I will have waves of panic that come up in my life. And I'm like, what am I doing right now that's making me feel this way? I'm not even thinking about anything that's stressful to me. But it might actually just be residual panic from a conversation I had 2 hours ago about an upcoming appointment, or my doctor sending me a note, and that I, in the moment, felt like I handled okay. And 2 hours later, my body's in a state of panic because I wasn't able to emotionally process it, but my body was still going to process that trauma. It's also important to know that two people can go through the same event and have different emotional responses to it. And a lot of times that comes from the previous experiences they've had in their life. So if this is the first bad thing that's ever happened to you, like really, really, really bad that's happened to you, you may actually be more resilient than someone who's had many, many, many hard things happen to them in their past, because when you're re-traumatized with a new event, it often brings up all the feelings of other traumas that you've had in your past. I worked with a dad in the UCD community who is such a solid rock. Man, he is such a great dad. 3 girls, he and his wife are just people of faith, just working really, really, really hard to help their daughter who is living with a really challenging medical diagnosis. And he has been the one to be the emotionally strong one. She had an incident at school where she had a behavior change and her seizure manifested in a different way. Within a week, he attempted suicide. And his wife reached out to me. I knew them. And she said, I don't understand. Like, we've had so many harder things than this happen before with her. Like this was just something moderate. What's going on? And so as we continued, as I consult with the psychologist that we consult with, what we really understood is that, I'll call the guy Josh. Josh had actually had diagnosed depression when he was an adolescent. He had actually had some thoughts of self-harm as he went into college. Through his marriage and having his kids, a steady job, even through some of the traumas of the diagnosis, he was able to manage and maintain. But something about this specific incident re-triggered him, and he all of a sudden was having the same emotional struggles that he was having much earlier in his life. So trauma means that sometimes people's behaviors don't line up with what they're experiencing in the moment, and that can be really confusing. But I do want to say that some people can be under intense stress and they don't experience it as a trauma, and other folks can experience a trauma and feel like it's not a big deal. I do want to say like a little context note here about the word trauma, and then I'm going to get off it, I promise. I do think that right now we're in a moment, especially with our young people, who are very willing to claim trauma and their mental health challenges, which has been a beautiful thing in terms of stigma, that we want to talk about mental health. But I do want to acknowledge that the word trauma is sometimes overused. At Given Hour, we talk about big T trauma and little t trauma, right? It might feel like trauma to you if your child doesn't get into the preschool that you want them in, right? Because you think it's going to change everything about their life, right? It's a very different thing if you can't get your child in to see the doctor that they need to see, right? That's big T trauma. That's the way we see it. But again, it's all about perspective of what people have experienced before and the language that they use to communicate about mental health. And there's a tremendous amounts of points within a rare disease journey that, again, clinically mark all those check boxes for trauma. Many of you have experienced extended diagnostic journeys. There's so much complexity in the healthcare system. We know that there is not just the grief that you experience at the time of a diagnosis or a realization of a change of capabilities, but there's a lot of anticipatory grief in rare disease too. What's coming, what's happening. I see this a lot with newly diagnosed folks who are trying to kind of get their feet underneath them and learn as much as they can. And sometimes when they meet patients and caregivers who are further on their journey, it can push them into anticipatory grief because they see the changes or they hear the stories and they have a different realization of what this life is going to look like for them. And so there's a lot of points in time where the rare disease journey can be deeply emotional. And I want to, level set you all around this issue because Emotional pain isn't just in your head. It comes out in your nervous system. It affects your overall health. This is ultimately what we're working at, given our in rare disease, to really amplify, is that your physical health is not separate than your emotional health. If you want to get the best out of the therapies that you are trusting to help the physical manifestations of your illness, you have to also pay attention to where your mental health is, because that's going to impact a lot of times how your body responds to the helpful things that you're trying to do. We know people that are highly stressed, for instance, who are maybe also exercising and maybe also eating all the right things, have a more difficult time losing weight than people who have less stress, and they're doing the same behaviors, right? So the way that we think mentally absolutely impacts the way that our bodies respond. And just keeping it real, this stuff's hard. This life is hard, right? And not hard like I feel so sorry for you, just like acknowledgement, like it's hard. It's a different life than most of the folks that you live around have to live. You have to think of different accommodations for yourself. You have to have different considerations around your needs or your loved one's needs, and that can create an experience that does carry a lot of stress. And each stage of the journey has its own unique emotional needs, right? It's very, when you get that diagnosis, there's one piece of the puzzle. When you start to move into rare disease and you're trying to find the balance between what can, what can't, what's changed, what do I need to adapt, who did I see myself as being, who do I have the capability of being now, that can come with a lot of emotional activation. And then when I work with caregivers, maybe who have been caregiving for their partners or their children for a very long time, long-term management becomes the key cornerstone. What's going to happen with my child when I'm gone? What's going to happen to my partner if I get ill? What's going to happen if I get a diagnosis on top of this? So there's a lot of uncertainty in the rare disease journey. But the great news is, you have the ability to make some changes in the way that all of that impacts you. Number one suggestion that I want to put in front of you today is the thing that you can change right now today is the way that you talk to yourself. Self-compassion, right? Self-compassion is so simple, and let me tell you why. Instead of what you would say to yourself, think about what you would say to someone else. So if let's say my friend comes to me and says, I'm going to write a book this year. I'm like, cool, all right, and how are you going to get that done? She's like, well, I'm going to get up every single morning. I'm going to write at least 100, I'm going to write 1,000 words. I'm going to write 1,000 words every morning before my kids get up. Okay, cool. I check back with her in 2 weeks. Hey, Karen, are you working on your book? Yeah, but, I've been getting up every morning. I've been writing the 1,000 words, but I just don't think it's very good. And, I don't know, it's just like I'm doing it, but it doesn't feel great. So, this is probably not what I'm supposed to be doing anyway. I should probably just shelve this. I could use the time in some other way. Would I say to her, you're right. It's a waste of time. Yeah, don't write if you're not going to write great stuff, You're right. You're being a little selfish as a mom. You could get up early and make a homemade breakfast for your kids instead of writing that book. Never. I'd be like, girl, keep going. You got that. You're still getting up. How do you know if it's good or not? You're just washing it through your own brain. You might be saying profound things that other people would find value in. What's important is that you've kept your commitment to yourself, that you were going to get up and do the work. Stay with it, girl. And guess what? If you don't do it one day, it's okay. You can get back on that horse again. But that's not how we talk to ourselves, right? We say the exact opposite. We say, why didn't I do more? Why did I snap? Why wasn't I more patient at the doctor's appointment? Why didn't I remember that the neurologist was at 2:30 and not 3:30? Why did I forget to check my chart before I came in the door? I forgot the cooler to keep the medications. We just constantly are in a cycle of why didn't I do more? And it's not just about the rare disease, right? It's like all the other things that you have going on in your life, your house, your home, your social life. Oh, I haven't called my mom in forever. Oh, I haven't seen my friend in forever. Oh, I'm horrible. These are the ways that we can change it. And the reason that it's good is because people who have more compassion for themselves have the capacity to be more compassionate to others. And this is where there's an intersection in caregiving, right? We're going to talk about how selfish we feel when we care for each other. But self-compassion, knowing what you need, being able to say back to yourselves, it's okay to take that moment. It's okay to walk away right now. It's okay to be on that overnight trip. It's okay to ask someone else to come in. All of that is going to lead you to being a better, healthier, more compassionate person for the people around you. All right, let's talk emotional regulation. Oh, look at that big clock there. That's perfect. So I know I've got 50 minutes. That's awesome. Emotional regulation. Again, what's in control of you? What are you have in your hands? Well, what you can do is you can learn how to manage and respond to the emotions that rise up in you in healthier ways. That does not mean don't feel the feelings. Feel the feelings. Feel the madness if you need to. I'll give you an example of emotional regulation with me yesterday at work. Yesterday, it was my day off. Somebody on my team was working on something that's incredibly important to me. They had given me, felt like a directive. I don't like directives. I don't like to be told what to do precisely, especially by someone who is supposed to be supporting something that I'm doing. So yeah, I knew she had maybe languaged it wrong. Maybe I'm sensitive. I don't know. But I didn't like what she said. I was getting ready. I was on my phone like. But my emotional regulation kicked in because I've learned from years of making that mistake of pushing send and creating conflict where we really don't have time for any. It's really not that big of a deal, but I'm just having my own emotional probably reaction to my own work trauma for many years of men trying to tell me stuff and me saying, don't tell me stuff. Sorry, men, love y'all, but I've had that experience sometimes. I've had some horrible women bosses too, but instead, what I've learned, because when I do what my brain tells me to do, it doesn't have a great it doesn't hurt the other person. It has bad consequences for me, right? My employer sees me as problematic. Instead, I've learned to emotionally regulate, okay? I'm recognizing that I'm activated. I'm recognizing that this is a push point for me. I'm also recognizing that when I've responded in my go-to way, it hasn't worked well for me. So it doesn't mean that I'm still not frustrated or upset. I'm not suppressing my emotions, but instead of pushing send to that coworker, not even a coworker, I instead call my boss. Hey, Jess, I need 5 minutes to process before I put this through. Can you help me? This is how I'm feeling. This is the context I'm getting, which was so super helpful because she was like, oh, yeah, I told her to push us to get things done. I was like, oh, well, there's the problem. That's not going to work with me. Pushing me is not your job, I promise. So let's relanguage that for her so she doesn't make that mistake again. But emotional regulation, like nobody else interceded there, right? That was just me recognizing parts of myself that have not served me well. I can still feel the feelings, which were valid, but the ways in which I responded to it were different. So these are things that you can pick apart for yourself in ways, what hits me? How do I react? When I react that way, how do others respond? Is that the response I wanted? Is there a different way I could react to get to the response that I want? Does that make sense? Yeah, it sounds like years of therapy, doesn't it? But there's a lot of self-help books out there too. There's also fantastic things, like just like you guys were just doing the stop, that was beautiful. Who's the person that was in that video? Is she here? Blessings on her, right? Like, what a beautiful job. She did a great job. This is very influenced by that same kind of mentality and modality, right? Here are the things that not just are a good idea, but that we see have real impacts on the parasympathetic nervous system. This is why you hear people doing these cold plunges all the time, right? Because there's really science behind it that tells you that that really does help with your emotional regulation. People that get mad and they got to go take a walk, that rhythmic movement of your arms and your legs is actually resetting your brain in a way that feels calming and soothing. Extended exhales, I do this kind of automatically now. Like people around me, will say, "Are you okay?" Because all of a sudden I'll just go, it sounds like an Eeyore, you know, like, which sounds to others like, are you good? I'm like, I think my body's just naturally resetting itself, you know? Like maybe I just came out of a meeting and I'm just like exhaling, right? Like I just find myself doing that. And I guarantee if you really think about the ways that your body responds, you probably find yourself doing this whether or not you realize it. Sometimes I'll wake up in the middle of the night. I know this sounds crazy, but I've told this story before and other people have been like, I do that. I will wake up in the middle of the night sometimes and I'll be rubbing my arm like this. And it's some type of self-soothing thing that I've done. I've had people in the audience before say, I rub my feet in bed. I'm like, okay. I've since then actually seen videos about people keeping their arms above their head as a way to regulate their nervous system. So I was like, oh, my body is showing me what I need to do. So if you're feeling led, if you're the kind of person who's like, I need to get outside, or I need something really cold to drink, or you know what, I do that with gum. If I feel anxious, I'll chew peppermint gum. There's something about that really just helps me come back into myself. Think about, just notice for yourself how that works. All right, be honest. When you think of the word self-care, or the what do you call it, a combo word, two-part word. What do you call self-care? What is that when two words are hyphenated word? Hyphenated, two words. When you think of self-care, do you think of the word selfish? No? Well, y'all are evolved. I hate the word self-care. I think about bubble baths and getting your nails done and going to the beach for a weekend, an Instagram post of your lovely life. We have a very self-care society right now, right? Where it's like, oh, look at me getting my $7 coffee every morning. You know, like, look at me. Yeah, I just can't work today because I just really need to care for myself. Like, I have so many negative connotations coming from a farm family, right? Where you work all the time no matter what. I was just telling my coworker today, I don't think I've taken a sick day in 3 years. Like, I don't even know that that's a thing. But I do know that self-care is imperative, and I think there's a different way that you could think about it. But before I show you that, first I want you to think about, do you only practice self-care when you're at your breaking point? If so, that's not self-care. That's called collapse, right? I do that too. I work. If I'm not at work, I do really, really physical work on my farm. So if anybody calls me on a Sunday and says, what are you doing? And I'm like, I'm laying in bed watching Netflix, that means I've collapsed. That means I'm not just saying like, oh, I'll sleep in today, and that means I physically can't go anymore, and my body has just said, get in the bed. That's not self-care. Sometimes I find myself also allowing myself self-care if I earn it. Anybody done that before? Yep. Yes, I'm going to do that face mask tonight, but only after I do the dishes and answer all the emails and make sure that the lunches are packed tomorrow and I have washed my bed sheets. You know, like you just put like 15 extra things in front of it to be able to earn that, right? That's been modeled for us, many of us in our histories with generations that have come before us. For those of you who are from the South, I can tell you there's a idolification of the martyr woman, right? Oh, she just did and did and did for others. All you ever saw her do was cook for others, or she'd go over and talk to grandmama, all right? And now you think of the physical picture in your mind of that woman, right? She's usually overweight. She's usually crunched over, right? She's got her own physical stuff, right? Like you can see the manifestations in the women who have cared too much for others and done very little care for themselves. And yet they're kind of idolized. So it's very hard to work against that. However, let's change it. If you reimagine self-care as self-preservation, that has a different connotation. There's a difference there in understanding that self-care isn't an option to get to when you can. It is a part of your daily need to be able to show up for yourself and others in the way that you want to be the best version of yourself you can be. What I have found for myself in terms of self-care is that I need to make sure that I have my foot in one or two of these domains of self-care practices. So for me, it sounds crazy, but financial self-care is a big thing for me. Like when I get like busy or stressed out, it makes me feel good to sit down and do my bills when I have money, which I used to have a little bit more of. This year as a caretaker with no second income, that has not been my happy place anymore. Paying my bills, my boyfriend who grew up poor is always like, you're that crazy person that gets her mail and opens it. Who does that? I'm like, why wouldn't you want to know the due date of your bills? He was like, because you don't have any money to pay them. I'm like, why do you want to know that? I'm like, oh, I get that now. I learned that this year, what that feels like. But I know that I need to diversify. For me, so much of what makes me happy is being outside. And my self-care and my self-preservation literally means that when I stop work on my computer, sitting at home, I change into my boots, put my hair in braids, and I walk out my back door into my backyard where I might spend 10 minutes, 20 minutes, 2 hours, or 5 hours, depending on how much energy I have. It doesn't cost me anything. I don't have to go anywhere. If I need to change my plan, I can, because I've created a self-care practice that is accessible. It doesn't mean that I have to have money. I don't even have to have a car that works. I can literally feed my soul in that way. However, I can't do that when I'm on the road. Right? I travel all the time. Corey knows. Like, I'll be gone for the next 3 months on the road. I can't walk into my backyard. If I only had one domain of self-care, then I'd be in trouble. So instead, I've really trying to build in more of the mental, more journaling, more reading. That's what I've told myself. I take my sewing on the road now. Oh, I'm going to sew while I'm on the road. Oh, this is when I'm going to get my reading done. Oh, I'm going to make all the phone calls to all the friends I avoid when I'm at home all the time, because now I'm sitting in a hotel room. I'm going to catch up with everybody. Like, try to readjust so that I always have a mechanism in which I can find my decompression. Again, a lot of different options for ways that people can pursue their needs. I want to just point to this one. Seek and accept help from others. Hopefully this is a skill that you continue to learn. When somebody calls me and says, can I drop off dinner? They don't even finish. I'm like, yes, please. Thank you, that'd be excellent. Yep, I don't even have a sniffle, but you got extra soup, I'll take it. You know, that'll change my whole night. I don't have to think about anything. And then also, I want to say disconnect from social media. I just want to highlight that one. I am only hooked up to one social media. I only have Facebook. That was part of my self-preservation, is getting out of everything else. But you know when I'm on social media? First thing in the morning, I roll over, get my phone, turn off the alarm, and start looking. Last thing at night, I look. During the day, I never look at social media. I'm too busy doing life to record it and post it. But then I really kind of evaluated that. I'm like, what am I putting in my brain first thing in the morning, you know? Am I raising my anxiety level? Like, you think that you're just like checking in on the world, but the world is crazy. I don't know if y'all have noticed, but the world is crazy. There's rarely something I'm gonna scroll that's gonna make me feel super hopeful first thing in the morning. And that's what I'm trying to hold on to. So I know sometimes social media, though it does feel like a connection space, can sometimes be a space that inadvertently overwhelms you. So it's just good to take note of that too. Ooh, I'm doing good, almost there. So beyond yourself, others can help you on your journey too, and it all comes from connection. We're not connected just because we're all in the same room, right? But I felt connected to you all at lunch, right? I felt connected because we leaned in to each other, right? We asked questions, we looked for similarities, right? We asked authentically, we listened to each other, we paid attention. That's what authentic connection feels like, and that is what we want to pursue. And though I may not see my new friends from Jacksonville every day, I walk out of today feeling like I had a beautiful moment of connection with 2 new people. So connection doesn't mean that you sustain these relationships over long periods of time. It means that you pay attention in the moment, to have authentic connections, and you take advantage of those because they really do feed your soul. There's been a whole lot of research about people the happiest people. Harvard has done, have you all heard about this Harvard study? It's like 75 years old, yeah. And the number one thing, they said, what is the key thing to people having a happy life? And it's being surrounded by people that they feel connected to. Not even loved, connected to. They felt connected to. So how do we pursue that? You know, we crave it in our souls to be connected to each other. And yet, we oftentimes avoid conversations with strangers or conversations with people that we feel we might have short-term interactions with, because underneath it, we think that people are complicated and messy, because they are. We're afraid we're going to get stuck in a conversation or someone's going to say something sideways, and then we're going to be like, God, why did I waste my lunch talking to these crazies from Jacksonville, right? But what they find when they've done studies at Harvard is actually, they did a great, cool study where they put people on a train, and they're like, talk to other people, and let's see how you feel afterwards. And the other group, they said, don't talk to anyone. And 78% of the people that were on that train never talked to anyone every single morning. It was their morning commute, and they were there to focus and get work done. Let me tell you what, if my friends hadn't been with me on the train this morning, my head would have been on my computer the entire time. There's no way I'm leaning over the aisle to talk to the people next to me. Not happening. I'm getting some work done, right? But what they found, 100%, is that the people that had conversations with others didn't feel like they lost time. They didn't feel like they wasted time. They actually felt more energized and more hopeful. So take advantage of those opportunities. And you're already so smart because you're already here. So you all said yes to an opportunity of connection. And this isn't just good practice. There's real science behind this. We know that it lightens the emotional load. We know that it decreases anxiety and depression. We know that sharing stories with people who have similar lived experiences make us feel less isolated, physically and emotionally. And we want to just remind you that small moments of connections matter. Have you ever gotten like that person in your head just comes up in your head and you start thinking about Shannon, like for some reason in your head? Text them that moment. Hey, Shannon, I don't know why. You just came up in my head this morning. Just wanted to tell you, miss seeing you. I hope you and your family are doing well. What I didn't say to Shannon is, we should have lunch. Let's go get coffee. I'll call you tomorrow, right? Because then I'm going to be mad at myself because, like, I really don't have time to do all of that stuff. Though I should, because I'd feel better after I did it. But those short moments of connection mean so much. So think about the time when you've gotten that quick text from someone or that quick call that just made all the difference. It didn't solve anything for you. It's just someone saying, hey, girl, I know that you had a doctor's appointment today. Hey, I know that your son went in to be evaluated. Hey, I remembered that this is the anniversary of your transplant. It's those small things that make you feel connected, loved, and seen. We have this great activity that I think this is one of the tools you have in your resource, Corey, around who supports you. Like really thinking about these circles of support and figuring out where you might need to broaden it out. You might be someone who has a really dense family that you're really connected and close to, and therefore some of the other circles of your kind of extended family or your friends might be really small because you're just like a pack. You and your crew are a pack. And others, come from families where that is not their number one point of connection, and you might see a lot of friends who create the community that is their family. It doesn't have to look one way or the other, but it's nice to consider the different ways that these types of individuals could impact your life. All right, quick notes on this. How are you doing? I like to point out to folks that as we try to engage with folks and have conversations about emotions, we oftentimes don't make it very easy. Because when I walk in the room and I see, what's your name? I'm like, hey, Travis, how you doing? There you go. What's your name, sir? Hi, Nick, how are you doing? That's right, of course you are. Of course you are. The reason we just give very short answers is because it's not a question. In our culture, it's a greeting. It's a way of saying hello. And we've trained ourselves to say hello back by saying, good, and you? I'm fine, thank you. Other cultures have different greetings. Some cultures, the question is, blessings to you and how was your family, right? Like that tells you cultural context about what they care about. In the US though, how are you doing just elicits I'm fine. So that's not enough of a question. If you really want to support someone or if you really want to check in, you got to really go past it, because oftentimes behind what's fine is I'm lonely, I don't want to be a burden, I feel overwhelmed, my feelings are hurt. There's a lot of underlying maybe sadness, anxiety behind the I'm fine. So one of the tools that I've worked on that I think really helps is starting conversations. If someone, you said Nick, right, sir? Yeah, Nick says, I'm good. Then usually for me, I'm going to say, no, really. Like, for real. How are you? You might give me something a little more, right? Like, I'm really tired from the trip, or like, I feel that. I feel that, and I'm so sorry that you're feeling that way. Thanks for sharing with me. You know, like, there's just, but that's not what he's going to lead with if I ask him, right? Because it's not culturally appropriate for us to tell people all that stuff. But I can change the way I ask the question if I'm really wanting to know how you're doing, right? We can change our tone. And then if I'm concerned about someone or myself, but usually someone else, if I see that their personalities have changed, maybe they're more withdrawn, maybe they're more outgoing, maybe there's more agitation or anxiety, maybe they are pulling out of things, ways of communicating with others or participating in community. Maybe you're seeing that they're not taking their medications well, they're not eating well, they're not caring for their bodies in the way that you've seen them in the past, or you hear these signs and symptoms of hopelessness. This is big. Hopelessness at given hour, the way we think about this is a scale in which people that become completely hopeless are the ones that we worry about the most, because hope is what pushes us forward. We're going to end on talking about hope. But if I'm watching people around me and they are presenting any of these changes in behaviors, that's when let's see if this works backwards. Yeah, that's when I'll say, hey, Nick, I noticed you put on your glasses. Are the lights like affecting you? You know, if I know you well enough, like that might be my sign to be like, do you want to go take a break? Can I get you some water? Is there anything that I can do for you, right? I've noticed, you know, hey, I've noticed, Tyrone, that you keep leaving the room. Like, are you okay? You know, or something that we're talking about, bringing up anything, you know, or do you need to make a phone call? Is there anything I can do to help you while you're gone? You know, like, I've noticed in such a gentle way, because it tells people I care about you, I see you, and I'm concerned. All right, final thing, you heard me just say it, hope leads to wellness. We believe it so strongly. And actually, in our first years of working in rare disease, and we would talk about hope, I got some kickback. And I know you do too sometimes in your Facebook groups and patient communities. If someone shows up too hopeful, people can sometimes squash them down. Like, let's not make light of how serious this living with this disease is, right? But hope has to be a part of the equation. And we know that it is emotional whiplash, right? From hope to despair. You can get one piece of good news. Oh, I've got, the clinical trials got approved. And then 2 weeks later, your neurologist is retiring. You know, it's going to be like that constant whiplash within the rare disease journey. And that has to be normalized. You're not going to show up hopeful every day. That's okay. But a persistent pulse of hope in your life is what we believe really leads to healing. It rises when you are connected with others. When we look at peer support groups, this is one of the #1 indicators of increased mental health, is asking people how connected they feel to the others in the group has a direct correlation to how well they're feeling overall. We know hope instills optimism, it builds confidence, it inspires the kind of healing that we all need, also can foster recovery. Again, if my partner who's had a neck fusion doesn't believe that the neck fusion's really going to work, right? And now we're in recovery, and his constant is just like, yeah, we'll see. I don't know, the pain's still there. It didn't solve, the stimulator didn't solve it. The problem, the neck is not going to solve it either. We're not even going to be able to weed through what's physically happening because emotionally, he's going to perceive every cramp, pain, glitch as failure, right? Treatment failure. We have to stay hopeful so that we can actually see reality across the board. And then we love this visual. What I just want to leave you with is just, where are you on that continuum of hope, and where do you want to be? Are you feeling like you're struggling? Do you want to move towards being generally hopeful? You know, some of these practices we've talked about today are accessible to you. Work on the way that you talk to yourself. Take time for yourself. Give yourself a break. Be in community with others. Cherish connections, small and long term. And then you have to really hold on to a sense of optimism that the experience is going to bring you some type of joy, love, connection, relationship. There is a purpose. There is a purpose. And I think when we get to a place where we feel overwhelmed, we can live our lives feeling as victims rather than as authors of our experience. And that's really hard in rare disease because there's a lot of systems trying to put you down and hold you back from living the full life that you want to lead. But we believe so strongly that communities and patient health organizations are the types of places and spaces where people can really grow. So we have all kinds of tools at Given Hour. Patient Health Alliance has a whole toolkit that we've helped them develop that will be a resource always available to you. I'm so excited. I just want to announce that we are going to be having a year from now the first ever Rare Mental Health Summit. So if mental health is something that's really interesting to you, you want to be with others to talk about having a rare disease, caregiving in rare disease, and all the things that it brings mental health-wise. We'll have mental health clinicians there, industry folks there. We'll have researchers and advocacy. We're actually working on a national advocacy agenda around rare mental health. And if you want to get in touch with me, or you can't capture this now, Corey and Kim, Dan also knows how to get in touch with me. Please reach out. I'm always here to support you. I'm so grateful for the time I had with you today. I'll be on the panel later, too. Thank you.
Hello? Thank you. 3. Is it on? Oh, it is now. Oh. Do we have enough chairs?
I think we're good, yeah.
Okay. I'm sorry. Remember I said I counted the number of people on all the panels 12 times today at least? Do we have enough chairs?
Yeah.
All right. Well, welcome Chrissy from SRNA. She's going to moderate this panel. It's going to be on peer support, so take it away.
Yes, thank you so much to PHA for inviting me to moderate this panel. We're excited to be here, and this is a really important topic, peer support in rare disease. This panel today will talk about connection and how it becomes community when lived experience can be translated into knowledge, support, and hope for others. And we'll explore why peer support matters, what healthy support looks like, and how each of us can decide what level of involvement feels right. So to start off, I'd like to invite each of our panelists to briefly introduce yourselves. Just tell us how long you've been involved in peer support group leadership, and what motivated you to become a volunteer and step into this role. So you want to start, Julie?
Sure thing. Well, y'all know me now. You just have to listen to me for an hour. But I will say one of the tenets of Give an Hour is to help others create their own peer support responses. But we also run, I think we're at 28 groups a month right now. So we have a lot of experience doing trauma-informed peer support, which is our model. I also facilitate peer support for 3 groups and train up others to do the same.
So yeah, Jody, would you like to introduce yourself?
I'm Jody Arminio. I run a support group in Georgia, specifically in the Atlanta area. We meet in person and also online. And you want to know how I started, or?
Yeah, just what's your background in this community? And
well, my background is I was a patient. 2011, diagnosed with NMO, and then attended my first Guthy-Jackson Patient Day in 2013, and listened to a speech on advocacy, and so left that one, met another patient in the Atlanta area through UT Southwestern's working with Martha Mann and taking blood draws, and she let us know that there were even more people in the Atlanta area with NMO. So we decided to start the support group, and so that started in 2014 at the Shepherd Center, and we've been going ever since. And I had absolutely no training to be a support group leader other than being a patient.
Great, thank you. Doug and Holly.
So, hi, my name is Doug Kirby, and this is, well, I'll let you introduce yourself.
Holly.
I was diagnosed 9 years ago with aquaporin 4 positive NMO. I think we attended our first Guthy-Jackson conference in 2018, I think. And I've been asked that question a lot. Why did I begin? And I'll be honest with you, I'm not exactly sure. I just felt like there was more that I could be doing. And the Guthy-Jackson were asking for people to join their advocacy group, and I signed up and interviewed with Corey, and then Holly and I both got involved, and at some point I got asked to co-host the men's group, which I've been doing for several years now. That's how I get to know people like Travis and Robert and others, and it's been a real pleasure to do that. And then Holly and I wanted also to be active and engaged with SRNA, so we asked them if we could do a patient support group. This was during COVID, so it was all virtual, and still is, although I think we've got enough people in the Utah area, we could probably get away with doing a couple of in-person ones. We've been doing that for 3 or 4 years now, and enjoy that a lot, and we'll talk more about that, I think, in a minute.
And I'm his caregiver, and we do it together. It's a we.
Thank you so much. Yeah, so to start us off, Doug and Holly, this is, I guess, for both of you, you lead not only a community support group for SRNA, but you each lead specific support groups for PHA, the men's group for you, Doug, and the caregiving and care partner group with PHA. So can you each talk about why that specific using, having specific support groups for, men or caregivers is important, how that differs from like a general support group?
Yeah, I'll talk about the men, and then you can talk about how that differs in the caregiver support group that you support. So you would think that because it's a men's group that we get together and talk about men's stuff, and we do, but I can't tell you what it is because it's a secret. No, we really don't. We get together and we talk about all kinds of things. And, occasionally we'll slip and slide into things that are maybe we wouldn't talk about if it was a mixed group. And we can talk about those things and be very open. And it's a safe place for men that have just been diagnosed and are going through some men kinds of things as a result of being diagnosed. They can come in and they can talk about those things and be connected. You know, I guess one of the words for today is to connect with people who know what they're going through and feel the same way. But honestly, we probably 2/3 of our time is just talking about stuff. And maybe 1/3 of our time we talk about things that we've learned at conferences or other things that we know, or new treatments or things that are coming along. But it really is just an opportunity for men to come to a safe place where they can have a conversation and feel connected.
Caregiver support group. Shout out to Jesus. He's awesome. And the thing that I want to say about that is, as caregivers, we need support too. And I think we talk about that a little bit later, but it's a great place to feel important and that we matter too.
Great, thank you. Yeah, so these experiences, I guess, in these different types of support groups, have they taught you anything about how there's different needs for different types of support for different groups of people, did you say?
Yeah, absolutely. And I think there's a great overlap, like this meeting today, right? We can all come together and support one another, but there are those edge cases that require that maybe sometimes we get together with somebody who has a better understanding of what you're going through specifically because of your gender or maybe your culture or different kinds of things. And there's probably a number of those.
Yeah. Yeah, I totally agree, and it's great that you're able to lead those specific support groups and have that space to go over those different types of support. So Jody, you've hosted the Atlanta support group, both virtually and in person for many years. This for both Guthy-Jackson and now PHA and SRNA. So you give so much of yourself, and I know a lot of people in both communities have really been impacted by your support. So how has showing up for others changed you?
Well, we talked about this a little bit earlier. I ran it by my husband too. Has it changed me? I don't think it really has, but it came up at a point where I had just lost the job I'd been working at for 35 years, and the company closed down, and I was trying to find another job, but wasn't working out, and so this provided me with another outlet for those skills that I had developed while working, which, just wanting to be around other people that I could relate to and what I was going through. And so we were able to spread the word through Martha Mann and through the different MS centers in the area. And we did we met in person up until COVID, which did introduce us to Zoom. And thankfully I had Travis, who knows AV inside and out, because I was totally lost with how we were going to do that. But so we were able to keep it going. So I don't think it's changed me. It's just brought out more skill set and it really kind of leads itself. I always try to start out with a little bit of an agenda, but it quickly goes off the rails and in other directions, and it all depends on who shows up on that particular meeting. So,
yeah, I think for some people they're well equipped already to just kind of step into that role, and it sounds like that was you, that you were kind of meant to be a support group leader in one way or another. So,
well, when you talked about talking, I'm the person that embarrasses my kids by talking to people in the grocery store line everything, or waiting in the amusement park lines. And so it's just always been kind of easy. I enjoy listening to people. I enjoy listening to their stories. And people that come to the support group always have a lot of great stories.
Great. So, and as a follow-up to the last question, what have you received from the community while serving it?
I think a greater empathy, because I was so lightly affected, because we caught it early. It's given me a lot more sympathy and empathy for other people who haven't been as lucky as I was. And then also I've been able to translate that to people outside of the support group, because as we age, we're all running into, my friends, my family members are running into situations where they're having to battle the medical community, and they're having to battle disabilities, and I've got experience in that, and so I've been very happy to share that with them and kind of guide them through it. So.
Yeah, that's great. So in addition to leading support groups, you are also a Peer Connect leader with SRNA, and that is a one-on-one support program. So what would you say is kind of the difference and the different benefits that you see for peer-to-peer versus support groups?
Doing a peer-to-peer is very rewarding, because in a lot of cases, they are people who are very isolated. I have one who's in a nursing home. I have one who battles situations with her family. They don't really believe that she's as impacted as she is. So it's probably a little more emotionally invested in those people, and it does take a little more out of me when after I've been dealing with them and talking with them. But we try to check in, every couple of weeks and see how they're doing.
Yeah, I imagine it's a very big impact in their lives that you're making. So.
Well, for some of them, it's the only person that they know that has their disease or something similar.
Yeah, it's amazing that you're willing and able to do that. So thank you.
I get a lot more out of it than I put into it.
Yeah. Great. So Holly, this is for you. Caregivers often carry invisible weight while supporting everyone else. What happens when caregivers finally find a space where they don't have to explain themselves?
The caregiver support group is amazing, but it took me a while to go. And Jesus was awesome. It's okay, come when you're ready, it's okay. And I appreciated that, because I didn't feel pressure, but I knew that I was welcome. But it took me a while, because I was still figuring out what life was. And Doug needed a lot more help in the beginning than he does now. And so I was over my head and trying to figure it out and trying to figure out all the things. And then I finally went. And the only times I miss is only because I can't go. In fact, that's my support group is this day. Remember, my support group is this day, because it builds me up. It makes me feel like I'm important, that I matter, and I am not invisible. I have the song, The Wind Beneath My Wings, by Bette Midler. The first line is, "It must have been cold there in my shadow." And it was lonely. Doug slept a lot, and I didn't know what I was doing. I was figuring it out. I was sole caregiver, and I felt very alone. But now I feel supported, and I feel like a part of a family with all of you. But as a caregiver, I have support as well, and we support each other. We talk, like Doug said, we talk about life, not just caregiving, but we also get to talk about caregiving and the things that we do and that can be tricky, but can also be very rewarding. And it's a great thing. Thank you, Jesus, for encouraging me to be there.
I should just add, it was the medications that made me sleep all the time. I don't do that anymore.
Thank you so much for sharing, and that it just really does highlight the importance of care for the caregiver. We need to be doing more to support that community, and it's amazing what you all put into this work. So thank you. So there are so many benefits, right, to peer support, and it can generate a lot of healthy conversations and helpfulness to each other. But there's also some boundaries and some guidelines that you kind of have to adhere to in a support group, so that you're not turning something great and positive into something that can be potentially harmful. So what does healthy peer support look like in a rare disease community, and what are some things that we need to be mindful of in these spaces? Do you want to start, Julie? Oh, yeah. Oh, yeah, let's start with Jody.
We tiptoe around vaccines. And then I guess you have to kind of be mindful of somebody that usually a first timer, and we try to give them extra time when they do join the group. But you also have to be mindful that everybody else is there for a reason too, and so trying to limit their time. But then I do try to follow up with them afterwards and make sure that they have my contact information and any way that they're open to getting in touch with me if they had something further that they wanted to discuss. But yeah, the vaccine thing is, you really have to tiptoe around that one.
Yeah. Doug and Holly, if either one of you want to.
Yeah, just a couple of thoughts on that. First of all, everybody wants to know what they should be doing, and we have to be careful to say, this is what I do, this is what works for me.
For me, yeah.
And if we put it that way, that's fine. When Sky was still with SRNA, I don't know how many times I said, Sky wants me to tell you that I'm not a doctor, and I don't have any. I'm not qualified to say anything other than what works for me. Something in that sense. The other thing is that, and this is it's going to be different for every group, and that is balancing the players, giving everybody a time to express themselves and to say something. And I know we're supposed to be sensitive to those that don't want to say anything. I will tell you, the only time we had a group meeting where the person didn't say anything, it was somebody that shouldn't have been there. Yeah. Okay? And so I don't twist people's arm. I don't get ornery with them if they won't say anything. But I don't think we've ever had a meeting where somebody has refused for other than a technical reason to participate. And it's amazing what happens when you get somebody, particularly a first-time person, that starts to open up and they realize that they're not alone and that they can talk in this safe space. And so I probably push a little harder than I should to get everyone to participate, but they do. And as far as I know, I haven't pushed anybody out yet. So you're not going to feel like part of the family if you just sit there and listen. If you don't be vulnerable, if you don't share some of your own experience. And that doesn't happen at first, right, initially. Once they've seen that everybody in the group is going to take their turn to be vulnerable and talk about how they're feeling, then it's comfortable for them to also add how they're feeling. So timing is really important, and making sure that one person maybe doesn't dominate, because that can certainly happen.
I also really appreciate at the very end, sometimes the conversations are pretty heavy, sometimes we laugh a lot and it's just fun. But at the very end, Doug always says, okay, tell me something fun, or tell me what you're doing for Christmas or Easter or summer or whatever, so that we always end on a positive, happy note.
That's a good point. Yeah, that's a great point. And I think what you all, the experience you bring is so valuable, but it's also valuable to know where you can't offer help, medical advice, and if there's ever, something outside of your sphere that you know when to escalate or when to refer out, I guess. So I guess on that note, what are some green flags, so to speak, of a healthy support group? How do you generate healthy discussion? How do you help people kind of experience that trust? Jody, do you want to start?
Well, when you talk about safe spaces, there's nothing like having a real rousing bowel and bladder discussion to really break the ice and make everybody feel like they can talk about anything they want to. We don't really have a set lit, because we just kind of started this from the seat of our pants and just went with it. So we didn't have a set list of rules and everything. But I think everybody understands that it's a private group, and it stays there unless you have permission from somebody else to discuss their situation. And things have been told to me in private that then they bring up in the group. So that makes me feel good that they have felt like they could share that information with the group and they feel safe with it. It is a really good group. Our core group is fantastic, and they are so supportive of everybody else.
Thank you. Doug and Holly, do you have anything to add?
We love it. Like Jody just said, we love it when somebody asks a question and everybody answers. When they share their own experiences instead of waiting for either of us.
The leaders, yeah.
And then they have this conversation and they're helping each other and supporting each other, and it's just such a happy thing. And sometimes we're really tired before support group, and by the end of the support group, we're energized. We're excited. We've had a great time with friends, and it's just a great experience. It really is.
And maybe to lead on or follow on that, I think that one of the signs of a healthy group is when you can step back, particularly when there's somebody new in the room, and the members of the group, the veterans, kind of take over and just grab this lost sheep, so to speak, and pull them in and give them a virtual hug, and you watch that person's face light up, and they get it that they're not alone. And for me, those are my favorite meetings, when we have the veterans there and some new people, and I can watch the change in the new people and how they feel about being there.
Yeah. Great. Yeah. It's truly amazing what that support can look like, especially for someone who hasn't had that before or yet. And then sometimes those specific people go on to lead their own support groups down the line because they were so impacted by their experience. So, yeah. So we know that mental health support can be difficult to find, or there can be financial barriers or a mental health professional shortage. Just finding someone who you connect with can be difficult in that space. So how can peer communities become part of someone's overall wellness plan without carrying the full weight of mental health support? And I'll put that one to Julie first.
Thank you. Absolutely. And thank you for pointing that out. We know that for every 350 people
looking for a mental health professional, there's one mental health professional in the U.S., and that's across the United States. So you think about rural communities, and then if you think about, hey, I actually want a provider that matches my socioeconomic status or my gender preference or my religious preference, it can be incredibly challenging. So what we say at Given Hour all the time, as we are steeped in mental health all day long, clinicians are never going to solve the mental health crisis of our country. That's just an unattainable goal. We have to find ways for us to help each other in a more community-focused, centered way, which makes a lot of sense because we didn't just create peer support. This isn't a new concept. This is how people have survived for generations and generations of connecting with others. I was just in a Bojangles. If you're not from the South, I was just in a Bojangles the other morning. And it was funny because I'd used it as an example, and I saw it. There were the older gentlemen who were all there having their breakfast together on a Friday morning. That's their peer support, right? They don't call it peer support. They don't name it that way. They would never say, I go and have mental health discussions with my friends at Bojangles. But that's what they do. Men who golf together, that's what they do. Women who have play dates with their kids, that we find these ways to be with others who have similar lived experiences because we know that it feels good. So I love peer support so much because I see it as one of the most sustainable things that we can do to increase the capacity of individuals to find communities that feel comfortable having conversations about mental health. A lot of times in peer support groups can get set up where, and you all are doing such a magnificent job, congratulations, but I love that you acknowledge that you're a part of the circle. It's not a triangle. I always talk about that. You're not at the top and everyone's sitting underneath you waiting to learn. Everyone is sitting in a circle together where they share information, power, experiences, and stories. You are putting yourselves in a different space as a facilitator because you hold a little more responsibility. You're a little bit of the admin of what happens. But I think also understanding that those who are in mental health spaces like peer support, they have to consistently have their own mental health checked on as well. And so I hope that you all have team members in the organizations that are supporting you who are leaning in and making sure as well, because if folks go into facilitation of peer support and they don't have their own, if they're getting it from the members of the group, but it is helpful to have one more layer of support on top in case you feel like you're getting into conversations that are testing your own capacity to have mental health conversations. And you always will eventually have someone who shows up in your space super dysregulated, and peer support is not going to be the appropriate place for them. They need individualized therapeutic supports. And so facilitators can see that in how they engage in the space, and then that's why it's really helpful if you're working underneath a patient advocacy group to kind of know what to do next with that dysregulated individual.
The SRNA and PHA have both been very helpful in putting together some webinars for us to attend to kind of watch for those red flags. I think in our group we've been very blessed that we haven't really had a situation like that that we've had to deal with. Everybody seems to be pretty together and coping with what's going on. We do work with a range. We're not just NMO. We're NMO, we're TM, we've had some people with AFM. So we do a wide range of it, but I do feel after going through those webinars that I'm a little more prepared. So I appreciate that very much.
Julie, we heard from you in the last talk that Given Hour and PHA has partnered up to kind of try and bring some initiatives to the community. How is working together to strengthen mental wellness resources working for you? And also, can you talk a little bit more about the mental health toolkit that you helped develop?
Absolutely. Given Hour believes very strongly that we're going to be most effective if we're not trying to bring the rare disease community to us. Instead, we are going to the places where community already exists. And so it's been fantastic working with individual rare disease groups, with Patient Health Alliance, specifically Guthy-Jackson previously last year when we worked all together. We were able to go through 12 months of really understanding, what do you already have? What's missing? How are y'all doing? Are you okay? Everybody's mental health good? Are there policies and procedures that make you worried about having those conversations? How are the resources and tools that you've provided now being received? Do they feel specific enough to your community? And so that's how we continue to refine the information that we help develop or share. Presentations like the one we did today was, a working group between myself and Corey and Kim, figuring out what based on what the community is saying organically, then that's how we create the programming. The toolkit specifically is really exciting because it is those references and resources that you're able to pull that speak exactly to what it is that you're looking for. So if you're a caregiver, there's a lot of information specifically for caregivers. We have information for siblings. We have information about how to find a mental health provider if you're looking for one. Information on the concepts I talked about today, self-compassion, how to respond in a crisis. And all of those, again, they've been taken our mental health expertise, infused it through the experience that patients are having at PHA so that those resources really read and feel real and relevant. So we're really, really proud to be able to co-design and co-develop that.
Thank you so much. Yeah, it sounds like an amazing tool, and I'm sure that more information can be found on PHA's website and Given Hour's website as well. So I think we're getting a little low on time, but I do want to ask the peer support leaders. Not everyone is, willing to jump right into a support group. Some people might be hesitant to talk or even, take that step of joining. I know you said, Holly, that it took you a while to even go to the first meeting. So what would you tell someone who is, diagnosed with one of these disorders and maybe hesitant or unsure of whether or not they should join a support group? Yeah, Holly,
I'll start. Okay. I find that people say, oh, I don't want to go because I don't want to hear all the negative. I don't want to sit in a thing where all you talk. That's not what it is. It's not what it is. It is a positive experience. And yeah, we share what our experiences are. I share what happens to Doug. I share what happened to me. I share all of that. And, but we also share the good and how we feel, and we encourage and support each other so that everybody feels better. We feel better after we leave, not weighed down, and it's a wonderful experience.
So yesterday, I had an opportunity to be on a panel with Gigi and a couple of other people at the MS convention that was happening, and there were four of us, and there's Gigi, and then there was the founder of the Stiff Person Syndrome, who was very well spoken, and then there was a young woman, or I guess she would, got to get away with that. She has grandchildren.
Younger than him.
Younger than me. Her name was Amy, and this was the first time that she had done this, been on a panel, let alone the first time she'd ever met anybody else with a rare disease. And we chatted for about half an hour, I think, the four of us before, and Amy did a tremendous job, and at the end she started to almost cry, and she said, I can't tell you how thankful I am for this. And I didn't try to pin her down on that, because I think what she meant when she said this, it was the opportunity to be with other people that were like her. And that's what I would tell, that understand her. I think that's what I would tell a new person is, just come. This isn't like, AA or something like that. You don't have to confess your sins and do whatever. We're just going to come and we're going to chat and we're going to get to know each other, and you're going to find out that the isolation that you're feeling is going to go away. And wouldn't you love that? So I think that's the way I would approach that. And I think what happened yesterday, unintentionally, by the way, I think was just really a good lesson for me.
I think the way it happened with me was kind of dipping my toe into the Facebook groups to begin with. And because you can read all of that and you don't have to participate and you don't have to ask questions. And now Facebook even has the opportunity for you to go in anonymously and ask your questions. So I think dipping into those Facebook groups is a good way to start getting involved. And then if you can find a support group, as I said, we met first strictly in person, and then we're able to expand it through Zoom and everything to a hybrid format. So it does allow more people to participate, and they can participate as much or as little as they want to. But that opportunity to find out that, somebody else has that particular symptom or somebody else's, and what they're doing about it. Those are questions that your doctor really can't tell you. He can tell you what he's prescribed for other people, but he doesn't really know how effective that's been. So just to be able to bounce those ideas off of other people that are going through the same thing that you're going through.
I just wanted to say too, I feel it, and I tell others, anytime someone hits that button to get on that first call, they have made such a brave, bold step. And I know as a facilitator, like it sounds like you do as well, I really try to honor that and greet them of like, wow, this was a big deal. It is, particularly in virtual environments, it's so easy just to skip it, right? I'm not going to do that. I don't know these people. I don't know what it's going to be like. So honoring the folks that make those first reaches, and I think create environments that feel very welcoming. I've worked with groups before that want to start with a bunch of rules, what we're not going to do, what we can't do. I'm like, let's celebrate the fact that they pushed the button, and let's just sit together for a little while first. Yeah, it takes a lot of bravery. It's such a beautiful, welcoming community, but we do have to acknowledge it's really hard for people to make that first step forward. And sometimes they circle around it for quite a long time before they actually join.
So it's okay, I don't have a lot of rules.
Don't have any rules.
Well, thank you so much to our panelists for joining us and for the work that you do in this community. We are so grateful. And this is I want everyone to know there is a place for you in the community, whether you want to, come to the occasional event, join but not really, participate too much, or, lead a support group, or, just kind of volunteer where you can. There's no right or wrong way to be involved in community, and if you'd like to participate in something like a support group or any of the other programs that PHA or SRNA or some of our community partners like Give an Hour or the MOG Project, what the programs we do, please reach out to us. Please don't hesitate. Or if you don't even know where you might want to, where you fit in, it's a conversation we're always willing to have. So thank you all so much.
Thank you.
Great job.
Oh, so we have a 20-minute break. Yeah. Yes. Did you guys want a photo?
Getting diagnosed with NMO at the age of 15 was something that was difficult for not only me, but those around me to understand. The life that I had previously known, participating in extracurricular activities, having a group of friends to hang out with, going out, and simple normal teenage things all changed when I became sick. People do not know how to cope with young people getting sick. So there were many people in my life who cut me off and completely distanced themselves from me. I became isolated alone in my bedroom, only going out for doctor's visits or family outings because I was in too much pain to do much else. I was put on medications that changed my appearance and my mood, resulting in a deep feeling of loss and depression as I was grieving over the person I have always known. I could no longer recognize myself. Mental health is something that is so significant, but something I felt was very overlooked upon my diagnosis. All of the attention was put on stabilizing my spinal cord and my brain damage, but there was a lack of acknowledgement for what these treatments, these trips to the hospital, and the side effects to the medications were doing to my young mind. As we continue to make strides in NMOSD research and education, I hope that we can continue to validate the experiences of patients of all ages. Though it has been years since my rare disease journey began, I am still dealing with issues from my past today.
All right. Thank you, Jesus. Okay. Then we, yep, thank you. You got it. Okay. Right. Oh, you're good. All right.
Hello, everyone. Oops.
Oh,
Hello.
there we
There
go.
Hello, everyone. Next on the panel, we're going to have a subject called, let me see, where is it? I bended these too much. Representation and inclusion from clinical trials to community. It's going to be moderated by Gigi, and we have with us Kim. How are you, Kim?
Fine, thank
And
you.
Dr. Diaz. How are you, Doctor?
Great.
My name is Jesus.
All right, thank you, Jesus. All right, so thank you all for coming back after the break. So when we talk about representation and inclusion, we often think about who's in the room, but inclusion goes far beyond that. So it means who has access to research opportunities, who receives information in a way that they're able to understand, who feels welcome in community spaces, and whose voices are shaping the future of care. So today's conversation is about how we move from intention to action, from clinical trials to community. So before we dive into the questions, I'd love for each of you to introduce yourself briefly and also share what part of this conversation feels most personal to you. So that can be through your work, through your lived experience, or also through the people you serve. So Kim, do you want to start?
Sure, thank you. So most of you met me earlier. So I'm Kim Jackson Matthews, and I'm with PHA now, formerly Guthy, in a few capacities. So one is being the Director of Diversity, Equity, and Inclusion, and the other is being the co-facilitator for the women's group. And I'm a patient with NMOSD, transverse myelitis, and I'm blind in one eye. These different things that you really don't see or you may not know. For me, what's most important, it's just all together, is this, in the first time that I even got with Guthy-Jackson first, it was that I was in the hospital and I was Googling and I came across Guthy-Jackson, and because my first name is Guthy, I thought, well, that was it. But I'm very faithful and very prayerful, so I said that must be a sign, and it was. And I ended up calling, in a nutshell, I got a hold of Corey, And I think I had just gotten home and reached out, and she was like, yeah, we're starting this group eventually, but you need to go home and take care of yourself first. We'll talk about it. She did tell me, a little bit about the Patient Advocacy Council that they'd be starting. That was around 2022, but I was diagnosed 2021. And long story short, I started with the helping with the women's group, volunteer with the women's group at that time. I thought that it was important for the women that I did meet. They didn't look like me. I knew maybe a few people, but I thought it was still important for me to join the women's group to learn about the resources and to learn, period, about what this was that I had. I really didn't know, but I'm one for not just the researching, but yes, researching and reading and studying. That's me, And so I said, well, this is a way I could get in and learn and see what this organization is all about. And that was important to me, so that not only, it's a double-edged sword, that I would help myself while I was helping others. Mm-hmm. And it's something that's inbred in me. I've come from a household of, my mother and father were community members, and not only teacher and an executive, but they did a lot for community. And to me, it feels good, and to do that. And I thought it was very important. I still think it's very important, not just the people that look like me, but now I had to come to grips with, I'm in this, the accessibility to the table there to help people.
Great, thank you so much for sharing. Jesus, do you mind just sharing a little bit about you and kind of share what about this
roller coaster that is our new life now? But you have to learn and continue. And that's what we do. We try to do it every day. We also cry ourselves at night sometimes to sleep, but we live life. By giving back or sharing with you guys, it helps a lot, definitely. It's important.
Thank you so much for sharing. Community is so important. Dr. Diaz?
Okay. I'm Monica Diaz. I'm a neuroimmunologist at the University of North Carolina at Chapel Hill. So I see many patients with NMOSD and MOGAD. And if you don't know about UNC, we serve underserved patients from across the state of North Carolina. So for me personally, I've been very interested in working with underserved populations for a long time. My parents are immigrants from Cuba. I grew up, having to go to doctor's appointments with them, translating for them. So it just, I've just been very passionate about this topic for a long time. And a lot of the research that I do actually focuses on how can we minimize these barriers to providing appropriate health care to patients, not just with neuroimmunologic conditions, but also with other neurologic disorders like dementia. So happy to be part of this panel.
Great, thanks so much. And so as you mentioned, your work has focused not only on neurology, but also improving care and outcomes. I know you talked about that in your presentation earlier today, especially in underserved communities. But in rare disease research and clinical trials, what are the consequences when diversity of race, gender, culture, disability, geography, lived experiences is missing?
Yeah, that's a great question. When we don't have adequate representation of different races, ethnicities, geographic backgrounds, socioeconomic backgrounds, we miss out on all of that, all of that, not just data, but all that information that we're not being able to capture in research studies and in clinical trials and give back to those communities. So we know, for example, I kind of showed one of those slides earlier. We know that NMOSD is more prevalent in Black African American populations and Asian populations. Of course, we wouldn't have known that if there weren't those patients or participants that were enrolled in those studies, right? So I think it's really important to try to reach out to those communities the most that we can, and try to get those communities involved in our research studies, so that way we can give back that information and tailor treatments to those populations as well. But if we don't include them, then we don't know what's going on with them, right?
Yeah, and so since it's so important to make sure we include people from a variety of backgrounds in clinical trials. What have you found, or what is known about kind of the barriers that exist to having people participate in clinical trials or studies?
Yeah, so I think first is awareness. So if your doctor doesn't tell you that there's a clinical trial out there, you may not know, right? If you don't take the initiative to Google it, you may not know that these clinical trials are available. So I think it comes down to first, the doctors being aware that these clinical trials exist and sharing that information with patients. The other thing I think is access, right? So we heard a lot about different clinical trials going on in Dr. Greenberg's talk, but oftentimes patients have to travel long distances to participate in those trials. And if travel is a limitation or a barrier, that may not be feasible, right? So I think that's another barrier to involving underrepresented populations in clinical trials. And then the other thing too is our eligibility criteria oftentimes for clinical trials may exclude participants who maybe have certain comorbidities like high blood pressure, diabetes that tend to affect underrepresented populations more, or they may exclude people that have a certain level of disability. So we also have to be more cognizant when we're designing these trials and these studies to really include populations that can represent what the whole patient community looks like.
Yeah, and so once we have people participating in trials, what does it mean to kind of simply ask communities, to move from simply asking communities to participate in research to actually building trust and relationship with those communities?
Yeah, I think, historically, when we think back to the beginnings of medical research here in the United States, unfortunately, there have been a lot of, not a lot, but some negative things that have been done to certain underrepresented populations. And I think that, we have to make it more, instead of having a unidirectional or, a one-directional model where we just take data and don't give it back to the community. It has to be more bi-directional. It has to be like a two-way model. Mm-hmm. So we as like the scientists, the investigators, really have to like share that information that we gain from the research studies or from the clinical trials back to the community. So I think that's really important. And then also, making sure that we're sharing all of the risks, the benefits, and being very transparent about what is it actually going to take for you to invest your time, invest your money, your travel costs to come to our research study and do your study visits. So we have to be really transparent about what it's going to involve, so that way you can make an informed decision to enroll in our studies.
Yeah, thank you so much for sharing. And it's so important to have physicians who are advocates for ensuring that representation and inclusion are not an afterthought, but something that's thought about before trials are designed and all of that. So thank you so much for sharing. Jesus, you've supported Spanish-speaking families and have also brought your own personal experience as a caregiver and advocate. So how can language barriers delay education, treatment, support, or trust in the healthcare system?
The first step is to recognize the person, a patient or a caregiver, when they come to a doctor's visit. If they find at least information on their language or somebody that can help in translations, that makes them feel more secure. They can communicate better what they feel or what their symptoms are, and also the doctors can communicate better with them. In the beginning, our journey started here in the United States, and after 1 week of going to different hospitals, we decided to fly back to South America, to Venezuela, to our country, because my brother was a medical doctor there. So my wife was diagnosed in Venezuela. We stayed there for about a year for recovery and therapy, and we learned a lot from that opportunity about the health care system over there. When we got back, we had an issue with the insurance companies, so we have to go back every 6 months to get their treatment in Venezuela. So that were like both worlds, fighting with insurance companies over there and over here and all that. So we learned that there was a lack of communication, a lack of information, especially in our language. You not only could find information in English, I'm talking 20 years ago, every time you logged in, you found something bad about debits, it was called at that time. But then I realized that I needed to help in a way that I could. and I started translating information. Translating information is key to do it the right way, because we live in Miami, and we have a say that we all in Miami speak Spanish, but we don't understand each other, because we're from different countries, and each word means different things in different countries. So to do that on the right way and to recognize the person on their language is extremely important, especially the Latin American culture, and men or women, they don't express themselves the way they're supposed to if they're going through a difficult situation. So it's important to be there for them. And since then, we also have a support group in Spanish. And this year, I started a support group of caregivers in Spanish as well, because we feel that it's very important to recognize that. Like Danny does wonderful work in Brazil, in Portuguese. We do have people that in France and friends that are doing the same thing that we do, and we try to communicate with each other to do the best that we can for those communities.
Yeah. And so what have you learned from the Spanish-speaking community and from families that the broader healthcare community should really be aware of to better understand?
Definitely recognize them. I mean, details like that, the printed material, or talking to them on their own language. Even when you make a phone call, if the people recognize that you speak Spanish or your accent, if they answer to you in your language, is extremely important because they feel recognized. So those are steps that, in this case, the health system in the United States, we know they have a lot of resources. There are a lot of, there's beautiful hospitals with all this technology and all that, but you also have to be close to the people in certain ways that they need to be recognized.
Got it. And so we've obviously talked about how you're a caregiver as well. So caregivers are often overlooked in conversations about inclusion. So what does inclusion look like for caregivers in healthcare, research, or even community support?
It's extremely important. And when you go to a visit with a doctor, you are the person accompanying the patient, but the caregivers are seldom not recognized as well, because we're going through the same journey. Once a family member or a loved one is diagnosed, we are all part of that diagnosis. We live it day to day, 24/7. So caregivers need to be recognized as well, not only for the health, for the doctors and the health community, but also for the rest of the community, in a way that they can be, feel, that's the word, recognized, because you feel like you're there, you're just the person that needs to do the errands and do things and come and go. But there are more to it. There's more to it, I'm sorry.
Thank you so much for all you do for caregivers in the Spanish-speaking community. Really appreciate it. So Kim, sometimes people hear DEIA and think only about race or ethnicity. But in rare disease, inclusion means so much more. So what does meaningful inclusion look like in a community where people may be navigating disability, which you mentioned earlier, invisible illness, that's a big one that we hear, caregiving responsibilities, financial barriers, or cultural differences?
Well, yes. I mean, Jesus, kind of, hit the, nail on the head. And it's so much with inclusion, but making sure that we're getting listened to as far as, in the health industry, period. We've advocated, I've gone to DC with rare disease, and I've seen, how important it is for us to come together. And when we come together, not only as a community, like Jesus said, we make a bigger impact, and that inclusivity is everyone. Doesn't matter, we've said it earlier, you're hearing some things redundant, but because they're true. It doesn't matter, your race, your ethnicity, and what you choose, as your partners. It doesn't matter. The diseases don't matter. They don't see that. They don't see color. But I want to make sure, or we want to make sure in the inclusivity and accessibility that we get the same treatment as everyone else. And you don't get people saying, oh, you don't need this. It's important. This is not just, a disease, it's a rare disease. We need this now. So it's speaking up and teaching people in our community, new people, I'm telling them as well, they may be a little shy at first because like we were all there initially, and we didn't know. When you don't know, you don't do as much. You're not as confident. And so therefore, you're not advocating for yourself maybe in a way that you need to. So we will do it for you. If you need help, we will show you how. Come to us. Come to this, all the support groups. And if you have all our information today, grab it. But it means so much for me to know that people are getting what they need despite anything that people may think about you. It's just like, you're a stranger. You don't know me, but I should be able and worthy of getting the same treatment as anybody else. And so that I could have the better quality. And that's what we are about when we talk about that. It's like the quality of life. My quality of life means, and all of our quality of life means just as much as anybody else's who doesn't have anything going on. Doesn't mean that their norm is born. But anyway, it's just, just being different. And so therefore, that's what it is in a nutshell.
Got it. And so I know you do so much for the NMOSD community and the rare disease community, and also in your local community as well. So how do we make sure that people feel represented, not just in research, but in support, education, and community spaces as well?
Yeah, but by education, yeah, that's right. It is getting the resources to them. Like today, we'd sit hours. We hear, from you. And in those Facebook groups, not like we're sweets being secretive. I'm in there, and I'm asking and want you to come to our support groups because we ask those questions. It's what is going on today? What can we help you with? It's not just asking that. It's so we can get that information and try our best. Not always, but we try our best to get to sRNA, get to our partners over there that you've heard about, at Alexion, Amgen, Genentech. They're constantly asking, well, what are the patients? What's on the patients' minds? If you don't tell us, and I'm always, hey, how you doing? I'll ask you. And that's how we get to find out what's going on. And it's more than that. It will trickle. We have so much going on with advocacy in our own organization with PHA that is amazing. We do have our Patient Advocacy Council. We have we've had to do some other things, but we're coming strong with our patient advocates that are here. If any are here that haven't been on the panel today, would you stand? It's Keisha, Kim, that you probably talked to. They may have walked away. Keisha is my co-facilitator of the women's group, doing a fabulous job as well. And Maria and Vilma and all, and Mo. Yes, Mo Jones, Monica Jones, Mo. They're doing so, so it's not about me. See, this is a community. I've met so many people through being on the Facebook groups. So that's not just, we're shouting out Facebook so much. Anyway, for all the social media alone. And then my first patient day when they welcomed me. And so I'm giving back. That's, I'm going to give back as much as I can and pour into the community. But it's important for us to, in our groups, we're bringing those resources, and we will talk. We'll say, oh, you remember? And we will recap. Like today, we will recap for those that weren't here, those that were unable or not feeling well, who are even not able to get online. And we will share that information to them. So we're telling them what's coming up, what we need to do. And if you can't go there, somebody else will. Go to DC or go to represent you.
Yeah, and so there's something also so special about being in a space where you don't really have to explain yourself, where people understand. They have similar experiences living with one of these rare conditions. And so how do we create spaces where people don't feel like they have to explain, prove, or justify, especially in the case, I think, of invisible illnesses or invisible presentations. How do we create these spaces where they don't have to explain, prove, justify their experience in order to belong?
I think it's easy. I think it's easy when you have empathy and then you're living it, lived experience and empathy means a lot, and it goes, without saying. It's natural. Someone talked about it earlier. Well, it's just not a normal, our support groups aren't just normal support groups or those old adage of, AA. It isn't that. Sometimes we don't want to even talk about the disease. We're having too much fun with, the icebreakers that Keisha comes up with, or some subject that I thought about, or whatever's happening. Is it Valentine's Day? So let's talk about, hey, what's your love language? Whatever it is, that makes it easy for people to come in. And we said the same thing, like we say, you don't have to talk if you don't want to talk. Just come in, bring your little favorite drink and just listen for a minute. And then that lasts just for a second, and then people are already getting to know each other. Then we go, okay. Because again, it's not about me, but I'm getting a lot out of it. And we go around the circle and the work, or we are doing the work behind the scenes to find out what will make, you come. And it's just like here, looking in the room, what will make you come? Well, providing the sources, right? Providing the information. But the community, this is such a beautiful community, and, and we've done a lot to help people, and that's the main thing. Make it where you feel it. You feel wanted, and you don't feel alone. And me finding out, I think Jesus may have said this, finding out, what do you like? I just met Nick yesterday. Shoot, I feel like I still feel like I've known you for a while, but I got to know you. We sat and did some designing of, we said we were designing the flowers last night, but we sat and we talked and we laughed, everybody that was here last night. And so it's just about that, getting to know each person. And it's been, I've been diagnosed for 5 years, but it's been about 4 years, and I've gotten to know these Jesus and Maria, and waiting to get to Miami so we can go to baseball games.
Anytime.
And we can go, do things that we have in common. And I have a spouse that, hello, if you're listening, Frank, dearly, he's always my side. I say he is my care partner. Care partner in crime, and he's always there for me. He's been unable, unfortunately, to make it to some of the last ones, but I know he's always here, and that helps me be confident because of him pouring into me.
Thank you. If I may,
Yeah.
is creating spaces where that you're safe, you feel recognized. Maria and I have been to all patients' days for 18 years. Wow. And every time we sit on a different table, every time we travel. We met you there. So that was something that we created. Every year we sat on a different table so we could meet new people. And they became our friends, our family, and we could continue to communicate. We have experienced a very important on our Spanish speakers group that we have everybody speaks Spanish, but they come from different countries. We get people from Spain, 3 o'clock, 4 o'clock in the morning, and they wake up just to come to our meetings. We have people from Peru, we have people from Argentina, we have people from all over, and they have different, all the time, questions. How is it? Treatments, and also their cultures are different, so you need to recognize them by their culture, the way they speak, the words that they need to hear. And being there for them is important. We're always there. In our case, it's the last Tuesday of the month. Maria and myself, and Vilma and Dulima helping us out as well. We do it at 7 o'clock every last Tuesday of the month. And then at 8 o'clock, we have the caregivers group, and we're always there. I remember, I just mentioned to Corey that I saw a note on my files that this year, we're celebrating 10 years of the caregivers group.
Wow.
And in the beginning, it was just a phone call. It was called conference call. You dial a number, and then you need to dial like a code, 10, 20 numbers, and then you didn't recognize who was on the other side of the line because my name is Jesus. Yeah, who are you? Where are you from? It was a phone call. And there were Tuesdays, last Tuesdays of the month, that nobody called, but I was there. And thinking to myself as a caregiver and say, I'm here for an hour waiting to somebody to speak to me through a phone. That's important and powerful for them to know that we were always there. And now we have 9 support groups on PHA, and we continue to share our journey, and especially to the newly diagnosed. It's very important to feel recognized, for them to know that there are people that are going through their same journey. So.
If I can say as well, thank you, Jesus. And I don't want to take over your job, but I really just want to say one thing that, too, we have done, 10 years, and all of our support groups are just amazing. And with the women's support group, we have doubled in capacity, and so that we've had to increase not just one, we have 2. Wednesday nights and Saturday nights, so that we can accommodate the many ladies that want to come, or if they want to come, twice during the week, that's fine. And just so too, like Jesus, it's about recognizing the cultures of people, and it's so fun that I have met, like I said, different ladies, and they're mostly a lot from the South, and but the commonalities. Mo and I, when we first met, I found out that she was from my area, Jacksonville, Florida, was born there. And now back there, hold up your hands. Dee and Tyrone are from Jacksonville, Florida. If this wasn't meant for me to be, but it's just amazing. But you never know. But just knowing and getting to know people, because the people, they make assumptions. I'm like, I used to have my accent, but now it's, a Cali girl. But anyway, all the years of living there. So, and I think we're good now.
Yes. Well, yeah, as if you can't already tell, an absolute powerhouse of a panel here. So thank you all so much for everything you do for our patient community, and for helping us think about representation and inclusion as not just something to be checked off, but as something that is really an ongoing commitment. So thank you all so much. Really appreciate it.
Thank you. I can help you step down
and then are we clicker, right? Yep. Thank you. Yeah, you can introduce this. Do you want to do that? Jesus, do you still have the microphone?
Yes. I got it. And now we continue on the agenda. That is called Programs with Purpose, supporting the NMO and MOGAD community. Gigi will moderate it, and we have our wonderful panel.
Oh, no.
Oh, my goodness.
Yeah.
I'm sorry. Talk first? I'm so sorry. I brought the wrong glasses. Have you noticed that I'm going like this? I'm sorry.
No worries. All right. Yes. Hi, everyone. Hello again. So yeah, I'm just going to very briefly go over kind of what SRNA does. And I'm going to go through this quickly. So if you have any questions about any of our programs or support or anything, please find me or Chrissy, who's over at our booth over there, or Landy, who's at this table here. So I am the executive director of SRNA. Let me just see. So SRNA is a nonprofit organization that advocates, supports, and educates people and their families diagnosed with a spectrum of rare neuroimmune disorders. This includes acute disseminated encephalomyelitis, or ADEM, acute flaccid myelitis, or AFM, MOGAD, NMOSD, optic neuritis, and transverse myelitis. And we also accelerate and invest in scientific research, and our ultimate goal is to improve the quality of life of individuals diagnosed with these rare neuroimmune disorders. So we were actually founded in 1994 as the Transverse Myelitis Association, and this was because people diagnosed with transverse myelitis came together. There weren't any resources, no information, no physicians, and so it was founded as a completely volunteer-run organization. And then we throughout the years, we're getting people coming back to us saying, hey, I was diagnosed with transverse myelitis, but now I have optic neuritis, or I was diagnosed, as Jesus said earlier, with DeVick's disease. And so we have, from the beginning, been working with people with more than just transverse myelitis. So to reflect that, we changed our name in 2019 to the Siegel Rare Neuroimmune Association. And so we're a team of 7 people supporting over 15,000 people from over 121 countries. So just to note, you can join as a member of SRNA. It's completely free. It's just a way to get information about resources, events, research. And so this is just the form, but it's just wearesrna.org/join. And then, so I have this logo here because we talk about Connect, Care, Cure as our 3 C's. And that's kind of what makes up our logo there. So in terms of Connect, we offer a support group network and our peer-to-peer program, which was talked about during a previous panel. We also offer personalized support through phone calls and emails. I know PHA does this too. People get newly diagnosed and say, hey, I've never heard of this condition before. What do I do? Or maybe have a new symptom or something and are seeking support. So we do that one-on-one support too. We also have our blogs and magazine. Andy over here works on many of these. So we have a weekly blog and then a quarterly magazine that Landy very thoughtfully puts together on different themes 4 times a year. So these include stories from members, research summaries, recaps. You'll see a blog about this event coming up soon. And so you can subscribe to this via email. We also have our family camp. You may have seen on the screen kind of show up that we have one coming up later in June. But this is an amazing opportunity for families with children affected by rare neuroimmune disorders to come together, meet with each other. We also have medical professionals come, so there's a medical education kind of component there too. But many of our volunteers are kids who were campers and are coming back to volunteer. Again, don't want to call out Landy again, but she's an example of that. And so it's a really wonderful opportunity for parents to see that their kids, growing up will be okay. So we had 23 families in 2025, and this year it looks like we'll have 30 families. And it's a completely accessible camp. And so we have dates for next year. So if you know of any families that are interested in attending, we don't have the application up yet, but these are the dates for next year, June 27th to July 1st, and it's at Morgan's Camp in San Antonio, Texas. We also have Walk, Run, and Rolls. These are awareness events. They're organized by community members and are used to raise awareness and fund education and research opportunities. So we had 6 events last year, and there are several scheduled for this year. There's one actually happening on Sunday. So you can find that info on our website. We also have under care, we have our resource library that has almost 1,000 resources available. These are podcasts, videos, external resources. You can sort by the type of resource if you want a particular format to learn information, or the topic, and also by disorder. And then we have a myelitis helpline. This is an online tool where you can get additional information about various topics. We also have our symposium coming up in October. This is something we do on a yearly basis. Every other year we have a large 3-day one, and that's what's happening in October in Dallas. And so we've been doing this since 1999. And this year's symposium will be hybrid, so you can attend in person or online. We also have our online learning program. This is a self-paced set of courses where you can just go on and learn at whatever pace you want. And so there's videos, animations, and so we have one course that's about kind of how the immune system and nervous system interact to create these rare neuroimmune disorders, about each of them. And then we have disorder-specific ones as well. And we're currently working on topic ones like clinical trials, mental health, and other things. So stay tuned for those. We also have disorder information sheets available for all of them, all of the disorders we cover, and all of them were translated into Spanish in 2022. We also have our partnership with Can Do MS. They're primarily an MS organization, but have been working more in the rare neuroimmune disorder space. So we have a coaching series with them. This is our 3rd year working with them on that. That's coming up this summer. I'll show you the dates in a second, but it offers a way to talk to other people about wellness. You share things you've learned, and a place for mutual support. So This year it's completely online. You don't have to attend all of them. You can just pick one if you want. But it'll be on mood, pain management, movement and staying active, and fatigue management. And so that is the website there in order to sign up. We also have our podcast series called SRNA Sound Waves that include podcasts like ABCs of NMOSD, ABCs of MOGAD, Community Meets Clinic, where we chat with clinicians in our who see patients with rare neuroimmune disorders, and then also Community Spotlight, where we highlight members of our community. We have a medical professional network, so if you're having a hard time finding a doctor in your area, you can go on our website and try to search for one. And we've got, I don't know the number at this point, but there are many, and if you can't find someone, reach out to us and we will see what we can do to try to find someone else in your area. We also have centers of excellence in rare neuroimmune disorders. These are centers dedicated to providing comprehensive care to people with rare neuroimmune disorders. We currently have 24 centers, 7 are pediatric only, and we have 1 rehab-specific center, but you can find a list of them on our website. We also have a physician consult portal. So we have one that's actually for all rare neuroimmune disorders. So this is a physician-to-physician consult. So if you're seeing a doctor and they're maybe not as familiar with NMO or MOG, and you want them to speak with another physician who maybe has a little bit more expertise, they can fill out this form, and then we send a request to one of the physicians we work with, and they do that peer-to-peer connection to make, to have that kind of second opinion without having to go anywhere. So that form is available on our website, and again, has to be filled out by a medical professional. And then under CURE, our third C, we have the Eclipse Fund, which is in memory of Pauline Siegel. She passed away, unfortunately, several years ago, but is one of the founding members of SRNA, or the TMA at the time. And so as part of this, we fund research, and SRNA also conducts research as well. So we have a registry, we've done studies on experiences with vaccinations, and we also worked on a study on quality of life in NMOSD. So the registry, as I talked about, is you can go online, sign up. It's completely self-reported, so you just fill it out about your experience with diagnosis. And yeah, it's a way to, researchers are able to request de-identified information. We have, this number's not entirely up to date, but we have around 800 participants. We also have a fellowship program, so in order to increase access to care across the country and world, we fund the training for clinicians after their residency, so they learn about rare neuroimmune disorders, spend 2 years doing that, and the goal is hopefully to have them go somewhere and create a center of excellence to provide additional places where people can get good quality care. So we've had 11 fellows since 2012. We have 1 starting in July. And we started with only 4 training institutions and now have 7. And on our website, there's a really great video about the fellowship if you are interested. These are our current fellows, Dr. Sydney Lee at University of Utah, and Dr. Rachel Walsh at Boston Children's Hospital. And yeah, if you have any questions, you can email us at info@wearesrna.org, or talk to me, Dr. Chrissy, or Landy, or reach out to PHA and they'll connect us. But yeah, thank you so much for letting us talk a little bit, and we greatly appreciate our partnership. So. All right, thank you. I don't know what the clicker. Okay. Let's see. Yeah, do you mind?
Okay. It's the last panel. We're almost to getting to listen to Kim. It's going to be good. Does everyone have a mic? Do we have to share a little bit? Okay. Thanks, Gigi, for talking about programs of SRNA. We often refer back and forth, I think, to each other, because we're all doing a little bit different things, and there can't be too many programs. We want to help. And so we're going to talk about programs with purpose, and we're really going to talk about impact of those programs today, which is something that's kind of hard to measure unless you just listen to the stories in the community from people that have utilized the program. So we're going to try to highlight some of the impact of SRNA and PHA programs and demonstrate how education, peer support, storytelling, and community connection reduce isolation and improve quality of life, and just explore how connection can lead to confidence, purpose, a sense of belonging. I think we've all felt that, so it's easy to talk about. So through today, we've heard a lot about the science and the symptoms of NMOSD, treatments, and information is so important, and so is connection. That's why you're all here today. We're connecting with one another, and we all hope that we'll stay connected after today too. The phrase "you're not alone" comes up a lot, right? We say that to one another, we have that everywhere, but I hope today you leave with "I'm not alone," because it is a very personal journey. And I think, I wasn't going to say this earlier, but after listening to Julie, I feel like that's self-care for me. I don't know if anyone else felt like that. This connecting with other people, it makes me feel like I'm not alone. And I know you're not alone because we're together, but it's a form of self-care in so many ways. So we're going to talk about just the impact of that, and to share real experiences about what happens when education and support become connection, and connection becomes community. So I'm going to start with you, Mo. Let's just do self-introductions, and then maybe just share how you found a patient advocacy group.
My name is Mo Jones. I was diagnosed with seronegative NMO in 2020. Community actually found me. After I was diagnosed, I decided I had to make some changes, and I started putting myself out there on social media. After I was diagnosed, I got my degree. I started a business, and my local newspaper and my school both did an article on me, and through those articles, the first organization that I was with found me. I decided they weren't a great match, and then Corey found me on Instagram, and it all went downhill from there.
That makes me sound like a stalker. A little bit, yeah, that's fair. Oh, I'm just gonna take this back, I'm sorry. Landy.
Hi. Yes, so I'll talk a little bit more about my introduction to SRNA a little bit later. But for now, I want to talk about how I first found, PHA. Basically, when I was a kid, I had my onset. I'm kind of a rare case. I've had it since I was 6 years old, which is hard because I don't really have a lot of people that were around my age when something happened. I've had it for 18 years. So I kind of feel like I was in a really, really rough spot growing up because, it was so severe and so painful for me. And I didn't really have the right words to express myself throughout it. I was a little kid. All I could tell anyone was that I was felt like I was on fire, that I was in so much pain. And I didn't know anything, and nobody knew anything. It was so long ago. I was able to, or my family was able to find online, a very, very scary article, and that said some really harsh facts about the disease that are no longer true, about what my outlook of life might look like, and that scared us. But we also found the Guthy-Jackson Charitable Foundation. That was what they're formerly known as. Now they're the PHA. But we were able to get in contact with them and go to a conference in California. And I had never been to California. I was 8. I was this was 2 years after, my onset, but I was still able to find these people, fly to California, go to this beautiful, wonderful patient day with people that finally understood me And, you know, not many of them were around my age, obviously. Most of my friends are, you know, 40s plus. But at the same time, I was in a room with people that like saw me and said, you know, oh, I get it. Oh, you're going through something. And they actually like could grasp the amount of like grief that I felt, that my family felt about it all. And of course, the really pivotal thing for me was meeting Allie Guthy, who was like, I think she was like 13 at the time. Like, and I know that that's not necessarily like young, but when I was there with her, I was like, I was looking to her as like a representation of like a young girl, and I was a young girl, but all of a sudden I had gained like 60 pounds from steroids. I'd gained 30 pounds in a single month and then 60 within 3 or 4 months. And it killed me, it killed my confidence. And I was able to go into that area and talk with her, and she treated me like a human being, and like a really scared little girl. And she understood what I was going through, and all the I mean, it sounds pathetic to be like focused on the beauty aspect of it, but my self-image as a kid was so destroyed. I was able to talk to her, and she just like kind of consoled me and spent like almost the entire patient day just hanging out with me. Like, and I think that was a lot to ask. And I think that she really stepped up and was a huge like pivotal connection for me, and really shaped my journey with advocacy and with these organizations. I think it just takes one person to change a person's life, and Allie Guthy was that person for me.
And I got to follow up that. I'm Travis. I've had NMO since 2016, diagnosed in 17, and you know, first thing the doctor said to us was, don't Google it. I Googled it. I found the horrible stuff on the internet. My wife found Guthy-Jackson, and that led us to meeting up with Jody and the Atlanta group. And they've been stuck with me ever since, and my mother-in-law's cookies. And it's been, I guess, kind of a roller coaster since then, the good and the bad, the good, meeting everybody, hanging out with everybody every month, meeting Corey, meeting everybody here, hosting the Wednesday group, the men's group. It's just been kind of fun. I don't know.
I'm Holly Kirby, and the answer that I can give is Doug. He's the one. I was taking care of him. I was trying to keep my head above water, and he was doing all the research. He's the one that knew it all. He's the one that did everything, but he also included me. This was a we. I've said that already. We do this together. It didn't happen to him. It happened to us. And he's the one that said, okay, let's go to LA. And then a little while later, I just signed us up for this. And a little while later, we're doing this. And we just do it together. So he's the one that got us involved here.
Yeah. Well, I'm glad that you're doing it together, because then we get the blessing of knowing you too. And I always appreciate the caregivers group myself to attend and have some self-care that way from Jesus and from you. I want to talk a little bit about what it felt like before you knew there was a community at all. I remember that. I remember feeling like nobody gets this. My daughter was 15 when she was sick, and like you said, when one person in the family has it, the whole family has it. And we had 4 children. Meg was the oldest, but the youngest was only 4 years younger than her. It was a busy time, and everything stops, everything stops. And we thought, oh, well, we'll get mental health support to help us through this. And we saw a therapist that said, this is very complicated. I don't think we can help you. Didn't give us any other direction, just, my husband and I tried to go first, thinking, well, we'll go and then we'll make it a family appointment. And instead, we left there thinking, well, we have each other, we're a strong unit, we'll get through this together. And I was so grateful to also find Guthy-Jackson back then, 10 years ago, almost exactly. And it was remarkable, the change in my daughter, finding community, and for myself, but it was remarkable, the change. Her depression was better. She felt like she could text a friend any time of the day and they would understand whatever symptoms she was feeling. And when she was in the hospital, she could reach out. She could join the teen group back then, ran by Heather Swala. Heather, if you're watching, thank you. But it was a significant change from thinking no one in the world knows what this is about. Our friends and family did not understand. They seemed, sorry if they're watching, they seemed disinterested in learning, which I think probably many of you have experienced. Like, they ask you how you are, but when you want to really tell them, it's just words are going over their head and their eyes glaze over. But when you come together in a room of people that understand NMOSD and you start talking about whatever symptom it is, it's like they lean in. Tell me more about that, because they also want to know and care and understand. So significant for us. But I remember when you first came to Patient Day too, but tell me what it was like before you knew anybody.
I felt isolated. I had had symptoms for a long time before I knew what it was, and I would go to doctors and they would always say they can't find anything, or it was anxiety or depression, or it was just stuff that didn't make sense. So when I first got the diagnosis, there was some relief because it finally had a name, but then there was also fear because what is this? And, you know, of course, I did what everyone else did, and which is what doctors tell you not to do in Google, but you're being told that you have something and you have no clue what it is. So you're trying to find out what you can expect. So for a while there was some depression because, you know, now I have this disability, I've lost vision. I have this disease that they're saying is no cure for. I don't know what to expect. And so I was nervous getting on the plane because it was the first time I had traveled by myself, and I don't know how long. But then by the end of Patient Day, I was in tears because I was like, now I have to leave and I have to go home, and I don't have anybody who's gonna understand what I'm feeling. Like at Patient Day, if you say you're tired, everybody in the room understands at some point because the fatigue can hit you out of nowhere. Or if you start having spasms, you know, everyone's like, I know, we've been sent for a long time, we understand. So Patient Day was really life-changing for me because now I have this community of people who understand what I'm going through. I can unapologetically be myself. I don't have to explain why I'm tired or why I'm feeling a certain way. And so now it's like tradition for me. It's an anniversary. Well, a family reunion, really, because all your people are there. Everyone understands, you know. It feels like home, and it's great to have people that you can talk to that understand how you're feeling, and you feel less alone.
Absolutely. Landy.
Yeah, I guess, I mean, not to be too depressing, but before everything happens, I mean, it's free fall. It's free fall to be in this, like, life. All of a sudden, everything just shifts, and you don't even have a functional baseline by which to measure where you were even supposed to be or who you're supposed to be. For me, I mean, when you're a kid, you don't really have any sort of, like, you're still forming your identity. You're still forming who you are. And when the trajectory is just, of your life is just crushed under the heel of something, you bend. You have to go to a different direction, and you have to, you know, completely steer your ship another way, in a way that, like, you don't have choice or autonomy over, especially when you're a kid. So I would definitely say that, like, when you don't have community and you don't have, like, other people's stories to hear and to look at and to kind of not compare, but to, like, see, you can't really, like, proceed. I mean, there's so much grief that you have to process, and Having community can make that process so much quicker. Having people means that you have a measure again of like what can be possible, what I can do, what I can be, and yeah, that's my thoughts.
It also was so long ago, was really much more frightening 18 years ago. Not that it isn't still frightening for anyone that's newly diagnosed, but it was a much different landscape.
It's leagues and bounds.
Yes.
Better. I mean, like people that are diagnosed now, I hope you feel the hope that I didn't get to have when I was a kid, because I feel the hope for it now, but I didn't then.
Not then. I'm sorry.
Yeah, when I first learned about it, it was rough. Family, friends, they just kind of zoned out. Oh, you'll be fine in a day or two, whatever. Blew it off like it's nothing. I did have one family member that had MS, and she was kind of, I was leaning on her quite a bit, and then we found, Nicole found the Guthy-Jackson group, found Jody and the group, and that changed a lot of my mentality on it. I was, I don't want to say depressed, but yeah, before, and seeing people that had it for 10, 15 plus years doing fine made me feel immensely better.
Yeah.
Jody
was so humble earlier, like, oh, I haven't really done much. You have done so much for the community.
Yes.
I mean, really, for so long.
Yeah.
Thank you. And very steady, right?
Yeah.
Your group meets and people show up, and I'm sure it grows in size and changes and when people are available. But
yeah, we meet up almost monthly. We take summer off because it's Atlanta, it's hot, and people have stuff to do.
People don't want to leave their AC.
Yeah.
Yes. We have very close relationships with air conditioning in Georgia.
Ollie, do you remember that shift?
Oh, I so remember. I start off with 9 years ago, I became a caregiver. Kind of lost myself a little bit. That's all I focused on. I went to the hospital. He was in the hospital for 10 weeks, and I went every day. We ended up just explaining what the hospital experience was a little bit. We had a basket of chocolate in the room. This is Doug. He was positive, okay, let's move forward, that we've got this diagnosis, let's move forward. And we had a basket of chocolate, and medical personnel, the aides and the doctors and the nurses would come in and have chocolate. Some of them would get yelled at somewhere else and come in and say, I just need to come sit in your room for a few minutes. And they would eat chocolate. And even I went home sometimes at night. Towards the end, he kind of started kicking me out. He goes, you need sleep, please go home. And which I did. It was the right thing. But I would come back and just in time for breakfast and get his breakfast. And I did most of his care in the hospital, and mainly so that I could learn what I needed to do. It was tricky, but we had lots of support. We had lots of family support. We had lots of friend support, and our neighbors were awesome. And when we got home, he was in a wheelchair and needed to be lifted, and I did most of that, but a couple times he fell on the floor and I couldn't get him up. And I would call a neighbor and they'd run, and so we had that kind of support. But when we got involved here with all of you, it was a different support. It was family. It was, you understood what we all were feeling and what we all were doing. And I was going through some other things that were pretty tricky. And coming into this space, being with you, I felt safe. I felt loved, and I felt like I was heard and seen. I had a friend one day come up to me, not here, but in our neighborhood, and she came up to me and she said, I just want you to know I see you. And it was the best thing she could have said, because sometimes as a caregiver you feel invisible. And I was so grateful for that. But here, I feel seen always. And I'm not invisible. I am somebody important. And I'm grateful for that.
We're grateful too. So that is the basis of this, right? The programs that we create as a patient advocacy group for the patient advocacy portion of the work that we do, not research, right? But the programs are meant to meet a critical need in the community. So some things that we do, you might not think of as programs, like Patient Day is a big program. It's the longest running program that our team has done. Dan and Jacinta have been running Patient Days since Jesus was there in, I think, 2008. And every year since, he had to show off that he's been to all of the Patient Days. But I'm so glad he has been. And from there, things have grown. So Landy, a happy thing that we can talk about is, I know was very impactful for you to attend family camp with SRNA.
Yeah, I mean, absolutely. So after I had been connected with Guthy, or, with PHA, that was so pivotal for me, because I did get to meet so many amazing people that were, understood me. And Ali Guthy, for sure, pivotal because of our, I was 8, I was 9, I was 10. And I was really lonely. I was really going through it with my friends at school didn't really understand me. Most of them did not. I mean, most of them were kind of actually turned into kind of bullies with me, would run away on purpose because they knew I couldn't, I could barely walk, let alone run. And I was really feeling so friendless. I had family, but I didn't have friends. And Mom knew that I was going through that, so she was looking things up online, and she was able to stumble upon the TMA because she had been looking up a ton of different search words, and technically, my condition, she thought maybe I'd be able to do family camp with them. So she messaged and was like, "Hey, I know you guys are the Transverse Myelitis Association, but would you please let my daughter come with? I promise that she's going through something similar to you guys. I promise that, we'll do our best. We'll be very quiet, but we'll have a very good time if you let us come." And Sandy, who is our president of SRNA, said yes. I said, absolutely. Please come and be with these kids and hang out with them and have your daughter be part of things. And so I went, and yeah, I was the only person with NMO, but I wasn't the only person that was going through the same stuff. I mean, all these conditions are very similar. A lot of these kids were, many had transverse myelitis, many had acute flaccid myelitis. I think some had ADEM as well. Across the board, it was very, it was people that looked like me, people that had the steroid bloat, people that, needed mobility aids, people that had to sit down for long periods of time, people that had fatigue, all the things that I was experiencing as a kid. And I was able to have this complete shift of frame of reference because I could go to this place and see these people that were still having fun, still doing activities that were, super accessible and super awesome activities. And it brought me a lot of joy back to my life because and I was looking forward to every summer. I started when I was 10 and I did it every single year. And every summer, it gave me something to look forward to, even though things maybe didn't improve in my day-to-day life of finding a lot of friends. I had people at camp that really got me. People that I could text if I really, if I needed a friend, I could text them across, year round. And it was really life-changing for me to just be in a place that I could see people like me.
That's profound, to find when you're young, especially. So, and I know that's so much work that now because it's led to you working with them.
Yeah,
yes.
I mean, they're a fantastic organization led by awesome people that I got to spend so many summers with, and they do great stuff all the time. We're always trying to come up with new ways to help people, and PHA does the same. So absolutely, I totally recommend you guys join the SRNA, become a member if possible, because I mean it's free, and who doesn't want more support groups, more friends, more opportunities to be here, like be in events. Like we do walk, run, and rolls. We do, patient day type events. There's more opportunities to be in a room with people that get it. And, I would rather go across and do everything with everyone all the time.
Yep, absolutely. All right, Mo. So I think that you've participated in a lot of programs that we do. And you used to say to me, I don't know if this is still a mantra of yours, but you had to get comfortable with being uncomfortable. So panels, you were on a panel with Christine Hav, remember that, in Chicago? That was fun. I said, not every day can be a master, what did she win? Master Chef, yeah, not every day can be a Master Chef winning day. That was my favorite line on a panel. But you did it. And then you told your story in a Hear My Voice video. And then you did an adaptability video with us, which is the program that helps provide tips. And well, you saw it Vilma today. That program is in collaboration with the MOGAD Project and SRNA, so we can bring more tips and tools to the community. But you also joined the PAC pretty early on, as soon as you found community. So what do you think the impact of those programs and participating in them is? And are you comfortable with being uncomfortable yet?
So to answer your last question, no. I still get uncomfortable. However, I think you just throwing me on stuff without asking first helps. Yeah. It's helped me. It's definitely helped me come out of my shell. Being sick in general has helped me come out of my shell because in my everyday life, I keep to myself. I'm one of those people who are shy until I'm with the people that make me comfortable, and then I can be authentically me. But I think it helps when people are able to see that you can be sick but still live. I remember when Keisha came to her first patient day, and she was in awe of everything that people were still able to do. People are still getting degrees. People are traveling. People are living life. And I think when you have someone who looks like you or who is in the same position as you, it helps you to remember that, my favorite line, you're disabled, but you're not deceased. You can still move. You can still do things. And being sick doesn't mean you have to lay down and take it, there's days where we may have to lay down and take it, but I think programs like these and having people who are actually patients and understand what you're going through really helps you get through, because who wants to be a part of something where somebody really doesn't understand what you're going through? If it's not relatable, I don't really think it helps. I will never forget right before I was diagnosed, when I had my first event, and I went to the emergency room, and I had a doctor who looked like me tell his colleague that he didn't think that imaging was necessary for me. And so I went almost 24 hours without an MRI. And, I wonder often if I would have gotten imaging earlier, or, if treatment would have started earlier, would I still have vision? So I think having, the support groups and having patient days where you can talk to doctors who specialize in NMO, or you can be around other people and compare symptoms like, hey, I'm experiencing this. Have you ever dealt with this? And then being able to ask a professional, well, what do you think? Is this something that I need to talk to my doctor about? I think it helps.
I have to agree with that. Travis, what is the impact for you on being able to join the men's group each month? Is that something that you look forward to? And do you feel like it's really important that we have groups that are specific in that way?
Absolutely. I didn't meet, we have 2 guys in Atlanta that have it, but the virtual meeting with the men's group is the most often I get to talk with guys that have this.
Yeah.
This is the way I say it. It's, we don't meet up in Atlanta too often. And other than Mr. Kirby and Mr. Brooks over there, I've only met one other guy at any of the patient day events in person. So yeah, the virtual meeting has been pretty important to me and something I look forward to every, was it last Thursday of every month or third Thursday?
Third Thursday.
It's on my calendar. My brain
8 p.m.
sucks.
Eastern.
You guys know.
Well, you met Nick now too.
Hmm?
We'll have to get Nick to come to the men's group now too.
Yes.
Oh, good. And you just joined the PAC.
Yes.
Recently, so we're glad to have you. And Travis is also co-leading the Midweek Connect. It's on the first Wednesday of every month, and it's like noon Eastern, so it's kind of a lunch and learn or coffee for West Coast. So it's a great opportunity to connect and not have to join late at night, because a lot of the groups we have to do at night to accommodate both coasts.
Mm-hmm.
So that's really helpful.
It's a good one. I co-hosted with Sally. I think she did it on purpose. She's planning on going to Cleveland. No idea why she would delay to Cleveland, Rock Hall of Fame. But
yeah,
no real rules or anything to that meeting. It's come in, talk about what's going on with you, and check in with everybody else.
Yeah, it's a good
Easy
one.
going.
It was nice to add a meeting that's during the week, or during the day, during the week. So it can be easy to join. Holly, I always think of when you joined the PAC, you saying that Doug just came home and said, I signed us up to be volunteers at this organization. And you said, what? Right?
Yeah, I was really going through some hard stuff. I was barely hanging on, honestly. And I went in his office and he said, I just signed us up to be patient advocates. And I said, what? You signed me up to do what? What? I can't even hold my head up. How am I gonna do that? And he goes, I feel, whenever he says I feel, I don't argue. And he said, I feel that it's something we need to do. And I will be forever grateful.
Yeah, we are too, and so many people, you've touched so many people. And it brought opportunities to do other things. You were part of the NMOSD Won't Stop Me with Landy and Kim and Kayla, and broadening like more relationships within the community. It's beautiful. There are lots of opportunities to get involved. So one last thing, Travis, what do you think though of coming together face to face? Because you were talking about the men's group online. Do you have thoughts about the impact of being in the same room?
It's definitely different in person versus the Hollywood squares. And yeah, it's nice being in physical contact with each other, I guess.
Yeah. So when we are creating programs, like I said before, we're looking at how can we meet the critical needs of the community, but also we want to address barriers of participation or make sure things are equitable and accessible. So if you saw the slides that were going like during the break and this morning and at lunch, you'll see all of course, the support groups, which you talked a lot about today, but maybe you don't want to talk in a meeting. Maybe you want to join and do something and not have to really turn your camera on. We do have the Artistry in Motion program. If you're here today, registration is open early. It usually opens on the 1st of the month, but I opened it early for today. So there's another workshop coming up later in June. But when we were creating that program, it was coming out of COVID. People were very isolated. We were like, how can we help support mental wellness, mental health? And we started partnering with Indigo Art Therapy to create this art and wellness program. And the first pilot part of it, we created it, had the workshop, but people had to gather their supplies and come to the workshop. And immediately the feedback was,
well, it's really hard. I really don't want to leave my house. It was 2021, so it was still, some people were out in the world, but a lot of the NMOSD community was not ready to be out doing much, right? We were still like hiding and wearing masks for a lot longer after that. So that was a barrier. So we were like, okay, we're gonna supply the kits. We're gonna have a 2-hour virtual art and wellness workshop, and we're gonna send these kits out. Thank you, Renee, for sending them every month out to all of our participants. And it's been going strong. It's really well attended. It's fun. It's what you want to make of it. You can share what you made in the workshop, or you don't have to. It's not something like a sip and paint. You're not making art for like to hang on the wall. It's really process art, and they're art therapists that are running the workshop. It's not specifically art therapy because it's a large group across Zoom. So it's a wellness workshop, but it's a great experience. If you haven't done it yet, I highly recommend it. It's a wonderful program. I think some of you have probably participated, yeah. But it's those kind of things, finding the barriers. And the other thing that I want to bring up, because I think a lot of people in this room have understood the need for this, and it's something that PHA is doing, carrying on a tradition that we did at Guthy-Jackson, is providing assistance to get to patient day. So how impactful is it, right? If you can't get there, and someone says, oh, well, we have this grant program, and if you've never been to patient day, we can help get you there. I was a recipient of that. Well, not myself, but my daughter, Meg. We couldn't have afforded that. We were like financially devastated after her diagnosis, like months and months in the hospital and lots of lost income. And does anyone talk about the cost of parking when you have to pay to park at the hospital for 3 months straight? There's just a financial nightmare happening when you're first diagnosed. So any assistance like that can be incredibly impactful, and I'm really proud of us that we don't have, we haven't spent money on like a grandiose event. What we've done is invested in you being able to be here, which I thank you to Dan and Jacinta for keeping that going. And if you've ever received assistance to be at a patient day, I think it's something also to be proud of, being part of an organization that recognizes that that is a barrier, and we need to keep supporting our own community in that way. So I'm so proud that we do that, and I hope we can keep doing that. Where's our friends over there in the side of the room? We really couldn't do any of the programs that we are running for the community without the support of Alexion, Amgen, and Genentech. We're eternally grateful for all of their support. They really help work with us to create programs with purpose. And so I just thought we should do like a little hand raise, like for things that people maybe have participated in. Raise your hand if you've participated in a patient day. Oh, it was a trick question. Okay, so I know who has done this, some of you people, but has anyone ever called the helpline? Kim, raise your hand, Kim. Kim. I know. Some of you have called the helpline at 4 a.m. Okay, so I know because I took the call. How many people here have volunteered at an event for SRNA or for PHA or Guthy-Jackson as a PAC member? Okay, and how many people are volunteering to run support groups? So thankful for the leadership in the support groups. Some people here have done the Hear My Voice Story series. Anyone else that would like to is welcome. Yes, yeah, Danny did one when we were doing vignettes. We do have more adaptability videos coming out later this year. So if you have a tool or trick or tip that you want to share in that series, reach out to us. But Mo has done that. And I don't know if anyone else in the room has done that one. Oh, Gigi, that was my favorite one. I love that one. The cat, you got to watch that one. And then, has anyone signed up for a Medic Alert bracelet? Okay. Does everyone know about the Medic Alert bracelets? It's a great program. So we can sign you up to have a medical alert ID, a bracelet, or a necklace. It includes the ID and the subscription, and you get 2 little cards that you can give your caregiver so they can help remember all of the medications you take and all the things you need to know when you go to the hospital. So there's more, but these things are incredibly impactful, and we're so proud of all of the work that the whole community is doing. Yeah.
We talked a lot about the PAC. I'm not sure everybody in this room knows what it stands for.
Oh, the PAC stands for Patient Advocacy Council. So that's the group of volunteers that we have at PHA now. It's a lot of the same members that were with us before. We did transition pretty smooth and seamlessly from Guthy-Jackson to PHA. It's the same team, and we're really proud to continue supporting the community and all of these programs. I just thought maybe we should finish with thoughts on what you learned today. Did you find out about a program you didn't know, or something that you want to participate in?
I actually enjoyed hearing Dr. Chitnis speak. I was only diagnosed in 2020, but I've had symptoms for a long time, and I've had 3 pregnancies, and each of them have had complications. And learning that, you know, pregnancy can be more difficult with NMO, and hearing some of the things that she said kind of piqued my interest and leads me to believe even more that I may have had NMO a lot longer than, you know, I thought. So hearing that, and then also hearing the correlation with menopause and NMO also. So that was very interesting to learn about as well.
Oh, it's very good. Anything new?
I had not heard about the CAR T. Oh
Right?
gosh, that is such an interesting study. I mean, I've been around, I look like often at, you know, different studies that come out, and I honestly think this one's really, really fascinating. I was super interested, so I'm trying to learn more about it now because I think I could be eligible.
Yeah?
Yeah, that's so cool.
Very cool.
Me is Dr. Greenberg, and this is a little Q&A session afterwards. Always enjoy the Ask the Docs section and enjoy his.
And getting a direct answer to something you needed to hear, so.
As direct as we can get with my fun.
Holly?
You know, all of this science stuff really goes right over my head.
Oh.
But I sat there in awe of all of you doctors and the work and the amazing things that you do and the knowledge that you have. And I'm very, very grateful for all that you do.
Oh, that's an excellent ending. Thank you so much. All right, well, we're going to exit the stage and let Kim give us a closing reflection for the day. Thank you so much for being here. Thank you to the panel.
Good. All right, Travis. All righty. Yes, you did. I need the podium. No. Let's get Jesus. Are you able to lift the podium? Scoot back some more. I'm good. Yep. I think I'm okay.
So we've come here today. Good afternoon. As we close today, and today's NMOSD Patient Day here in Charlotte, I want to begin with being grateful. And that was one thing that everybody said. So grateful that we're all here. Thank you to every doctor, every patient, every caregiver, every industry partner that are represented here tonight. Your presence made this day more than a program on a schedule. You made it a gathering of strength, honesty, learning, and hope. Today was created for individuals and families living with NMOSD, MOGAD, and rare disease. Throughout this day, we have seen what is possible when people come together, not only to share information, but also to share understanding. We have felt the truth of this year's message from Patient Health Alliance, rooted in connection, building support and community. That theme is not just a slogan, it is a reminder that connection is powerful. Connection helps people feel seen. We've heard it all today. Connection turns isolation into community. And connection can help transform uncertainty into courage. Together, today, we also accomplished something important. With the collective help of everyone in this room, we met our goal of empowering patients and caregivers with knowledge so that they can pursue better health outcomes, so we can. Knowledge matters. It helps people ask stronger questions, make more informed decisions, recognize symptoms early, understand treatment options more clearly, and advocate for themselves and for the people they love. Knowledge does not erase the challenges of rare disease, but it can lighten the burden and help families move forward with greater confidence. To the doctors and healthcare professionals who joined us today, some had to leave, thank you for sharing your expertise with compassion and clarity. Thank you for listening, for teaching, and for standing with this community. Your knowledge is vital, but so is your willingness to meet people where they are. That combination of science and humanity is deeply meaningful to patients and caregivers navigating complicated and often overwhelming journeys. To the patients, thank you for your courage, your openness, and your willingness to show up for yourselves and for one another. To the caregivers and families, thank you for the countless visible and invisible ways you support the people you love. You care, advocacy, persistence, and your care, advocacy, and persistence and sacrifice are woven into every step of this journey. And to our moderators and industry partners, thank you for helping make conversations like these possible and for supporting education, dialogue, and access in meaningful ways. If there's one feeling I hope each person carries home today, it is this: you're not alone. There is strength in this community. There is wisdom and shared experience. There is hope in being connected to people who understand in their questions, the setbacks, the victories, and the determination it takes to keep moving forward. Community does not remove every hardship, but it reminds us that we do not have to face hardship by ourselves. So, as we leave Charlotte today, let us carry the Spirit with us. Let us stay rooted in connection. Let us keep building support and community through connection. Let us continue asking questions, sharing resources, opening doors and making space for every voice in this, with this rare disease or in this rare disease community. And let us remember that when knowledge is shared, when compassion is practiced, and when people come together with purpose, better outcomes become more possible. Thank you again for being here, for bringing your experiences, your expertise, and your hearts into this space. Thank you for helping make today meaningful. May you leave encouraged, informed, and reminded that this community is strong, growing, and deeply connected. Safe travels, and thank you for being part of this day. Thank you.
Thank you, Kim. That was amazing. I know the agenda says that Gigi and I are supposed to adjourn the meeting, but we just talked and we're like, I don't know, we can't follow that. So, but I do want to say thank you all for coming, as Kim said, and this has been an amazing day. And we're going to get ready for our group photo now. So, as we've done every year, we're going to line some chairs up. Everyone, these first two tables are here, I think. We'll see what the photographer wants to do. We'll have to move back, but thank you again, and we'll get all set up. Oh, at first we're going to probably do all the patients first, and then patients and caregivers, so and doctors and everyone. So, thank you.